मैं कौन सा कौन है?
कंट्रोल करेंगे कर देंगे।
तो ये कीबोर्ड से कंट्रोल कर। अच्छा माउस यू नीड दिस।
नहीं माउस इधर नहीं हो पाएगा इस साइड। और जैसे ये बोल रहा है तो इधर से कंट्रोल करना।
नहीं नहीं, हमें सीवी डिस्प्ले करनी रहेगी। आप बताते जाइए, मैं
नहीं ये तो मैं देख बटन पढ़ पाऊंगी नहीं पढ़ पाऊंगी।
ये कौन सी देखिए ये फाइनल वाले का? नहीं नहीं, इसको इसको बंद कर दीजिए।
फाइनल
डेस्कटॉप वाले ये फाइनल। हाँ
पता है वो वहां लेके कर।
हाँ, और दूसरी वाली दूसरा वाला जो वो अभी डिस्प्ले में था। कीबोर्ड से अगर हमें शिफ्ट करना हो तो विंडो विंडो डी कर लेंगे आप, या एल टैप कर दीजिए चाहे जैसे कर ऑल तो टैब जो चाहिए आपको ऐसे एल ऑल टैब जो आपको चाहिए।
फुल टैप।
हाँ जैसे जो चाहिए। देखो दोनों खुले हुए हैं, ठीक है।
हाँ
बाकी मैं तो रहूंगा एक साथ ऐसे नहीं पकड़ के आपको ऐसे एंड और टैब, ये आपको टैब के साथ इसका मूवमेंट करना है।
ऑल दबे रहना।
रुको आई विल जस्ट बटन दबाए रखना है ना।
बंद हो गया बंद हो गया।
क्लोज नहीं करना सर, आप क्लोज कर देंगे फिर से कैंसिल कर।
कैंसिल करिए उसको वैसे ही रहने दीजिए।
आप मेरे को बताइए आपको चाहिए क्या?
मुझे चाहिए जब ये बोलेंगे देखिए जब ये स्टार्टिंग में
हाँ
सर्च आने के पहले ये बोलेंगे
ठीक है
तो वो तीन वाला जो स्लाइड वाला है वो हम
ठीक है
डिस्प्ले करेंगे।
ठीक है
जब सेशन में चालू करेंगे तो हमें टीवी डिस्प्ले करनी
कोई
है।
दिक्कत नहीं।
मुझे दिखा है ऐसे यहाँ पे इधर आ जाओ। नहीं
नहीं ये लीजिए आप ओके।
इधर हो जाएगा। ठीक है यही 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 इतना काफी है। हाँ ठीक है ठीक है ये तो हमारा हो जाएगा। अब हो जाएगा। ठीक है
बस ठीक है।
आप देख
हेलो हेलो। ठीक है सर स्टार्ट कर दिया। ये तो जूम खोल के चले गए। A very warm good morning to all the delegates, faculty members, distinguished guests who have joined us today. We welcome you all to this enlightening CME focused on gastrointestinal and gynecological pathology, organized by the Department of Pathology SGPGIMS. We, Dr. Rahul and Dr. Akansha, residents of Department of Pathology SGPGI, we take this pleasure in welcoming you all here. This day has been thoughtfully curated to blend clinical relevance with pathological brilliance. We are honored to host renowned experts from across the globe, uniting academic minds and diagnostic excellence under one roof. We are honored to have a galaxy of eminent speakers here with us today from leading institutions of India and across the world, including USA and Hong Kong. We began our day by celebrating young academic minds through poster presentations, which have been actively participated by the postgraduate students and the delegates, and these posters have been displayed on the first floor of this building. Now, to begin with the first session, we would like to invite our chairpersons for this session. We welcome Professor Narendra Krishnani, former professor, Department of Pathology, SGPGI. And, And Professor Rakesh Agarwal, Professor and Head of Department of Gastroenterology, SGPGI, for this first session. For this first session, we shall be exploring the art and challenges of endoscopic ultrasound-guided biopsies and diagnostic approach to inflammatory gastric disorders. We now request the chairpersons to kindly introduce our speaker.
Good morning, ladies and gentlemen. On behalf of Professor Krishnani and myself, I welcome you to this session, this first session. And our first speaker today, we have two speakers. One is a clinician and the other is a pathologist who are going to look at how biopsies work in gastrointestinal diseases. So our first speaker is my colleague here at Department of Gastroenterology at SGPGI, Professor Sameer Mohindra, and he's going to talk about the art and challenges of endoscopic ultrasound guided biopsies. Dr. Sameer, please.
Good morning. I want to thank Department of Pathology, Dr. Manoj Jain, Dr. Vinita, Dr. Neha, and the whole department for giving me a chance to be here. I've been asked to speak on a very important topic, which is important both for gastroenterologists as well as pathologists. That is EUS guided endoscopic ultrasound guided tissue acquisition. There has been rapid advancement in this field, and now we get very good specimen quality with very favorable adverse events. And this is becoming a part of standard of care in various GI diseases. Now, if you look at the history of EUS guided tissue acquisition, it started with in 1980 when DiMaggio attached an ultrasound transducer in an endoscope and used it as an ultrasound with endoscopy. Then the first tissue acquisition was done by Peter Willman in 1992 when he took FNA from a pancreatic SOL in a human being. And since then, we have come a long way. Now we are looking at next generation sequencing, complete genomic profiling, molecular analysis. We are looking at going into the tissue and taking biopsy, for example, in pancreatic cyst and so on. So there has been tremendous improvement in the technology, which has helped us in advancing in this field and acquiring tissue with the help of endoscopic ultrasound. Now, tissue is the issue everywhere. Now, when we talk about tissue acquisition, it can be a fine needle aspiration where we see cluster of cells, or we take a core biopsy. But now it's not only proving whether it's cancer or no cancer. Now we are going beyond. Now we are looking at what type of cancer it is. We need to prognosticate the cancer of the patient, and we need to make a strategy for the treatment, which is protocol-based medicine, so as to give the maximum benefit to these patients. So we are advancing in that area also. Now, in 1992, when we started, Peter Willman, we had only the concept of cytology. We put in a needle and take cells. There was always concern of complication because our experience was limited, and we didn't have any idea what we are doing because we are going out of the GI lumen and the adjoining tissue. We had only one FNA needle, which was 22G needle, and one technique, going in, coming out, traditional biopsy. But now in 2025, we have advanced to an era where we get cytology, where we get core tissue, we get tissue for ancillary tests. Complication rates are minimal. We have become more experienced. We have better diagnostic armamentarium. We monitor these patients better. We have got variety of needle of different shapes and sizes, and there are various techniques how to puncture the lesion, how to procure the specimen, and how to process the specimen. In last 1 decade, from conventional FNA, we are going towards tissue biopsy. That is because with the help of core needles, where we get the core of the tissue, because we feel that bigger the tissue is, better is the diagnostic yield. It reduces the number of passes. There may not be need for on-site pathologist. And of course, we get bigger tissue. Now, this slide basically shows the trend. The blue graph shows that EUS guided tissue acquisition. Red is percutaneous and green is surgical. You see the trend. EUS guided tissue acquisition is becoming more and more popular. And if you look at the cost, this is the Western data, Mediclaim data from US for pancreatic SOLs, cost is much less as compared to percutaneous and surgical biopsies. The same thing shown, number of passes have reduced from when they use FNB vis-a-vis FNA. And if you look at the diagnostic yield, it's better with FNB. It's a data of more than 3,000 patients, predominantly pancreatic masses. Now, why it is happening? There are certain limitations of FNAs because you need to assess the specimen which you take on table. So we need an on-site pathologist to make sure that adequate tissue has been procured. You don't want to repeat the procedure again and again. And we get only the cluster of cells. We don't get the architecture. We don't get the stroma. We don't get the whole picture of the tissue which we get. And these are the advantages of FNB. We get a larger specimen, better diagnostic yield. We can look at the tissue architecture. We can perform ancillary tests and may not need an on-site pathologist, though it is a little controversial and we need fewer passes. There's a long list of EUS guided tissue acquisition, which we commonly do, but the commonest ones are pancreatic masses, both solid as well as cystic, lymphadenopathy, both mediastinal and even abdominal, focal, solid liver SOL, subepithelial lesions, thickening of bowel wall anywhere where we are not able to make a diagnosis. Liver biopsies coming up is a very important technique with the help of EUS guided. And there are, on the right side, there are relatively less common indications. Now, I want you to see this slide very carefully, that all lesions don't need to be biopsied. For example, if there is a pancreatic SOL, now there are definite indications where we need to put in our endoscope and take biopsy. For example, if there is a suspicion of a medically treatable disease, for example, autoimmune pancreatitis, lymphomas, you think that in the background of chronic pancreatitis, there's an inflammatory mass, or in our country, tuberculosis. So these are tissues which don't need surgery. There we need to take the tissue and make a diagnosis. Atypical feature, it's not very clear, it's chronic pancreatitis with inflammatory mass or a pancreatic ductal adenocarcinoma. If patient has to undergo neoadjuvant therapy or ATT, we need to take tissue for culture and gene expert to make sure for the resistance profile. And of course, in a protocol-based era, we need to get tissue so as to decide which strategy for treatment is better. Similar for subepithelial lesions, where EUS appearance is not typical, we take tissue. Where we want to characterize the lesion, for example, gastrointestinal stromal tumors, schwannoma, where we need to do immunohistochemistry, and if the lesion is more than 2 centimeters and which can alter the treatment. But the bottom line is, if it alters the treatment, then definitely we need to take tissue. It is like any other method of tissue procurement. There are challenges. It's a very useful, easy technique, but there are definitely challenges in this technique. There are technical challenges, interpretation challenges, complications, and logistic factors. For example, needle access. Every lesion may not be accessible. For example, uncinate process mass, difficult to access. A lesion very close to the duodenum in the pancreatic head, sometimes become very difficult to position the needle. Sampling errors. We think we have taken adequate tissue, but the tissue is not adequate. It's too bloody. It is hypocellular. Imaging is not good because of various artifacts. We are not able to position the endoscope and we are not able to get a right tissue. Interpreting the samples which we get. And of course, device malfunction like in any other technique. Interpretation challenges, false positive. For example, there is a suspicion of autoimmune pancreatitis versus pancreatic ductal adenocarcinoma. We may not be able to differentiate between the two. There's always a possibility. False negative. We take adequate tissue, but still there's a possibility that it may not be representative of the tissue which we want to take. Difficult lesions, I've already mentioned. Hypocellular, for example, intense desmoplastic lesions. For example, GIST. We may not be able to get adequate tissue. But all these complications were more, all these problems are more common with FNAs. With FNB, it has become relatively less common. Then, of course, complication rate is less than 2%, mortality is less than 0.1%, but they are always there. We have to take care of it. Bleeding, infection, pancreatitis, perforation, needle track seeding, and device malfunctions. We need to be very careful. For example, in a pancreatic cystic lesion, if we are puncturing a cyst, we are taking a biopsy, there's always a high risk of pancreatitis, bleed, and introduction of infection. And of course, we need to look at the cost effectiveness, what we are doing. If we are able to do it at a relatively lower cost, it's always better. Whether it's accessible or not, every patient may not have an access to a EUS guided procedure. And patient selection is very important. For example, patient is on anticoagulants, antiplatelet drugs, patient is having severe coagulopathy, then it becomes difficult to do these procedures safely. Now, the aim is to get a sample which is adequately cellular, adequate quantity, and minimally bloody. So these are broad concepts. Basically, it's a trade-off between cellularity and accuracy. Now, variables that affect the tissue acquisition outcome are what kind of needle we are using. We are using a FN needle or a FNB needle. What size of needle we are using, 25, 19, 22, and so on. Number of passes we make, 1, 2, 3, 4. Puncture technique, not what we are trying to do is now we are trying to do different techniques so as to get better tissue by moving the scope from left to right or up or down. Competency, training, and volume, which the endosonographer and pathologist has. It's a very important thing. There's a learning curve, both for endosonographer as well as pathologists, which decide that what kind of diagnostic we'll have. Once we collect the sample, what are the specimen collection method? When we are taking out the sample, whether we have applied suction or not, it's a dry suction, wet suction, slow pull technique, and so on. Once we get the sample, on-site evaluation, whether it can be on-site cytological evaluation, macroscopic evaluation, stereomicroscopic evaluation, and so on. Then once we get the tissue, we get a cytology, whether smear-based cytology is good enough, or we need to take liquid-based cytology, histology, whether we want to take cell blocks, or core is good enough. When we do EUS guided procedure, esophagus is the easiest side because the scope is straight. Duodenum is the most difficult because it's an angulated scope. This is a needle which we use. It's a hollow needle. There's a stellate. We remove the stellate and apply the suction syringe and do the procedure. Different needles have come up. They are mentioned by generation. Initially, it was two-cut needle. Now we have very good third-generation needles, which are excellent in efficacy. This basically shows 4 needle on the left-hand side, traditional needle, what we get in the venous set. It's a hollow bevel needle, standard bevel needle, which are used for FNA. On the right side, 5, 6, and 7 are the FNB needles, which have different modification of the tips. The concept is either we can cut the tissue at a side cut, which is the needle which we have with the shock core, where we grate the cheese. That's how the specimen comes out. End cutting needle, which are basically Francine needle or fork tip needle, where we puncture, the whole core comes out inside the needle. There are different advancements for needle as to make them more visible and more flexible. For example, nitinol needle is very flexible. And we try to improve the enhancement of the tip because we need to visualize the tip when we do the procedure. These are 3 commonly used needle as of now for FNBs. Now, if you look at the results, there's a data 2016 series where they did the FNB and FNA for predominantly pancreatic lesion and non-pancreatic solid lesions. If you look at the diagnostic yield, there was not much of a difference between pancreatic lesions, between FNA and FNB. But if you look at the non-pancreatic lesion, diagnostic yield was much better with FNB, and specimen adequacy was much better with FNB. And cost was less with FNB because on-site pathologist cost was added. But this is the Western data, not Indian data. If you look at FNA versus FNB, FNB outscores in basically solid pancreatic lesions with better histological lead and cancer diagnosis. I've compiled the list of FNA versus FNB in solid pancreatic lesions. What we have to realize in solid pancreatic lesion, FNA is almost as good as FNB for diagnostic accuracy. But if you look at the quality of specimen, histology specimen, basically what you are doing is by FNB, you're getting a larger tissue. And when you get a larger tissue, you do ancillary test. But there is no difference in diagnostic accuracy between FN and FNB for pancreatic SOLs. That's very important, especially when you have an on-site pathologist. For lymph nodes, we use 22 and 25 gauge needle, FNA or FNB. We can use either. There's not much of a difference. For subepithelial lesions, FNB outscores FNA in majority of the series. But what recent data is coming, if you have got a good on-site pathologist, if you don't have FNB facility or because the FNB needles are more expensive, that FNA with on-site pathologist is as good as FNB for subepithelial lesions. It's very important to understand because we have to look at cost effectiveness also. FNB needle is twice the cost.
Silence, please. Thank you.
So when we look at different type of needles, the latest needle, Francine and fork tip, are much better than the second generation needles. Go through this. Now, so is the obituary written for FNA? My answer is no. There is a place for FNA. For example, if you can't stop anticoagulants, patient has got severe coagulopathy, difficult position. There are small lesion, difficult to puncture with the FNB needle. When you have to go through we are forced to go through a blood vessel where FNA needle will cause less bleeding. 19G needle, when we puncture the pancreatic cyst and aspirate fluid or take different needle through it. Then if it's a small pancreatic cyst, we use 22G needle. So as of now, FNA and FNB are complementary. You can't say that FNA is going to be phased out. It has got a role to play. Stellate versus non-stellate is basically what we do is we put a stellate and puncture it. The concept is to not unclog the tip of the needle. but it doesn't help. It's more time consuming. It's more chances of needle risk injury. Now we don't use stimulate. Suction is very important because suction gives you a negative pressure, whether we use a dry suction, wet suction, heparinized suction, or simply low-grade suction with a stellate pull. We pull the stellate so as to give a low-grade suction. We don't apply suction if it's a very vascular lesion and in lymph node as a first pass because it makes it more bloody. Wet suction is coming up in a big way, and especially in the context of liver biopsy. Studies have shown that if you use a wet suction, what we do in wet suction, we prime the needle with saline and heparin, and it basically decreases the bloodiness and fragmentation of the tissue. So wet heparin or wet suction has got a role to play in EUS-guided liver biopsy. Some data is coming for solid pancreatic lesion also, but as of now, the best data is on EUS-guided liver biopsy. Slow pull, it's a very good technique, especially when you are bothered about bloodiness. So you don't want to apply suction, whether dry or wet. You simply put a low-grade suction in the form of stellate pull-up, and chances of bloodiness of the sample is much lower. This is very useful when you're puncturing the lymph nodes and when you're using a vascular solid pancreatic lesion and other solid lesions. Again, I told you blood contamination is what more common, but sample adequacy is similar between the two. Now, there is a recent study which basically looked at pancreatic SOLs and the non-pancreatic SOLs, and they did wet suction versus slow pull technique and crossover trial. And what it basically showed, there was slight improvement with wet suction method as compared to slow pull through method, but data is still not adequate. We can use slow pull through technique or we can use wet suction. Now, coming to different techniques which as endosomnographer we use, what we do is we try to do maneuvers during the puncture so as to get a better diagnostic yield. This is a fanning technique. What you do is you puncture the lesion, don't come out of the lesion, with up and down movement of our scope, we make it left and right and try to get different part of the tissue and so as to increase the diagnostic yield. Data, first study by Shyam Vardalaju, which showed that less number of passes are needed if you do this fanning technique. And this is the standard of care now because different studies have shown that number of passes decrease and diagnostic yield is slightly better with this technique. There are another technique that is torque technique, which I have not mentioned, that you simply move your body left and right and try to go in different directions. And one more technique, door knock technique. We do a rapid sudden jerk with the needle so as to cause more fragmentation of the tissue, but limited data on it, but I'm not included. Number of passes, again, it is evolving. Traditionally, when we do FNA without rows, 4 to 5 passes. If we have rows, 3 to 4 passes. If you're doing FNB, 2 passes are good enough in majority of the cases. And studies have shown that. Rapid on-site evaluation, very useful modality where we get the pathology colleague with us who tells us whether we have done an adequate tissue acquisition or not. Because approximately 20 to 30% of FNAs are non-representative. So we don't want to do the procedure again. Our pathologist colleague can easily tell us after staining the slide whether the tissue is adequate or not. It gives you the real-time feedback. It reduces the number of passes. It reduces the procedure time because you don't have to do it again. And more importantly, if you're not getting tissue with FNA, you can switch to FNB. So that can also help. So it's a very useful modality to have, though I know it is difficult to get the pathologist every time we are doing these procedures. But if we get it, it's a bonus. And data has shown that it is good. Now, if we look at biopsy, FNB with or without rows, it doesn't make any difference. So if you are doing FNBs, then the requirement of pathologist comes down because studies have shown that if we have visual impression of the tissue, then rows may not be needed. But I would say that rows is needed in the initial part of your training, where specimen adequacy is less than 90%, and low volume centers, because you need to have more experience looking at slide, look at your technique, and look at whether you have got adequate tissue or not. I would recommend that when we are starting this procedure, it's always better to have pathologists by your side so as to get this is another concept, macroscopic visible core. What we do is we take out the sample and as endoscopists try to see whether we got adequate tissue or not. The whitish tissue or a yellowish tissue is the tissue, and the rest of the blood is the blood clot. And studies have shown that if you get a core of 4 millimeter or more, it is very useful, representative of an adequate sample. With or without Mohs, if you look at it, study has shown that Mohs is as good as tissue acquisition with rows. So data is coming that if you're taking biopsy, Mohs works for endoscopist. There's data between rows and Mohs, Indian data, Shyam Sridhar's group from Tata Memorial. They said basically diagnostic yield for solid pancreatic lesion is very good if we have Mohs. If you follow the Mohs protocol, it works. Visual on-site evaluation, very similar concept. It's basically you put the specimen in a formalin jar and you try to grade it. It depends upon the size, it depends upon the color, it depends upon the bloodiness. And red mixed, where there is a white and there's a red, diagnostic yield is much higher. This is just a visual evaluation of the tissue which we get. Stereo microscope on-site evaluation. Again, our pathologist colleague come to picture. They see the sample in the stereo microscope and tell us that whether it's good enough or not. Though few endoscopy centers, endoscopists have started doing it, but it's very limited data on it. This is how it looks like. We get white and red. We align the white tissue on one side. This is the representative tissue and send the sample to the pathologist. US guided liver biopsy, very much in vogue. It is slowly coming up as a very important modality. It's a real-time evaluation. We can look at small solid lesions. We can do bilobar biopsies. It's safe. And if you're doing endoscopy for other indication, we can do it. And if you want to target other organs, for example, pancreatic ductal adenocarcinoma suspected with liver as well, we can target both the pancreatic as well as the liver as well. So this is how we do it. It's almost as good as percutaneous, but I would say that percutaneous liver biopsy is a standard of care as of now. Increasing number of liver biopsies are being done by US guided procedure, but I think it's a very good procedure if done safely. Pancreatic cystic lesion, very important area where we puncture the pancreatic cyst and take out the fluid. Even if there is a mural nodule or a solid component, we take tissue also. This is a forceps which we use. It's a very useful modality. Diagnostic yield is around 70 to 80%. Problem is complications. Complication as high as 11%. That's a problem with this. So it has got a limitation, but diagnostic yield is very good if it is done properly, especially in cases where we cannot differentiate different type of pancreatic cyst. Now, in today's era, we have come towards personalized medicine, where we are looking at next generation sequencing for complete genomic profiling. We are looking at microRNA analysis. We are trying to create organoids. So what is the best way of procuring tissue? For this indication, FNB is better and preferably with a wide needle, that is 19G needle. And studies have shown that the specimen is as good as surgical specimen for doing these ancillary advanced tests. Now, once we get a negative result on a FNA or FNB, what should we do? Should we abandon the procedure or go for percutaneous? This Italian data has shown that we can make one more attempt, and 2 attempts, the diagnostic yield increases to 94%. So if 2 attempts are made, it works in majority of the cases. So this is my last slide. It basically, which technique we should use, it depends upon the patient factor. It depends upon the institute factor. It depends upon the lesion factor. For example, if I have got a very good pathologist who can come to me, if I have got a Rose facility, if I've got a pancreatic pathologist who's the expert, FNA is as good as FNB for pancreatic SOS. Now, if you are suspecting a mass in the context of chronic pancreatitis, then FNB is the answer. If you're looking at the characterization of a cancer, then FNB is the answer because you want to do ancillary test. If it's a very small lesion, we can do FN or FNB. Difficult site, we can use a FNA needle or a thinner FNB needle because maneuverability becomes easier. If we are looking at autoimmune pancreatitis, lymphoma, neuroendocrine tumors, tuberculosis, then FNB is the answer because we want to characterize the tissue. And simply proving that it's one or the other is not good enough. So when Dr. Vita gave me this talk, there were certain questions which I wanted to answer. Are we giving appropriate tissue for cytology or histology? Are we giving non-fragmented tissue? Is the specimen bloody or not, which makes life of pathologist difficult? Is there any tissue that the gut, when we puncture the tissue or take out the tissue, the gut contaminant is there, which makes life difficult for the pathologist? And is our post-tissue acquisition processing adequate or not? So I think it basically needs a close cooperation between the endoscopist and the pathologist for tissue acquisition. We need to tell the clinical details. We need to tell the technical details, how we have done the procedure, what was the characterization of the lesion which we took the tissue from, and how did we process in the lab before sending the patient. Then only the adequacy will be adequate. Thank you.
Thank you, Dr. Samir, for a very extensive and detailed information. I'm sure there are questions in the audience. Yeah, sure, Dr. Vinita.
over the years, we have seen that the efficiency and amount of tissue that we are getting for biopsy from these lesions has substantially improved over time. Do you think it is because the needles or because of the expertise or the learning curve that has made this different? That is the first question. The second question is, as compared to what it is not proven data, but as my perception is, over the years, it seems that the biopsy codes are getting better and better. As compared to that, the finding aspirates have improved, but not to that extent as we get for the biopsy. That is
Second question first. See, that's the problem with Rose. See, that's why Rose comes into picture. See, Rose is an asset in FNA. See, the tissue which you get on a slide, we are not able to see it. We are not able to interpret whether it's cellular or not. So therefore, Rose is a very big advantage for FNAs. And because the quality of FNA will be limited because you have got a thinner needle, you are taking aspirates. You can't improve it, you simply puncture it and aspirate. So the FNA, that's why Rose plays a very important role in FNAs. Regarding the core, we have got better needles. Our technique has become better. We have become better in targeting which part of the lesion we need to puncture. And then when we get the tissue on in the jar, then we have also become experienced that it's bloody or non-bloody. So that's why we were making sure, for example, if we get one pass, good tissue, good white core, we need not do it. If first pass, second pass, it's all red, and we know it's not adequate tissue, we'll go for the third pass. It's basically a learning curve, better technique, better equipment. All three are playing a role. All three.
So, as you said that biopsies are very good and it is to be done. The point is that not all the lesions are straight. So difficult to reach to the lesion. So there are flexible needles. So I just want to know that what kind of flexible needles are we using? Is it costly? And how much angle it can turn? Flexible needles.
See, I never said FNA has got a role to play. If you ask me, if we are not looking at core tissue, if we don't need core tissue for the indication for which we are doing, FNA needles are very good. They are much cheaper, much easier to do. We can always do smear as well as liquid-based cytology. You can even take a cell block. So FNA needles are very good. We have got very good flexible FNB needles also from Expect needle from Boston Scientific, which improve the maneuverability because it is made up of nitinol. The previous needle were made of cobalt chromium. So we can 30 to 50 degree, we can easily make it. But it depends upon the position of the scope. It depends upon what angle needle is moving, how much needle we can come out, how deep is the lesion. So there's a lot of variability that how much we can do. But what we need to do is we need to get the lesion at 5 to 7 o'clock in the endoscopic view. That is a straighter access to the lesion. That is the trick. But FNA has got a tremendous role to play. I know data says that FNB is the answer, but I don't agree with it. For specific indication, FNB should be done. For being cost effective, I think FNA has got a role to play, and especially when the cytologist, the pathologist is by your side.
So are we using nitinol?
We use basically cobalt chromium needle, that is acquired needle for biopsies. But in positions which are difficult, for example, Encinate process, we use 19G flexible needle, which comes with the name of Acquire Ultra. So that is more flexible FNB needle, which is because it is made of nitinol. But sometimes it becomes difficult. So what I would do, don't get bothered. Take a good FNA. Take a good FNA, get the pathologist, you make a cell block. Most of the time it will work.
Dr. Manoj.
In sales checking, what do you do first, FNAC or FNAP?
Very interesting. Data show we do only FNA versus FNB. But data is coming up if you do both. It is much better. But then it is more expensive. You need to use 2 needles. It is more time consuming. And of course, I mean, if you're getting with one technique, why do 2? But there's limited data which show that FNA and FNB combined together has slightly better. But with these FNB needle, diagnostic yield is more than 90%. So 90 to 95, I would not ask the patient to get another needle, which is very expensive. I mean, unless the tissue is not adequate, and then we need to, for example, if FNA doesn't work, FNA turns out to be negative, the next turn I'll do FNB. But that is in a very small subset of patients, but that should not be a regular protocol.
Based on the US finding or tentative diagnosis.
Pardon?
FNAB versus FNAC. based on your what material you is good in tumors or?
No, for example, if you have autoimmune pancreatitis, if you have neuroendocrine tumor, if you want to subtype lymphomas, if we are suspecting tuberculosis, if we are thinking of non-resectable pancreatic ductal adenoCA, or even resectable where surgeon wants to give a neoadjuvant therapy, so they will need core tissue. So these are the indications. For example, GIST or schwannomas, where it's basically now you need to look at tissue characteristic and decide what therapy you want to give. So there we need to do FNB.
Yes.
It's a very good thing. See, there is a known harmonic contrast ultrasound based biopsy. There's some data that you use a tissue harmonic or a contrast harmonic, then you can differentiate between viable and non-viable tissue, and you target those viable tissue. But data is very controversial. It doesn't go one way. So we don't use contrast harmonic based EUS guided biopsies. But your question is basically what you mean to ask is that if I do FNA, it turns out to be negative, and I'm going with the FNB, should I target the same tissue or the same area? We try to target different tissue parts of the tissue. Whether we are doing FNA or FNB, we try to completely cover the lesion by different techniques, fanning technique, top technique, or sudden rapid movement. What we try to do is we go left and right with a body movement, or with up and down movement. We try to, for example, if it's a circular lesion, we start at 7 o'clock, we come at 6 o'clock, we go at 5 o'clock, we try to go at 3 o'clock, withdraw the needle, go at 9 o'clock, try to go at 3 o'clock, and then while coming out, go at 12 o'clock. I mean, different movements. But it's not that we take from one place. We anyway target different parts of a tissue. We try to take non-necrotic areas predominantly to get the diagnostic.
Okay, thank you, Dr. Mahindra. That was a very nice talk and even better interaction. Thank you.
So thank you, Dr. Samir. So now going to the next lecture on diagnostic approach to inflammatory gastric disorders. So I'm inviting Dr. Rupa Rachel Paulos. She is professor at Amrita Institute of Medical Sciences and Research Center, Kochi, Kerala. And her achievements are lead GIN pancreatic pathology and head the GIN pancreatic pathology division and course organizer for 2 years fellowship in GI and liver pathology. Honorary consultant, small bowel transplant pathology at Birmingham Children's Hospital, UK, and sabbatical in GI oncopathology, National Cancer Center, Tokyo, 2012. Now her publications are in several, and there are many research projects are ongoing, and she has co-authored chapter in standard pathology textbooks. And her area of interest is GI and pancreatic pathology. So I know that she has a vast experience in GI and hepatic pathology. So taking the gastric lesions first, inflammatory, I hope that we are going to get a lot of information in gastric inflammatory pathology. Over to you, Dr. Rupa.
At the outset, I would like to thank Dr. Manoj, Dr. Neha, for having me over. It is really an honor to be here in the city of Dubai, and I'm coming all the way from Kerala, Kochi. So it is an honor to be here. Thank you. So as sir has just mentioned, so my aim here in the next 40 minutes or so is to talk about how do we, as pathologists, how do we approach gastric biopsies, particularly in the context of gastritis. So gastritis, as we all know, is inflammation of the gastric mucosa, and which should be histologically confirmed. Many a times these patients are asymptomatic, and endoscopic biopsies may not be telling us much.
So really, who are these patients who would have these endoscopic upper GI endoscopic biopsies? Essentially now, they don't necessarily have to have too many symptoms. Even a vague abdominal pain is sufficient to have the scope down. And what we have found is that, honestly, I know I've got the gastroenterologist here, but there is not too much of a correlation between what they see as gastritis and what we see as gastritis. But nevertheless, gastric biopsies still continue to be a bulk of our department's workload. And at this point, I just want to encourage every pathologist to have this very close, a relationship with the gastroenterologist, because it's extremely important to have that cooperation between both the pathologist and the gastroenterologist in order to make sure that we are effectively managing the patients. So what can we expect from clinicians? Again, I'm aware of the gastroenterologist here, clinical history. And many times we would like to know if the patients are on PPI or on non-steroidals. We are seeing changes, but we haven't got that information. We'd like to know the endoscopic biopsy findings. Many a time it's erythema, edema, but no more than that. But it would be nice to see whether there was thinning of the mucosa. And Sydney protocol is what is recommended. I will come to that in a bit towards in the talk. And ideally, we should be having biopsies from different sites. That's two from the body, and two from the antrum, and one from the gastric fistula, all labeled in different cassettes, or sorry, in different containers. So really, we would like the antrum and the fistula coming together as one, if that is okay, and the fundus, the body biopsy coming together as in another bottle. And for sure, if there are other additional findings, then that should be biopsied as well. So let's look at, there's a good place to start. What's normal? So many a times, when I have the residents next to me, I'll ask them, so where is this biopsy from? And they will look at me and say, stomach. But then, stomach is different, and it's important, different part, and it's important to know what's what in each part of the stomach. So whenever you see these specialized cells, that's the chief cells and the parietal cells, what we are thinking about is the oxyntic region, which can be the fundus or the body. So the chief cells are these basophilic cells, and they are important for pepsinogen 1 and gastric lipase secretion. Whereas these very pink cells, or the eosinophilic cells, the eosinophilic granular cells, they are the oxyntic cells, and they are responsible for the intrinsic factor production and the antral, that's the HCl. Coming to the antral fragment, antral area, we don't have the specialized glands, but rather we have a lot of mucus secreting glands, and they are rich in pepsinogen 2. And additionally, there are also the neuroendocrine G cells. I forgot to mention that there are the ECL cells in the oxyntic region. So these are the basic differences that one should be aware of. So here I am going to give you a very practical approach on how to make the diagnosis of gastritis. And it is a pattern-based approach. I've tried to include cases as well, so I really would like a little bit of interaction also. So topography. This is very important. Like I was telling you, I would ask the residents, where is the biopsy from? So where's the biopsy from? So they would look and tell me, there is no point in saying gastric mucosa, because I need to know where it is from. Even irrespective of whether the pathologist, the endoscopic has told me that this is body biopsy or it's an antral biopsy, one should be absolutely clear whether you're looking at the body or whether you're looking at the antrum, because there are certain pathologies which is antral dominant and those which are corpus dominant. It's extremely important to understand them, the difference, because that helps you to ascertain the etiology. So let's start with the most common, which is the chronic gastritis. So normally you will see some mononuclear cells, maybe about 5 lymphocytes, plasma cells per high pass field. And then sometimes you may see them even between the foveolae. So you really need to go into a higher power to just make sure that you're looking at, especially when it's very subtle, to ensure that there is a mild increase in chronic inflammatory cells. So once you've understood that there is mild chronic inflammation, then it's very important to just say whether this is mild, moderate, or severe. Try and categorize it as best as possible. And just a word of caution, try and grade it away from those lymphoid follicles that one might often encounter. So you're trying to say whether what sort of this is a gastritis at first, and then try to quantify it as best. Now, it's another way to look at it is that is it top heavy or is it bottom heavy? Now, these are clues to a diagnosis. If you're seeing it as top heavy, then that certainly helps to understand what the etiology is. Whereas if you're looking at bottom heavy, which means it is really long-standing, that again helps to approves towards a certain diagnosis. So this is a good way to start. So one, you look at the biopsy and think, are there features of chronic gastritis? I've just told you how to make that understanding. Then the next thing to look is, are there neutrophils? If so, how much? Is there Helicobacter? Now this is mandatory. Every gastric biopsy should have a word to say whether Helicobacter is present or not. Then following that, you look to see whether there's glandular atrophy, is there intestinal metaplasia? And then following that, understand where the biopsy is from, the site of the biopsy, because this topography is very important. Is it involving the antrum or the corpus, or is it involving both? Is it a pangastritis? Additionally, look for other features. Don't just stop there. Look to see whether there is, and are there any histiocytic aggregates? Is there any foveolar hyperplasia, any viral intrusions, anything else that might, is there any foreign material, anything else should not be missed. And then use ancillary tests appropriately and then understand how to make the interpretation of those ancillary tests. So we'll start with the first case. Here, this is a 45-year-old who had presented with dyspepsia, bloating, and the upper GI endoscopy was done, which showed erythema and erythema, and it was there both in the antrum and body, and the biopsies were taken. They did not really have any further opinion on that. This is what we got. Any thoughts? I think from even at this power, you would say, and even from such a distance, you will say, it certainly looks a little bit more blue, isn't it? So that blue should alert us to the fact that there is a mild increase in inflammatory cells. So and then I think additionally, you can see that there are some small lymphoid aggregates as well. And then this is yet another power, another view to show us that there are these lymphoid aggregates also. So is there chronic gastritis? Probably, yes, isn't it? Not probably, there is. Now, I just don't stop at the, from a distance, go look into the higher power. And here you will find that there is also, in addition to the chronic inflammatory cells that we can see here, there are neutrophils. So that implies activity. So it's very important to say whether this activity is mild, moderate, or severe. So you will look for activity, that is the neutrophils in the lamina propria, within the crypts as what we can see here. And then if there's any within the lumen also, which are the crypt abscesses. So always quantify the activity. And then additionally, if you went back to that first image, you would have seen that these are actually two sites. Here we've got some specialized glands. So that means this is the body or the corpus or fundus. And here we've got no specialized glands, suggesting that this is the antrum. So this tells me that we've got an inflammation that is affecting both. And further on, there were some focal areas which also showed intestinal metaplasia. And also there was thinning of the mucosa, which suggested that there could have been a little bit of atrophy. On higher power, I'm not sure whether this is clear. There were a few Helicobacter-like organisms also. So biopsy site, we understood it was both antrum and body. Well, so is there chronic gastritis? Yes. Was it mild, moderate, or severe? Moderate, at least. Were there neutrophils? Yes. Was it mild, moderate, or severe? Moderate, maybe. Was there Helicobacter? Yes, you have to believe me on that one. So glandular atrophy? Yes, there was. And intestinal metaplasia? Yes. Was there dysplasia? No. Malignancy? Did you see anything else? No. Do we need any special test? What would you need? But you saw the Helicobacter, or I saw the Helicobacter. Okay, you can do GIMSA, and that can just confirm. So really, this was a chronic active pangastritis with mild atrophy. There was focal intestinal metaplasia. It was H. pylori associated. Now let's come back to the history. See, you are the only person who could have told the clinician that this was H. pylori associated chronic active gastritis. This is all that they told us, that there was erythema, and that's why they took some biopsy. So I just want you to emphasize your important role in this multidisciplinary team, how you contribute towards patient care. You don't get much, but you can give out a lot more. So as we all know, this was a landmark paper that was that had come back, and which clearly has taken a long way from 1984 to where we are now, where H. pylori is a type 1 carcinogen. So H. pylori, you will on the GMSA, this was the same case, by the way, and here there were a few Helicobacter-like organisms. So this is a H. pylori, which they are seen as small curved, curvilinear spiral organisms, and occasionally you might see them as small coccoid forms also. So they do have, I don't have time to go into how the special adaptive mechanism is, but then there is the surface mucus and there is the bicarbonate, which keeps the epithelial integrity. Now, H. pylori comes and it has its way of surviving in that very acidic environment, but nevertheless, and in addition, it disrupts that very friendly or that protective environment that the mucosa is used to. So that's how the H. pylori creates the inflammation or perpetuates the inflammation from moving from a chronic to chronic active, and then it progresses to ulcerations, atrophy, and intestinal metaplasia, dysplasia, malignancy. So somebody might ask me, should I say there is one, there is two, there is plenty, there's dense colonization? What do you think? Is one good enough? Is one H. pylori good enough? Yes. Okay, so there is no need for you to say how much, but probably it would be relevant in the context of epidemiological studies. I must admit that when I see dense colonization, I just get a bit excited and I say there is dense colonization in the report. Now, there are non-invasive diagnostic tests like the CLO, the urea breath test, there's a fecal antigen test, and also serology can be used, but they are not entirely sensitive. So H. pylori, as we have already said, it's chronic active. Try and grade it. Topography is important, and look always look for the complications, which is the atrophy and the intestinal metaplasia, because they do increase the risk for gastric malignancy. Now, when I talk about gastric malignancy, is it just carcinoma? No, it's also the lymphoma. So what do you think this is? Does this look like the H. pylori that we saw? Why? It's a little more longer and it's more spiral, isn't it? So this is Helicobacter helminthi. So it's special stains, GMSA can be used, Geminus can be used, and IHCs can be used. So do we need to do it in all? Not when it's obviously there, but certainly when you've got that milieu is there. It looks severe, it looks chronic, if there is activity, but you are not seeing H. pylori. You just know it's got to be there, but you're not seeing it, then for sure you must do a special stains. Or if there's extensive metaplasia, you're not going to see the H. pylori, you must do the special stains. Or if there is in the context of follow-up biopsies where you might not see H. pylori, you must do the ancillary tests. Now, what if you saw H. pylori versus helminthi? The treatment is the same. Of course, H. helminthi is much more rarer. Now, coming to this, now when you use, I just want to just emphasize that you've got a case like this. This is a recent case where there was severe chronic active gastritis. It was H. pylori associated, but also very focally, there was this focus of dysplasia. So always look for other additional features also. Don't just stop with just having given one diagnosis. So coming to other infectious gastritis, there is, if you saw granulomas, for sure, you must think of tuberculosis, syphilis, depending on the clinical context also, histoplasmosis, fungi, etc. We'll just quickly move to the next case. This was a 69-year-old who was known to have a low-grade non-Hodgkin's and with bone marrow involvement post-chemotherapy. And she then recently presented with a low-grade fever, yellowish sputum, increased frequency of stools, no abdominal pain or vomiting. But nevertheless, she had an upper and a lower GI endoscopy. And what they had found was extensive erosion, patchy, not extensive, extensive meaning it was there, patchily, erosions, and maybe some superficial ulcerations. So this was a gastric biopsy. What do you think? Increased LP cellularity? Maybe. This was a higher power. There are lots of eosinophils for sure. There are some plasma cells and then a few neutrophils. So we look at mild chronic, maybe a little active also. So there's mild chronic, there's a few neutrophils. H. pylori was not seen. We didn't see any atrophy or IM, and there was no dysplasia. Additionally, do you see anything? some viral inclusion such as this. And then also it was interesting to see that there were many glandular lumina which had these small dots. Any thoughts? So a GIMSA was done. And these GIMSA did not highlight any Helicobacter, but rather highlighted these basophilic bodies, which is a cryptosporidium. So here we had chronic active gastritis, but in this case, there was co-infection of both CMV as well as cryptosporidiosis. So again, the use of ancillary tests, it's not always just to look for Helicobacter. It can help you for other pathogens also. Coming to the next case, this is a 35-year-old who had undergone a renal transplantation in 2018. Last year, this time, she had a varicella infection, and then she was doing okay up until the end of last year when she had worsening of her renal functions. A renal biopsy was done in November, and that had shown acute tubular injury, but there was no morphological evidence of active rejection. In December last year, she continued to have severe anemia. Peripheral smear showed microcytic hypochromic anemia. And then she was referred to AIIMS Kochi because of her worsening graft function. And on admission, she was found to have jaundice, deranged LFTs, viral panel was negative. And then because of the abdominal pain, and then she went on to developing dysphagia, she underwent an upper GI endoscopy. They saw a few erosions. So this is what we had seen. So when you look at this biopsy, there doesn't seem like there's a lot of inflammation, isn't it? Maybe at the most mild. And maybe the occasional neutrophils were also there. There was no atrophy, but there were these inclusions for sure. And these inclusions very much suggesting that this was the IHC that was done for CMV. Again, there were not that many, but you must make sure that you don't miss it because it was important in this, for treatment. So this patient went on to having a fecal biopsy after this because she just did not do well. A fecal biopsy done a couple of days later found that she had a large proliferative mass, and on biopsy, we found that it was a post-transplant lymphoproliferative disorder. Unfortunately, she expired a week later. So I just want you to know that we as pathologists do actually stand at a pivotal site. Now, we could not have afforded to miss that CMV that was there, but again, there were other features that had to be addressed also. So coming to CMV gastritis, common in the immunocompromised and also occasionally in children. Now, very important, endoscopically, it may be normal or it may be frank ulceration. Now, where do you look for it? You must look for these viral inclusions in the stromal cells, endothelial cells, and also occasionally they could be in the epithelial cells. They can be, you may not see much inflammation like what we had just seen in our case, or it could be just severe active gastritis. They may be accompanied by numerous eosinophils also. So that's CMV gastritis. So I hope by now you have seen we've moved beyond Helicobacter to occasional other pathogens also, and the use of ancillary tests like GIMSA, which can be useful in other scenarios. Coming to the next case, this is a 48-year-old who had a liver transplant. Autoimmune etiology was thought as the underlying cause. And she was okay up until the 15th day when she developed hematemesis and melena. So in view of the hematemesis, she had an upper GI endoscopy, which showed a 5-centimeter gastric ulcer and which had the stigmata of a recent bleed, and that was in the lesser curvature. She was given pantoprazole and also ganciclovir because of possible CMV. But she had hematemesis, continued to have. And this time a repeat endoscopy showed that the ulcer has enlarged, and therefore biopsy was taken from that ulcer base. This is what we saw. So here there's no chronic, it's just ulceration, just frank ulcers. And within that ulcer, just frank ulceration, just a lot of purulent inflammatory debris, a lot of acute tissue destruction. And there were these very broad, thin-walled aseptate hyphae, which is the mucor. So this was gastric mucormycosis. So by the time I told them that this was gastric mucormycosis, she had another massive bleed. It was necessitating intubation. And then an emergency endoscopy was, was performed to try and somehow control this arterial bleed. but unfortunately, she succumbed. So this was to show other pathogens also, and especially in the context of post transplant. So this was actually a case from a series that we had published. And what I can say is that the diagnosis is usually delayed due to non-specific symptoms, and early endoscopy is endoscopy with biopsy is the key to diagnosis. And these endoscopic features can mimic ischemic injuries. There could be ulceration, which are sharply demarcated, associated with necrosis, thrombosis of the adjacent vasculature, and you may have this black estrus. So, but nevertheless, you are the only person who can give out the diagnosis as a pathologist. So, which PCR can also be done, which can add to the diagnostic yield. So I'll move on to the next part of my talk. In between, you can see a little bit of Kochi also. So coming to non-infectious gastritis. So this is a 10-year-old who had atopic eczema. She was diagnosed to have UC about 6 years ago, and now she presented with rectal bleeding. She was having really very bad symptoms for at least 4 to 6 times a day with blood, crampy abdominal pain. Appetite was okay, and she had come to us for further management. So colonoscopy, our pediatric gastroenterologist told me that this was just severe bad pancreatitis, as you would expect in a flare of UC, and the upper GI endoscopy was normal. So this is the, I'm not showing the colonoscopy biopsies, but this is what we saw on these were the normal looking biopsies that we had received. So I'm sure on low power, nothing much to see, isn't it? You can see that they are both specialized, non-specialized. So he usually takes from different sites. But then on higher power, there were, in children, you can see these lymphoid aggregates, but there was a subtle increase in the chronic inflammatory cells. Mild, of course, the threshold should be much higher when it comes to children, but there was a very subtle increase in the chronic inflammatory cells. And then there were these sort of aggregates like this also, which showed that around certain crypts that there were some lymphocytes, histiocytes, maybe the occasional neutrophils here, and almost maybe destroying a crypt, and maybe 1 or 2 histiocytes coming through there. And then for just having seen that much, that prompted us to take further deeper levels, and that revealed that there were definite areas of histiocytic aggregates such as this, and such as this, and such as this, almost suggesting that these are multiple ill-formed granulomas. So this was maybe another area where the crypt is surrounded by some lymphocytes, histiocytes, and there were the occasional neutrophils there. And here you've got a few histiocytic aggregates, selective collections there. So what are we looking at? So here we've got deposited inflammation at best mild, isn't it? Neutrophils, maybe just focal. There was no helicobacter, there was no atrophy or IM. And the topography, yes, it was antrum, but there was a little bit in the body also. For sure, we saw something else, isn't it? There were these focally enhanced gastritis, and there were ill-formed granulomas. Do you need to do any special stains? Yes, you must do a GIMSA, just to make sure that you have not missed a helicobacter. So what are we looking at? Here was a child, a 10-year-old, who was labeled to have UC, but the upper GI endoscopy, which was completely normal, has actually suggested that probably this is not UC, but probably this is Crohn's disease. And that was because of the concomitant inflammation in the upper GI biopsies and the presence of the ill-formed granulomas. So Crohn's associated gastritis, usually you don't see much inflammation, or there could be just very patchy acute inflammation with pititis or abscesses. Focally enhanced gastritis, for those who are not familiar with it, it's actually a small collection of lymphocytes and histiocytes that's around or associated with the foveolae and the glands, and often with you might see a few neutrophils also. But in severe cases, you can have a severe chronic inflammation. You might see a few epithelioid histiocytes. So any such appearances should prompt you to take some further deeper levels, and that can reveal some small ill-formed granulomas, which is a clue to the diagnosis. Now, granulomas can be infectious, not infectious, which we have already discussed, or I have just mentioned, but non-infectious sarcoid is the other thing to also keep in mind, foreign material also. So moving to the next part, which is the gastropathies. Now, gastropathy is when you do not have, when you do not have a lot of inflammation, but there are other changes which suggest that there is a pathology in the gastric biopsies. So gastropathies are drug-related, drug-induced, or alcohol or radiation. That's the reactive gastropathy. You can have the reflux, which is the bile acid reflux gastropathy, or the chemical, the non-steroidal gastropathy. So how do we understand this? So when you look at these biopsies, they, at a distance, they don't seem to have a lot of inflammation. I mean, they don't look blue. But what actually helps us to understand is this very characteristic corkscrewing that you see of the fovula. So really, there are 4 points to this. So you see the foveolar hyperplasia, and that's because of this chemical noxae, which increases the turnover of the gastric epithelium, and that's what causes this very marked foveolar hyperplasia. Mild is not, you should see a good corkscrewing before you consider them. And then there's usually numerous congested capillaries, and that's because of the pro-inflammatory cytokines. There's edema of the lamina propria, usually a paucity of inflammatory cells or very mild, minimal chronic inflammatory cells. And also there would be a mild thickening of the muscularis mucosae. Often you will see these vertically splayed smooth muscle fibers. So these are the features of chronic gastropathy. They're usually asymptomatic, but they can be ulcerated also. Another very common entity that we see, or a finding that we see, is that many of these parietal cells are quietly mildly dilated, and they can have apical snouting. And so you would comment that there is parietal cell hypertrophy, and often associated with PPI therapy-related changes. So let's look at another case. Here, this was way back in 2022. This patient, a 60-year-old male, presented to us with abdominal pain, which is poorly localized, and heartburn, abdominal bloating, constipation. And this was the upper GI endoscopy. So here, they saw that the fundus was normal, body had some erythema, antrum also showed some streaks of erythema, pylorus was normal, D2 was normal. So biopsy was taken from the body and antrum, and essentially erythema, nothing more than that. So this is what we have seen here. Have a good look. So just keep in mind the same approach, chronic inflammation. Do you think there is? For sure, isn't it? Okay, so keep this in mind. There is definitely an increase in chronic inflammation. Now, before we start about chronic inflammation, the site of the biopsy, specialized or non-specialized? We are not seeing any specialized cells here. Okay, so that's something to just keep in mind. So always a good place to start topography. Okay, and then additionally, you're seeing there is chronic inflammation. We've got some lymphoid aggregates. Maybe this falls into the bottom heavy because we're not seeing so much of them on top, but rather it's more towards the bottom. We are not seeing any specialized glands. There is, if you look, the mucosa is quite thinned out, and there are patchy areas of intestinal metaplasia. Now, this was actually, in addition to that, you can see that there is an increase in chronic inflammatory cells. There are no specialized glands, although this was labeled as body. Here, this again emphasizes that, that there is atrophy. And that is again to show the same. So chronic gastritis, yes, this was at least moderate. Were there neutrophils? Didn't see. Okay, so it's just still chronic. There was no H. pylori. There was atrophy. There was intestinal metaplasia, no dysplasia or malignancy. So this is what we had got. So this was gastric body, but there was no parietal cell. And therefore, one has to consider that this is antralization of the gastric body. There was no Helicobacter, chronic atrophic gastritis with intestinal metaplasia, antralization of the gastric body, autoimmune gastritis is definitely considered. Antrum was normal. So I just want to I had shown this picture earlier, all the findings that we had seen, but additionally, there were these nests such as this, which I think you can clearly see here, a few more in here. But if I were to go back, if you notice, there are some small nests such as this in here coming down. So therefore, a synaptophysin was done, which highlights that there is a ECL cell hyperplasia also. So as you can see, we've got both linear as well as nodular ECL cell hyperplasia. So because we had raised the possibility of autoimmune gastritis, labs, they had tested the serology and found that IF was positive, antiparietal cell antibody was also positive, serum gastrin was very high, vitamin B12 was low, and therefore all confirming that this is autoimmune gastritis with pernicious anemia. Now remember, what was the endoscopic findings? I am completely aware that we have gastroenterologists here, but remember the endoscopic findings did not tell us too much. But we understood it from our end here. Patient was started on vitamin B12 correction, and then subsequently chromogranin levels were also found to be high. So autoimmune gastritis is relatively rare. Clinical signs include hypo or achlorhydria, hypergastrinemia, and that's because we have destruction of the parietal cells, and therefore there's a reflux reaction to cause hypergastrinemia. There's low pepsinogen, pepsinogen 1, pepsinogen 2 ratio, B12 is deficient. The antiparietal cell antibodies and IF antibodies are present, and often it coexists with other autoimmune diseases. Now, there is this molecular mimicry with H. pylori. The H. pylori antigen and the hydrogen potassium ATPase antigen. So the T cells recognize, the T cells of one recognize the other, and that's why H. pylori can give a similar picture as an autoimmune gastritis. The progression to adenocarcinoma is also high, and as we have seen, there's also a progression to carcinoid tumors. So autoimmune gastritis in early stages might be difficult to pick up, but certainly in a stage such as ours, where there was diffuse lymphoplasmacytic infiltrate, it was bottom heavy, there was atrophy, there was increased thickness of the foveolar component, pseudopyloric metaplasia, that's the antralization of the gastric body, and increasing intestinal metaplasia, all are sufficient to call this as autoimmune gastritis, and therefore you should ask for the serology. End stage such as this, where there's marked destruction, you cannot recognize this as being corpus. There's marked foveolar hyperplasia, and there's extensive pseudopyloric metaplasia, pancreatic metaplasia, intestinal metaplasia, and all of this suggests that this is end stage. And I think that on the endoscopy, you will see very thin mucosa with the vessels being seen clearly. So a few words on this enterochromatin cell hyperplasia. And as I had suggested, it's achlorhydria. There's no acid, so that prompts the G cells to secrete excess gastrin, which leads to the histamine producing ECL cell hyperplasia. So you can do IHC as in this case, and we can see that they could be linear hyperplasia, a nodular hyperplasia, adenomatoid hyperplasia, and occasionally there is this concept of calling them as dysplasia. So pseudopyloric metaplasia versus antral glands. This is extremely important, especially if the biopsy site is not confirmed. So how do we do that? Because you see, you're trying to give a diagnosis of autoimmune gastritis, saying that these are the changes that one is seeing in the body. Now, provided you are sure that you're not looking at an antral biopsy. So IHC gastrin can help because it suggests that this is that is antrum, and it is not body. So if the gastrin is positive, then you're looking at antral mucosa, and therefore it is unlikely to be AIG. Also, the pseudopyloric glands, they secrete pepsinogen 1 and 2, which will be seen in the corpus, and they have enterochromatin cells, whereas the antral glands only secrete pepsinogen 1. So with that, we'll move on to a few special types of gastritis. There's eosinophilic gastritis, which clearly suggests that there's a high incidence of where there's dense eosinophils. You will see them in the lamina propria within the crypts degranulation, and the number and the distribution is important. More than 30 per high power field is suggested, and you would put out this diagnosis provided that there is no H. pylori or Crohn's disease or anything else. Here, this is another case of celiac disease, where, as you can see, on this part, there's mild chronic inflammation, but there was this is a CD3 shows an increase in the T cells, suggesting that this was lymphocytic gastritis, commonly seen with H. pylori and in celiac disease, but occasionally can be seen with Menetrius disease. Collagenous gastritis is also well described. GVHD are not common only in the transplant setting, but look out for these crypt apoptotic bodies, which is a clue to the diagnosis. So we'll come to the next part, which is the staging, Olga and Olgam. I think people are becoming more and more aware of it. And this was a staging standard that's developed from the Sydney system. So when we look at this, so two things to remember, atrophy and intestinal metaplasia.
Dr. Paul, we are near the end of time.
Yeah, I'm also coming to the end. So Olga and Olgim this is a standard biopsy protocol where you have to take biopsies from the antrum as well as the body. And you have a scoring system, and stage three and four, it gives us the risk for gastric cancer. Similarly, there's the Olgim, intestinal metaplasia. Both of them can be used. So just a few words on the ancillary tests that can be used, which helps to give us the diagnosis. And this was a recent, we had developed an AI tool to detect H. pylori. And I think this would be useful for especially the young novice pathologists who may not be familiar with the very few H. pylori that may be present in the biopsy. So to summarize, it's good to have a pattern-based approach. You should grade the degree of inflammation. Always comment on H. pylori. Look out for the IM and atrophy. Use the Olgim if possible. Identify the topography. Identify any special types, ancillary tests as and when needed. So to conclude, we as pathologists is very relevant in that multidisciplinary team, so much so that even if you were to come for a conference such as this, they will miss you. So just to let you know, we have a 2-year fellowship at Amrita in GI and liver pathology, and welcome to Kochi whenever you get a chance to come and visit us. Thank you.
Thank you, Dr. Rupa, for giving us detailed spectrum of inflammatory disorders of the gastric biopsies. And especially, I would like to thank that you have covered almost all the things related to inflammatory gastric disorders. But one thing, it is a small question. It's very difficult to identify a small atrophic. So just give us the detail in detail that how to identify the atrophic glands, which really we miss in general. And with that, I would ask the audience to ask 1 or 2 questions because the time is less, because we have to go for another session. So any question from the audience? Yeah, please. Doctor. Yes, Dr. Haq, please. Yes.
So H. pylori is gram negative. So you could use the gram negative, and on the gene side, you will see these tiny small cocoid forms, which would help you to identify. So one, it's gram negative. When you see these cocobacilli, you are going to think of could they be gram positive, gram negative. So they're gram negative, and then these are the small cocoid forms that you would look for. And then coming to the question of atrophy, it is a very good question, sir. Atrophy is when you always in a biopsy, you must say this is gastric mucosa with muscularis mucosae or without muscularis. Now, when muscularis mucosae is present, that tells all of us that we are looking at a good adequate biopsy. So you would be able to identify the thickness of the biopsy or the normal, the glandular component within that biopsy, because it is completely represented. Now, if you've got a mucosa without muscularis mucosae, one cannot comment on that. Whereas if you've got mucosa with muscularis mucosae, I'm looking at the density of the gland. And if that density is certainly far less than what I should expect at that point, that would suggest atrophy. And that is the way one should immediately alert the clinician, there is my atrophy. Of course, by all standards, we should have the Sydney protocols to help us to grade that atrophy between the pocket and the antrum. But this is on a general note, this is the way to assess.
Any other question from the house?
Yeah. So top heavy is when you have got a lot of inflammation just confined to the top layer. So which suggests it's not that chronic. It is more, maybe it's more acute, maybe it's a little bit more, it's just early chronic, as opposed to to the bottom heavy, which suggests it has been there for a substantial amount of time, so that you are having the inflammatory cells that's settling towards the bottom, and you would expect to see additional changes like mild atrophy also. So a bottom heavy should immediately alert you to the fact that this is not just a mild chronic gastritis, but or rather this is far more long-standing than what one should expect. So that is the difference between bottom heavy and top heavy.
Thank you, Professor Paulos. We'll have to stop it here. After the inauguration, there'll be a tea break. We'll encourage you to ask your questions there, because I'm sure there are many questions, but we must go on. So this is the IPL season. We have had a good first wicket stand, and I'm sure the whole meeting is going to be very nice. Thank you to both the speakers, and thank you to the audience. Bye.
Thank you, chairpersons and speakers, for such an enlightening session.
बताऊंगी तब कर दूंगा अभी नहीं अभी रहने दो। अच्छा
बस चेक कर दूँ और ठीक है, यही प्ले करना है, बस आपको प्ले करना है। ठीक है, ये मैं मिनिमाइज है, यहाँ पे जाके प्ले करना है। हाँ, बोलने का फोकस का टेबल पर अरेंज हो रहा है, ये क्लियर वृंदावन है, पीयूष ने डाला। पूछ के आऊँ तो मैम से जाके स्टार्ट कर देना जब तैयार हो जाए, जैसे ही फिर मैं तुम्हें बता दूँ। also request
but we also like to request international guests.
the month of the one for पूरा पढ़ना kindly join for the inaugural ceremony। जब भी वो आए, मान लीजिए लैब लाइटिंग के टाइम आ रही है,
बंद कराना पड़ेगा, मुंह पे लगेगा तो कैसे प्ले होगा?
क्या बंद कराना पड़ेगा?
प्रोजेक्टर
प्ले तो इसमें हो रहा है, प्रोजेक्टर बंद करने से प्ले बंद थोड़ी है, प्ले तो वॉइस में हो रहा है, बैकग्राउंड में प्ले होता है।
स्टार्ट कर
After these enlightening talks, we shall now begin with the inaugural ceremony. Now we take this opportunity to start with the inaugural ceremony. We take this opportunity to invite our esteemed guest, Professor Radhakrishnan Dhiman sir, Director, SGPGIMS, to come on the dais, sir. We would like to now invite Professor Shalin Kumar sir, Dean, SGPGIMS, to come on the dais, sir. Next, we would like to call upon Professor Manoj Jain, sir, Head and Professor, Department of Pathology, to come on dais, sir. We would like to invite Dr. Vinita Agarwal, ma'am, Professor and Joint Organizing Chairperson, Department of Pathology, to come on dais. And lastly, we would like to invite Dr. Neha Nigam, ma'am, Additional Professor and Joint Secretary, Department of Pathology, to come on the dais, ma'am. Now we request Dr. Rupali and Dr. Mahima to welcome our guest. Dr. Jyoti, Dr. Mahima, please welcome our guest. Professor Radhakrishnan Dhiman, sir, we welcome you, sir. And I would like to welcome Professor Shalin Kumar, sir.
Thank you very much.
Professor Manoj Jain, sir, we welcome you, sir. Professor Vinita Agarwal, ma'am. We like to welcome you, ma'am, on the dais. Dr. Neha Nigam, ma'am. We welcome you, ma'am. Our Department of Pathology is highly obliged by the presence of our senior faculties and stalwarts of the pathology. To express our gratitude, we would like to welcome Professor Naren Krishnani, sir. We would like to welcome Dr. Madhumati Goyal, ma'am. We'd like to welcome Dr. Madhumati Goyal, ma'am. And we also like to welcome Professor P.K. Agarwal, ma'am. Thank you so much, ma'am and sir. We would also like to welcome Dr. Nuzhat Hassan, ma'am. And lastly, we would also like to welcome Dr. Haq. Please welcome Dr. Haq. All good things start with a prayer and a small hope for success. Therefore, we now invoke the blessing of Goddess Saraswati and request the dignitaries to light the lamp. Please, sir and ma'am, kindly come.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा
We would also like to welcome Dr. Mamta Gupta, ma'am, and Dr. Amitabh Shrivastava, sir, also one of our emeritus Alumni, Dr. Mamta Gupta ma'am, she is international coordinator, consultant pathologist with Israel Deaconess Medical Center, USA, to come on the dais. And also Amitabh Srivastav, sir, who is a consultant pathologist at Memorial Sloan Kettering Cancer Center. Please join us in the lighting of the lamp, Sarin ma'am.
हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां
We would like to welcome Dr. Amitabh Srivastav, sir, and Dr. Mamta Gupta ma'am to this inaugural ceremony. We welcome you, sir. We welcome you, ma'am. Now we take this opportunity to invite Professor Manoj Jain, sir, Head and Professor of the Department of Pathology, to welcome the gathering, sir. We like to welcome Professor Manoj Jain, sir. Please kindly welcome the gathering, sir.
Good morning, everyone. So, respected Dr. R.K. Dhiman, sir, Director SGPGI, Dr. Salin Kumar, Dean SGPGI, respected all seniors and teacher present here, my colleagues and dear delegates. On behalf of Department of Pathology, it is our pleasure to welcome you all in this international CME on updates in gastrointestinal and gynecological pathology being organized by the Department of Pathology, SGPGIMS. This 2 days CME will be focusing on recent updates on GI and gynecological pathology. We are grateful to our alumnus, Dr. Mamta Gupta, for accepting our invitation as international coordinator for the CME. She is currently consultant at TIS Hospital, New York, and specializes in gynecological pathology. We are also grateful to our alumnus, Dr. Amitabh Srivastav, for accepting our invitation for this CME. Dr. Amitabh Srivastav is Director, GI Pathology Fellowship Program, Memorial Sloan Kettering Cancer Center, New York. We are thankful to both of them. They are paying back to alma mater by sharing their time, expertise, and knowledge with us, and also coordinating with 4 eminent international speakers who will be online to share their knowledge in the ever-growing field of gastrointestinal pathology and gynecological pathology. Yesterday, we had a workshop on GI and gynecological pathology in the department with interesting cases, viewing, presentation, and discussions. Dr. Amitabh and Dr. Mamta both interacted with participants and department members, and we are really grateful to both of them. I'm sure for the next 2 days, we all will be enriching ourselves with enlightening talks and panel discussions, insightful presentations, and meet the expert presentations. Around 40 faculty members and around 140 participants, delegate and participants are participating in this CME, and 37 abstracts has been accepted and they are being presented as a poster and oral presentation this CME. This CME brings together leading experts, researchers, clinicians to share cutting-edge research, innovative diagnostic techniques, and recent developments in the field. We look forward to you all in engaging discussions, insightful presentations, and meaningful collaborations that will improve diagnostic skill and patient outcomes. We encourage you to take full advantage of this opportunity to connect with peers, exchange ideas, and explore new frontiers in gastrointestinal and gynecological pathology. As you know, Lucknow is a beautiful city with Lucknowi Tehzeeb and blend of old heritage and modernization. Recent lot of development is occurring in the Lucknow. So our SGPIM is in forefront in the field of gastrointestinal and gynecological pathology with dedicated specialty department. And this institute boasts 550-acre lush green campus with huge infrastructure facility. So when you get time, visit our campus and explore the city. So I welcome you all again in this meeting. We are thankful you all are being part of this CME. Thank you.
Thank you so much, sir. Next, we would like to invite Professor Vinita Agarwal, ma'am, to introduce the CME. Please come, ma'am, on the podium.
Good morning, everybody. We are pleased to welcome you to this continuing medical education program and to our institute. I would like to express my sincere gratitude to our director, Professor Radhakrishnan Dhiman, and Dean, Professor Shaleen Kumar, for gracing the occasion with their presence. This CME, as Dr. Manoj Jain has already told, we began yesterday with academic activities with the pre-CME workshop. We had various cases which were displayed, and we had postgraduates from Lucknow and around Lucknow. And I think it was an intriguing experience for all of them. And it was really good for Dr. Amitabh and Dr. Mamta to have interacted. And the CME brings together esteemed national and international faculty who are experts in the field of gastrointestinal and gynec pathology. A special thanks to Dr. Amitabh and Dr. Mamta Gupta, who are our distinguished alumni, for visiting us, and also for the close coordination with the international faculty for joining us virtually. Today's CME will focus on gastrointestinal pathology, while tomorrow will be dedicated to gynae pathology. Like many other areas in pathology, recent advancements in both fields have been driven by molecular diagnostics and integrated genomic profiling. And these developments are significantly enhancing the diagnostic accuracy and shaping the targeted therapeutic approaches. I think the pathologists are becoming more and more important by the passing day. And our CME will spotlight these advances through a combination of didactic lectures, panel discussions, and meet the expert sessions. The sessions and discussions are basically aimed to be interdisciplinary. So we have people both from the clinical and the pathologists. For proper patient management, there has to be a close coordination. We are also hosting an oral and poster presentations in the first and the second floor. So I will request all of you to kindly go to the first floor for the poster sessions. They will be displayed there on the boards. And this is, despite the relatively short notice, we have a lot of registrations, and we're very happy to welcome you all. We sincerely hope that the CME fosters a deep understanding and appreciation of these specialties in pathology. And once again, I extend a warm welcome to all of you, and thank you for joining us here in SGPGI. Thank you so much.
Thank you so much, ma'am, for introducing the CME. Now, we take the privilege to invite Dr. Radhakrishnan Dhiman, Director, SGPJIMS, to address the gathering. So please come on the podium.
Thank you. Good morning. And I will begin with मुस्कुराइए कि आप लखनऊ में हैं. This is the city which is famous for najakat, nafasat, and tehzeeb. You have been welcomed by at least 2 persons also. Once again, I welcome you, everyone over here. Whether it is the international faculty, national faculty, or the delegates. On the dais, Professor Shaleen Kumar, our Dean, Professor Manoj, Head of the Department, Dr. Amitabh Srivastava, our alumnus, Dr. Mamta Gupta, Professor Vinita Agarwal, Neha Nigam, and I can see my colleagues in the audience also, ladies and gentlemen. First of all, I would like to congratulate Professor Manoj Jain for organizing an update on gastrointestinal and gynecological pathology. That means that you are focusing in the pathology to some areas. And I tell you that I am also a gastroenterologist to begin with. And later on, I have become the hepatologist primarily. Still, I have the interest into gastrointestinal diseases. But I am looking at it The liver is missing in it anyway, no issue. Conducting updates, I think it is one of the very important thing. At least for the reason that you know what is happening as of now in these fields. You cannot cover all of the pathology, but as rightly done, you can begin with few things also, like here, gastrointestinal, as well as the gynecological. It is specifically useful for the delegates, for the students that they are coming over here. They need the extensive exposure in their field, that is the pathology, that what is happening over here. I was listening to the previous lecture over here. Madam is sitting over here from the Cochin. We will definitely come to the Cochin, such a beautiful city actually. I have been to there for several times. Also the AIMS also. So the nitty-gritties, small things that she was talking about, I think you will not get into the books also. That kind of the exposure from the stalwarts, I would say, or the doyen of the pathologies over here, that is at most important and should be done. I would encourage Dr. Manoj Kumar as well as Dr. Vinita Agrawal that these kind of the activities should be done every quarterly. At least should be you should be organizing in a very simple way every 3 to 4 months. I think the students are very happy to hear it. And you have to make concerted efforts that it should be done in your department. That would elevate the ranking of your department also across nationally as well as the international. Number two, about the department. This is the department. When I was a student over here, I think many of you don't know that I was the first batch student of this institute. I was doing the DM in gastroenterology. And at that time, head of the department, Gupta ji the, and Pandey Saab, the many more over here. So my exposure to this department, or I know this department since I joined this institute over here. And I can see the progress happened in last 3 to 4 decades over here. In that sense, I would like to suggest few things also. That we must not forget, this institute is a super specialty institute. The first institute in the country where they say that we will not do the medicine, we will not do the surgery, we will not do the gynecology, but we will do the cardiology, nephrology, urology, neurosurgery, and like that. And similar the PhD. But the DM in pathology is missing. I think we have to think, we have to sit together. All the faculty of the pathology sit together. What is happening actually? Why it had not started? The only thing I would like to say, whenever you are looking at your department also, look other departments also. Don't forget to look at the pathology at the PGI and the pathology at the AIMS also. They are running the super specialty courses. I think हमारा एक मंथन जरूर होना चाहिए, ब्रेन स्ट्रॉमिंग जरूर होनी चाहिए कि हमारे पास ये क्यों नहीं. To begin with, we have only 4 seats of the MD over here. We have faculty of 12 or 13 over here, but the number of the seats have not increased since then. They still remain the 4. I think this is something, as a director, it is painful for me. The department should grow also. I think this is I am not here to criticize. I am here basically to promote you in every sense. I want to see the pathology department flourishing like anything over here. And I think there are only the 3 things that we have to look at. Every department of this institute, if you see the 3 pillars of the institute, patient care, teaching, and the research. And that good doesn't mean only the institute, that transcends to the department also. So each department has to look at these three components, how much they are performing each year also, and where the graph is going on. So at last, I am ready to provide any kind of the help, whether it is a moral help or it is a support from the deans to the NMC, or it is a financial also. I am ready to provide to the Department of the Pathology. What I have said, I think this is just a part actually, but I feel I am not a pathologist, but I feel I have seen the Department of the Pathology of the PGI Chandigarh, and therefore I can say that at least we should go ahead of that department. That is my wish over here. Thank you so much.
Thank you so much, sir. You are a guiding force to all of us. Now we request Dr. Shalin Kumar, Dean, SDPJIMS, to share his kind words on this inaugural ceremony.
Director Bhiman sir, colleagues from overseas, Professor Amitav and Dr. Mamta, my teachers in the audience and seniors, colleagues, ladies and gentlemen. I will be politically incorrect today. SGPGI as an organization is really blessed with multidisciplinary care, basis its structure. There is a huge opportunity here to do two things. The first is to specialize and to develop specialization and go deep. And the second is to be able to reach out to peripheral centers and in terms of both clinical care as well as really mentoring centers around us, both of which I think we have not harnessed in the last 35 years. I'm sorry if this sounds a little patronizing, but in today's day and age, you're having a CME on gastrointestinal cancers and gynae cancers and not on pathology. Why is that? There is a recognition that you need to focus and zero in. You need to narrow down. Unless you don't narrow down, you can't go deep. And then the way the path services are structured, because we are in pathology today, the way it is that everybody sees everything, there is never that, incisive. There's hardly ever that incisive report that comes forth. And it is my request and humble plea to the department faculty that please come together, go site-wise. That is the only way forward. I'm sorry, sir, Director, sir, I may be transgressing my limits, but this is the only way. This is a wake-up call for us in the institute. That's one thing. And the second thing is that there are so many peripheral medical colleges. We have RML, we have KG, we have in Lucknow, the big places, and the other hospitals. Why do we not have a consortium? Each department builds their own sort of networking and collaborate. And each department, each institute, pathology departments of each institute take on. So, okay, let's say RML does nephrology, big time. SDPGI does GI, big time. Or maybe neuro, big time. Because we've got neuro facilities, we've got GI, we've got urology, we've got many things. So the time is for specialization, and it is a request, a plea, a fervent appeal that we must be site-wise. This is the only way forward. Thank you very much.
Thank you so much, sir. Now we request Dr. Mamta Gupta, our international coordinator, to come and please address this gathering.
Good morning, everyone, and welcome to all the participants and distinguished guests and speakers and my teachers. Many of them are here in the audience, Dr. Goel, Dr. Agarwal, Dr. Nuzhat Hussain, and if I have forgotten anybody else who is in the audience and I can see from the behind the podium. So welcome to everyone, and it is my honor and privilege to be part of this two-day CME, in which I'm not only the speaker, but I'm also actually honored to be as part of the CME as an international coordinator. So for the next 2 days, I hope we have curated an enriched scientific program where we have been able to actually invite the most renowned speakers in the field of gastrointestinal and gynecological pathology. So I hope all the participants can take the advantage of it and enjoy the time here. And before we proceed, I would like to take a moment to express my deepest gratitude and for all those who have made this possible. So first and foremost, our chairperson, Dr. Manoj Jain, who has actually, I have to tell you that spark of this conference actually started just 4 months ago. And it was just on a very casual phone discussion with Dr. Jain. And then with his commitment and, unwavering support, he made this a reality in a very short period of time. So thank you, Dr. Jain. Then I would also like to express my thanks to Dr. Dheeman and the Dean, Sir Dr. Shaleen Kumar, for their support and for their presence today here in the inauguration of the CME. My sincere thanks for the entire organizing committee led by Dr. Vinita Agarwal, Dr. Neha Nigam, who were able to bring together so many national and international speakers whose expertise will undoubtedly be valuable to all of us, and I'm sure we'll learn a lot from our speakers. I also want to acknowledge the hard work of all our trainees whom I saw yesterday, and the staff members whose efforts have made this conference possible. And last but not least, thank you and welcome to all the participants, many of whom I know that have traveled from afar to be here. So I wish you all the best, and I hope you have wonderful time here and enjoy the CME and learn from it, and also enjoy the beautiful city, which is also my hometown, Lucknow. I know it's very hot, but I think you can still bear the heat to see this wonderful city. Thank you so much.
Thank you so much, ma'am. Now we request Dr. Amitav Srivastav, consultant pathologist, to come up and please address this gathering.
Thank you so much. I'm not sure what else can I say other than what has already been said, but thank you to Professor Beeman. Shaleen Bas is my senior from my schooling days here. He looked a little different then, but we go a long way back. Many of you know that this is where my personal journey and professional journey started in many ways. So it's glad to be back. I see some former mentees here, former teachers here. So it's very gratifying to do something. Manoj Boss drags me here whenever I visit home to do something very informally here in the Institute, and many of the trainees know me. But it's nice to do something. We've either done a formal virtual conference or done informal personal sessions, but never a formal personal session. So this is a first for us. As Mamta said, it takes a lot of effort to put a conference together like this. And part of the driving force for us is that we've been fortunate to learn from the best in the world and to bring some of the stalwarts in pathology currently some of whom are legends like Dr. Oliva, who you'll hear from tomorrow. And it takes a lot of commitment from the speakers and the organizers. Just to give you a quick example, Dr. Singhi, who's a close friend of mine and has done a virtual conference here before as part of the endocrine meeting some years ago. He pre-recorded a talk. He'll be live in the Meet the Experts session, but then UPMC, his institute, blocked him from sharing the recording. So he had to go back home, do it again, and then found that he went a little over limit and was 48 or 49 minutes instead of the allocated time. So he did it a third time, which is now with us. So you'll hear from him. So for us as educators and teachers, I think it's very gratifying to hear stories like that, because it shows a commitment on part of, he's not here, he doesn't know many of you, but they like to teach. So it's a drive that they want to share the information that they have gathered over the years. And I think we are fortunate to learn from people like them. And we are fortunate to be here in person, visiting our city, our family, and then also being among all of you guys, sharing whatever we can. So enjoy the 2 days. You'll hear from a lot of national experts and also the international team that we've put together. And I'm sure that you will engage us. The only request I have is be interactive, ask questions. That's the only way to learn. And yes, I echo Dr. Shaleen Kumar's comments that yes, we need to specialize and focus. But it also is important to remember that what you end up doing after specialization, the basics of the game don't change. So that you can take just the focus on specialization to a limit where it doesn't really make sense, right? So I'm a big fan of Indian classical music. So you cannot have a musician saying, I'll only sing Rag Yaman and nothing else because I'm a specialist. So in the end, you have to have a commitment to learn from anybody and a commitment to pass on that knowledge to anybody. And that's the only way that our community in pathology grows. And we share whatever we know best and expect the best from our colleagues and peers. So thank you very much for coming, and I hope you enjoy the conference.
Thank you so much, sir. Next, we would like to invite Dr. Neha Nigam to give the vote of thanks.
Thank you, Akanksha. Good morning, everyone. On behalf of the organizing committee, I'll take a privilege to extend our heartfelt gratitude to each one of you for gracing the inaugural ceremony of International CME on updates in gastrointestinal and gynecological pathology. First and the foremost, I would like to thank our respected director, sir, Padam Shri Professor R.K. Bhiman, for his encouragement and support that has been instrumental in making this event possible. And as sir has said, we'll definitely commit a full-day CME program dedicated to the hepatic pathology. A special thanks to our Dean Sir, Professor Shaleen Kumar, whose inspiring words today have added a great value to this academic gathering. Thank you, sir. I express my deep appreciation to our head of the department, Dr. Manoj Jain sir, who have built the concept of this CME and gave us the opportunity to make it happen. Thank you, sir. My sincere gratitude to Dr. Vinita Agrawal ma'am for her constant hand-holding and the constructive inputs. Ma'am has been influential in giving this CME its shape and depth. Our international coordinators, Dr. Amitabh Srivastav and Dr. Mamta Gupta ma'am, has put their exceptional efforts in connecting with all esteemed international speakers and bringing the global expertise to this platform. A special note of appreciation to them. Thank you, sir. Thank you, ma'am. I thank all our distinguished speakers for taking the time to be with us and for sharing their knowledge. And we eagerly look forward for your insightful sessions. I'm indebted to all my teachers, seniors, and delegates for having a faith in us for providing a high quality academic content and have joined from the various parts of the country. I welcome and thank you all. This list won't be complete without mentioning the efforts of our efficient organizing team members. I thank them all for the supportive and the cohesive teamwork. A big thank you and lots of love to our amazing residents, the junior residents, senior residents, and PhD scholars for their unwavering support and the lightning fast responses. They worked instantly on every command with dedication, energy, and smile. We are proud of you. Thank you. Now, the supporting staff, the administrative, technical, clinical, from managing logistic to the finer details, their role has been indispensable. So we are thankful to all of them. Last but not the least, the backbone of this event, our sponsors. I'm thankful for your generous support, which made this CME possible. Your partnership not only enabled us to organize this program at the high standard, but also reflect your commitment to the advancement of the medical knowledge and the patient care. So to everyone who participated, presented, or attended this CME, thank you for making this event a great success and hope for a wonderful CME ahead. With that, I now invite all of you to join a tea break outside the auditorium. And we also look forward for welcoming you at the gala dinner this evening, which the program has already been shared in the group. And thank you.
Thank you so much, ma'am. With this, we come to an end of the inaugural ceremony. Thank you so much, our esteemed guests, for joining us on the stage. Please join us for the tea, which is being served in the foyer. Sessions will resume shortly after 15 minutes.
Folder. Lectures of speakers.
ये मेरा next वाला.
ये next वाला, हाँ, सुबह ऊपर वाला तो हो गया, ये वाला.
और आतुर की टाप
वो अभी, हाँ, वो सुबह वो आपने
perfect,
हाँ,
perfect.
ये आपका है. ठीक है.
हेलो. हेलो. गुड मॉर्निंग. बताइए. हाँ बताइए बताइए. हाँ बताइए जल्दी बताइए. हाँ. नहीं नहीं नहीं. हाँ.
आप सर की पीपीटी भी है इसमें, ठीक है। सबसे पहले वही है ना स्पीकर। अब हमारा राकेश पांडे सर हाइड्रेट है, जयंत सर को बुलाएंगे, गौरव सर को बुलाएंगे, ठीक है। तो मैं अपना
पिछले बार ना ये दिक्कत हो गई थी।
मैं आके कर दूंगी, ठीक है। इसमें 3 है ना, पहला जयंत सर को आप बुला रहे हैं, फिर गौरव पांडे सर को बुलाएंगे, फिर उसके बाद से
ये वैसे वहाँ से ज्वाइन करेंगे भाई, रात को 2:30 बजे ज्वाइन करेंगे।
हाँ, ठीक है। फिर उसके बाद अमिताभ सर की पीपीटी है, आतुर सिंह सर ज्वाइन करेंगे, फिर संजीव सर ज्वाइन है। 3 नंबर है, बस ये डन हो गया। अगला इसके कितने नाम चलेंगे पूरा, फिर थर्ड सेशन। हाँ ठीक है, थर्ड सेशन हम तब नोट देख लेंगे। अच्छा नीरज नाम तो है, नीरज नाम है, अशोक कुमार का तो पता चल गया। ठीक है, ये तुम्हारा सही है।
क्या क्या हम लोग
हाँ ये 3 बनना है ना, ये तो हम डिस्प्ले कर देंगे, ये 2 बंदों का करना पड़ेगा। सॉरी ये और ये, हाँ ये कैसे हुआ, हाँ सही है।
तो यहाँ से शुरू करना है, वहाँ से एक ये रहो।
बस जैन सर, जैन सर,
जैन सर।
हाँ जैन सर, ठीक है, अभी यही लगा देते हैं। हाँ। बैठ जाएंगे 5 मिनट, लगा दूंगी।
ठीक है, ठीक बढ़िया, ठीक है, ठीक है, थैंक यू, थैंक यू।
नहीं, आपको दे दिया सर। हाँ देख लिया सर, अभी तो निकाल के दिया आपको, चेक कर लिए।
We shall be beginning the session 2 shortly.
बुला लाओ, नेहा मैम को बुला लाओ, मैम बुला लीजिए। चेयरपर्सन में जैन सर है और वो है ना।
Welcome back, everyone. We hope that you had a refreshing tea break. Yes, sir. Sir, we now move on to session 2, where we broaden our discussion into gastric cancers, ampullary and periampullary tumors, along with colonic biopsies in inflammatory bowel diseases. We would now like to invite our chairpersons for this session, Professor Manoj Jain, Professor and Head of Department of Pathology, SGPGI, and Professor Gaurav Pandey, Professor, Department of Gastroenterology, SGPGI, to guide us through this engaging session. We request our to kindly proceed to the dais.
So welcome you all after the tea break. So for this session, I'd like to invite Dr. Amitabh Srivastav. So he's attending pathologist in Memorial Sloan Kettering Cancer Center, and is former alumni of our institute. He has got many publications and great achievement, gastrointestinal pathology, MGH, has worked fellowships in Brigham and Women Hospital, board certifications, American board, then honored Mentors Award, US CAP Foundation. He's got 181 publications and he has published books also. So I invite Dr. Amitabh Srivastav for his presentation. Please, Dr. Amitabh.
Thank you, Manoj Boss. Welcome after the tea break. So since it's IPL season, oops. Can you hear me at the back now? Hang on. How's this? So since it's IPL season, this is not my original idea. Arthur Singhi stole the theme first. So he sent his title first, so I just followed suit. But I think it's a good analogy because what I'm going to talk about in the next 40 minutes or so is how the management of gastric cancer is changing and changing very fast. And because of the mixture of audience, some trainees, some practicing pathologists, some senior members, it's going to be a little bit of everything. So just bear with me. If it's too simple, just hold on for a few minutes and you'll get to a part that you might find interesting or new. So, so why do we care about gastric cancer? One, or why do we care about gastric cancer in the West? Not really a common disease there. We see a lot because we are at a dedicated cancer center. But overall, if you look at incidence and mortality on the globe, India is somewhere in the middle, not really a very high incidence area like the Far East or Russia or parts of South America, but not quite like the West, where at least a subtype of gastric cancer has been declining, as you can see here. So from the mid-70s to 2019, you can see this dramatic drop in gastric cancer in the US. And this is largely due to the fact that gastric cancer in the most common variety is the prototypical inflammation to metaplasia to carcinoma sequence. So since Helicobacter has been identified and can be treated, in the West, the incidence of gastric cancer declined in parallel with the decline in Helicobacter gastritis. So before we get into gastric cancer classifications and therapy, first things first, how do we define gastric cancer? Or what is gastric cancer? So it sounds very simple that, gastric cancer is carcinoma of the stomach. And that's true and easy unless the tumor involves the GE junction. So this is something for the trainees to remember. If you get a specimen, a gastrectomy specimen, in which the tumor is involving the GE junction, you have to do a few things. One, measure the size of the tumor and see where the center of the tumor is located. And so you can see this is the current CAP guidelines or and the HACC guidelines on how you define gastric cancer. So if the epicenter of the tumor is more than 2 centimeters away from the gastroesophageal junction, then that qualifies as a gastric cancer. So you have to use the synoptic for gastric cancer, even though it's involving the GE junction. If the same epicenter is less than 2 centimeters from the GE junction, then you stage it using the esophagus GEJ template, and it's staged largely as an esophageal carcinoma. The exception to the rule is that if the epicenter is less than 2 cm, but the gastroesophageal junction is uninvolved, then you still stage it as gastric cancer. And the reason for that is that the data predominantly comes from the West, and cancers of the proximal stomach are more likely to be distal esophageal cancers that grew and involve the proximal stomach. And which is why I think you need more studies from the East to really refine this classification. It sounds very crude that if it's less than 2 centimeters, classify it as esophagus, more than 2 centimeters, classify as stomach. But that's what you have to do. So a few things: locate the G junction, measure the tumor size, see where the epicenter is, note the distance from the gastroesophageal junction, without which you cannot fill out the template properly. So why do we care about tumor classifications? We care because they give you a glimpse into underlying etiopathogenesis. Is this more likely to be inherited versus sporadic? What are the predisposing risk factors? Most classifications have some kind of a prognostic significance. And then, as I'll mention in the last 10 minutes or so of the talk, gastric tumor in particular, the classification is moving. We are becoming more like HEMPATH, and I'll tell you why. So this is how we have classified gastric cancer historically. There's a gross classification. If you recall the synoptic templates that we have to fill out for gastric cancer, there's a gross Borman's classification. There are histological classifications that have stood the test of time, are very helpful in some ways, which I'll talk about. Loren and WHO are the ones used most commonly. There are a number of others which are not widely used, but are used within certain geographic zones. The Japanese have their own classification. Since 2015 or so, there have been a number of genomic profiling classifications. I'll share one of them with you. And then what has really taken off is a biomarker classification of gastric cancer. And we'll talk a little bit about that towards the end. So macroscopic classification or endoscopic classifications are very useful if you have gastric surveillance programs and you detect early lesions. And they're important because just looking at the lesion gives you a sense of how likely it is to be invasive. And we won't go through each category, but in general, the more polypoid and projecting into the lumen kind of a lesion, the less likely there is an invasive underlying component to it. And the flatter and also more ulcerated the lesion, the more likely that there is going to be a deep invasive component. So as first principles in both esophagus and in stomach, the endoscopic appearance of the lesion and then an endoscopic ultrasound basically decide what happens to the patient. If there is no deep invasive component, those patients get treated by endoscopic resections, whether in EMR or in ESD, and I'll talk about it a little bit. And then if it's a deeply invasive lesion, then the triage or the algorithm goes more towards neoadjuvant therapy followed by surgical resection. So very helpful in deciding which patients need an endoscopic ultrasound before you start nibbling. You can take a biopsy, but you don't really attempt a resection unless you have done a proper evaluation. Lorentz classification into intestinal and diffuse has been around for decades. This is from the original paper showing that you can broadly define two groups of gastric carcinoma, one intestinal, which essentially is a mass-forming lesion. And if you take sections from that tumor, you see gland-forming tumor, the conventional adenocarcinoma. Whereas this other type, you don't really see a discrete lesion. You see prominent gastric rugal folds on the picture on the bottom right. So you can't really see a dominant mass. And this is the linitis plastica, leather bottle stomach, whatever you want to call it. And on histology, there's single cell infiltration. These tumors don't really form glands, and which we used to call signature cell carcinoma, which has been a bad term to use for decades. And now we're in the process of trying to fix it. So why is Lorentz classification very useful? It's very useful because it gives you two distinct groups of gastric cancer. One really associated with H. pylori, which is the typical intestinal type. Also in other inflammatory conditions like autoimmune gastritis. So this is the prototypical inflammation to metaplasia to dysplasia to carcinoma kind of a cancer, as opposed to the diffuse type, which arises de novo. So it's either inherited germline defects in CDH1 or acquired sporadic defects. Intestinal type more common in male, diffuse type more in female. The incidence graph that I showed you, that's declining incidence of gastric cancer in the West, is almost all intestinal type. The reason we are more interested in gastric cancer in the past decade or so in the West is because the incidence of diffuse type gastric cancer, for reasons we don't know, is actually increasing, and that too in young patients. And then the patterns of metastasis are a little different. Intestinal type typically goes to visceral sites, diffuse type, more the peritoneum and ovaries. So for trainees, the typical or prototypical Krukenberg tumor is diffuse type gastric cancer going to the ovaries. And then, as I said, there have been a number of attempts at histological classification because the morphology of gastric cancer is very heterogeneous and you don't really know to memorize all of them. The one that's most widely used now is the WHO classification. So I'll run through some of the morphological patterns of the simpler and more common types, and then focus really on two or three morphological subtypes that are rare, uncommon, but I think you need to know about them. And they are really the ones that have some prognostic significance, because the rest it really depends on stage. So whether it's tubular papillary, tubular papillary, well diff, pole diff, doesn't really matter that much. So this is what tubular type means, that the tumor cells form glands, hence an adenocarcinoma. You can have two types of differentiation: intestinal type, that it looks more like a colon adenoma. Gastric type retains the gastric type mucin. Usually, most gastric type tubular carcinomas are early stage. As the tumor gets more and more deeply invasive, they'll transform to the more intestinal type. So it's a rare pattern. You'll see it more often if you have an endoscopic surveillance and screening program, or you have gastroenterologists doing endoscopic resections. There can be different grades of the same tubular type carcinoma. So remember, we grade GI adenocarcinomas in general using percentage gland formation. So there's a spectrum where virtually the entire tumor is forming glands, to those tumors that are predominantly solid, they're not forming glands. So when you're filling out your synoptic template, sometimes it's confusing as to where to put it. Is this WHO tubular or papillary? Because the tumor is almost all solid. And those are poorly differentiated tubular types of gastric carcinoma. So here's a good example of papillary. As the name implies, they are finger-like or villous projections, fibrovascular cores lined by neoplastic cells. And again, there's a spectrum of differentiation. So in general, as a general rule in pathology, you type tumors based on the most differentiated or the best differentiated part, and you grade them based on the least differentiated part. So if you have a tumor where much of the tumor looks like this, it'll be a moderately differentiated tumor. A well-differentiated tumor will be where more than 90% of the tumor is forming some kind of tubules or papillae. And then, like in any other, as I said, gastric cancer morphology is very heterogeneous, and hence there's no real classification that carries prognostic significance to any meaningful degree. So here's an example where you have both tubules and papillae. And so this is the tubulopapillary architecture of gastric cancer. And then, as I said, the diffuse type is usually single cell infiltration. We used to call them signature cell type, still do, because the most common pattern of this tumor is eccentric nuclei with a dominant mucin vacuole. So it looks like a ring. The reason it's not a particularly good name, especially in context of the stomach, is that not every tumor will have mucin. So you can see examples on the right that are the same underlying CDH1 mutation, but they don't really have mucin. So some of them have very eosinophilic, abundant cytoplasm, almost a rhabdoid kind of a morphology with prominent nucleoli. Or examples here where these are all tumor cells. So this is the same spectrum of tumor genetically, but looks very different morphologically. So which is why there was this switch led by Fatima Carneiro, a fantastic gastric cancer pathologist in Portugal. And she's been integral in bringing this term poorly cohesive carcinoma into the WHO, which encompasses signature cell carcinoma also. So just remember that poorly cohesive carcinoma, signature cell carcinoma is a type of poorly cohesive carcinoma, and not all poorly cohesive carcinomas will have a signature cell morphology. And then you can also get mixed intestinal and diffuse type. So here's a tumor that's almost 50-50, forming glands and also doing the single cell infiltration. So this is mixed tubular and poorly cohesive type. So this is the probably, if you're filling out a gastric cancer synoptic, this will probably be 95% of the time, it's going to be one of these patterns. And then mucinous, as the name implies, just like in the colon or at other sites, the bulk of the tumor is going to be pools of mucin, in which there can be floating strips of neoplastic epithelium or clusters of neoplastic cells that have, again, a signature cell morphology. So often trainees will mistake this for signature cell carcinoma, and that's not accurate either. So goblet cells are signaturing in morphology, right? But we don't use signature cell carcinoma for that phenotype. So if you have abundant pools of mucin with floating tumor cells, that's a mucinous adenocarcinoma. And again, it's the percentage rule. It has to be more than 50% of the tumor. I want to just say a quick word about an interesting and important advance in neuroendocrine carcinoma diagnosis. Some of you may know it, many of you I'm sure don't. Gastric cancer, just like any part of the GI tract, most neuroendocrine carcinomas of the GI tract arise as divergent differentiation in a pre-existing adenocarcinoma or a squamous cell carcinoma. They don't, so this is not lung, they don't arise de novo. And if you look at the genetic signatures of these tumors, they are more like adenocarcinomas, not like the typical neuroendocrine carcinoma of the lung. And you can see examples where this is really happening. So you caught a tumor in transition where you see both components. Part of it is a gland-forming adenocarcinoma, and part of it is a poorly differentiated neuroendocrine carcinoma. So you can see a very nice example here. This is a biopsy where on the right half, this is tumor-forming glands. On the left is a poorly differentiated tumor, which looks just like small cell carcinoma of the lung. So why do I bring this up? Just to share something which really came about from colleagues of mine in thoracic pathology at Memorial, which is that we've known for decades that there is a subtype or subset of small cell carcinomas that really don't stain. They look prototypical small cell carcinomas in the lung, but they don't stain with neuroendocrine markers, chromogranin or synaptophysin. And at Memorial, the practice had always been to treat them like small cell carcinoma, but we know that there's a big differential, that there are other carcinomas that can look similar. So there wasn't really a marker that helped us identify these so that they can be treated appropriately as small cell carcinoma and not a poorly diff adenocarcinoma. And through gene expression profiling studies, they identified PAU2F3, which is a chemosensory tough cell marker in the lung. And PAU2F3, interestingly, is also present. Neuroendocrine cells in the gut express PAU2F3 because it's a chemosensory endocrine cells, which is responsible for sensing parasites. So it's present also in the GI tract, but we didn't know about it. And you can see on the top examples on just regular H&E that look just like small cell carcinoma. But if you look at chromogranin and synaptophysin, this is the prototypical example. But then all these others are negative for chroma and synapto. But if you had the antibody for PAU2F3, you can see this is a very nice, robust nuclear stain that stains this neuroendocrine marker poor or negative small cell carcinomas. So I'll just share a cool example, again, from the proximal stomach, a mixture of gland forming and solid components in the tumor. So this would be, if you only had this, it would be an adenocarcinoma. If you have this solid component, then it looks like a polydiff. Whenever you see a polydiff tumor in the esophagus or stomach, the differential really is 3 or 4. It's either going to be a polydiff squame, a polydiff adeno, a polydiff neuroendocrine carcinoma, or an undifferentiated carcinoma. There are some rare things, but that covers 99.5 out of 100. So if you have a tumor that looks like this, usually you'll do a P40 for squamous differentiation. You'll do maybe a CDX2 for adeno, but usually that's a diagnosis of exclusion. And then you do your chromogranin synaptophysin for neuroendocrine. But if it's negative for all, and it looks neuroendocrine like the case here, then it's important to think about PAU2F3. So here's a good PAU2F3 stain showing that it's negative in the gland-forming adenocarcinoma component like you would expect, and it's positive for PAU2F3 in the neuroendocrine carcinoma. So this can then be treated with, it's not that important in the upper GI tract because they still get platinum-based therapies, even if it's a polydiff adenocarcinoma, but there's a little change in the chemotherapy regimens that they use if you say it has a neuroendocrine carcinoma component. So just something to remember, which is new in the past 5 years or so. And then you can see a lot of lymphocytic infiltration in tumors, and these really are a differential of 2. It's either going to be an MMR deficient or DNA mismatch repair deficient tumor, usually loss of MLH1 and PMS2 because these are sporadic hypermethylators. Or it can be an EBV-associated adenocarcinoma, which we don't see too much in the West, but it's not that uncommon in the East, particularly the Far East. And then the way to make that diagnosis is to do an ISH for EBV, and you can see this nice nuclear positivity in the tumor cells. But we did many years ago a study with colleagues in Korea and showed that what we used to call the classic pattern lymphoepithelioma-like carcinoma, which is figure A in this panel, where it's actually very hard to identify the actual tumor cells. Most of this is non-neoplastic lymphocytes infiltrating the tumor. So that was the prototypical EBV-associated carcinoma. But if you screen a series of gastric cancer in an endemic area, you can see that it's not always the case. So you can actually subdivide the morphology of EBV-associated gastric cancer into 3. Those that have the prototypical lymphoepithelioma-like carcinoma appearance. For those who want to picturize in your head, think of nasopharyngeal carcinoma, where you have more lymphocytes than tumor cells, and it's hard to pick out the actual neoplastic cell. Then you can see what we called, at least in this paper, Crohn's-like infiltrate, where you have these big lymphoid aggregates in response to the advancing edge of the tumor. And then those that had a really minor lymphoid component and look like garden variety adenocarcinomas of the stomach. And if you look at prognostic significance, this is a better example showing you a panoramic view of the carcinoma on the top, which was positive on EBER-ish. And you have this Crohn's-like infiltrate, just like you would see in a colon that's Simplo or KRAS mutant. And if you look at prognostic significance, you can really see that the better prognostic significance of EBV-associated gastric cancer is restricted to the lymphoepithelioma-like carcinoma subtype. So they have the best prognosis, and tumors that are EBV-driven but don't have a lymphoid response really tend to behave just like garden variety gastric cancer. They don't really have the same excellent prognosis that we associate with EBV. 2 subtypes, or maybe 3 that have independent prognostic significance, which we should know about. The first is micropapillary, which, as the name implies, has this peculiar architectural formations, which I'll show you a higher part in a second. It's an adenocarcinoma. It's seldom present in pure form, usually as a minor component of a gland-forming tumor. So you can see a conventional adenocarcinoma on the left, and this is all micropapillary differentiation. And why do we call them micropapillary? We always tell our trainee these are silly or stupid tumor cells that have forgotten how to make a gland. So they're making a gland on the outside rather than the inside. So that lumen is a real space. And this inverse polarization or reverse polarization where the brush border is on the outside as opposed to the inside is very peculiar and typical of micropapillary differentiation. So they look like papilla, but they don't really have a big fibrovascular core in the center, and hence the word micropapillary, which we borrowed from the GYN people. You'll hear a lot of micropapillary tomorrow, I'm sure. The reason it's important is that unlike every other subtype where we need 50% of tumor to classify it as that particular subtype, for micropapillary, the cutoff is just 5%. And that tells you that this really has independent prognostic significance. It has a propensity for lymphovascular invasion much more than the other subtypes. And when you see this, the other challenge is that there is no way that you can actually differentiate this pattern from lymphovascular invasion because the space looks real. There's usually a fibroblast lining the stroma around it, so it can look very much like there's tumor floating in a lymphatic endothelium. There are some clues on morphology, but none are absolute. So you can see that here's an example of micropapillary on a CD31. So it's all micropapillary, no lymphovascular invasion. And here's an example of a D240 stain where you can see nice lymphovascular invasion, but then other parts of the tumor that are not really, they have a space, but it's not really micropapillary. And so why do we care? It's a rare subtype. The first series we put together was just 11 cases. You can see what I just said, that micropapillary differentiation was 5 to 70%. So in the colon also, that's the cutoff that's proposed by WHO. Very high prevalence of lymphovascular invasion, very high prevalence of nodal metastasis, so an aggressive subtype. So anytime in the GI tract, whether it's colon or upper GI, if you see a T1 or T2 early stage tumor that has gone to the nodes, if you look carefully, chances are you'll find a focus of micropapillary differentiation, which in the colon now we call solid cell clusters and other fancy names, but it's basically the same phenomena. And you can see the prognostic significance here. And as tumors advance and go to nodes or distant sites, whether it's conventional or micropapillary, you lose the prognostic significance. So you can see here that if you only look at stage 1 or 2, the micropapillary ones tend to do much worse. And once the tumors are very advanced, then you lose that prognostic significance. So if the tumor is already in the liver or lung or bone, whether it's micropapillary or not, it's not going to matter. But if it's confined to the mucosa or submucosa, then whether or not it's micropapillary has huge prognostic significance. Another very rare type, which is, if you've been following the gastric cancer literature, there's a controversy between the Japanese and the Americans, not very surprising. Initially described by the Japanese as gastric carcinoma with chief cell differentiation, renamed by Liz Montgomery and her colleagues in the US as oxyntic gland adenoma. And as always, the truth lies somewhere in the middle. You can see both. It's neither always benign, neither always malignant. It's more like a precursor that progresses in a small proportion of patients to an invasive carcinoma. So in the benign end of the spectrum, it's basically form of oxyntic gland with a little abnormal architecture. So these are polypoid lesions in the stomach. This is not a fundic gland polyp. It's a true precursor of gastric cancer. And when they progress, you can see the architectural disarray, irregular glandular profiles infiltrating the stroma with this loose desmoplastic response. And the reason they are peculiar is because you would expect carcinomas to lose differentiation, right? So these are peculiar cancers that retain chief cell differentiation. And if you look carefully, you can actually see parietal cells. So there are subsets the Japanese have reported is parietal cell adenocarcinoma or chief cell adenocarcinoma. Again, you'll only see this if you have a surveillance program and people doing endoscopic resections for early tumors. The same tumor, if it's a T3 or T4, it'll change phenotype as soon as it's going through the submucosa and the muscularis propria. So just something for you to remember that there will be a subtype of gastric cancer that will retain the lineage from which it arose. If it arose in the oxyntic glands, a subset will keep forming chief cells and parietal cells. These, if you want to stain, they stain with MUC6, which is a marker of pyloric glands, but also marks chief cells in the oxyntic mucosa, but will also stain with pepsinogen as it should, since it's chief cell differentiation. There's a category, I don't like calling this a subtype because I think it's been called so many different names in literature that it's lost its significance. It's been called enteroblastic, it's been called hepatoid, it's been called clear cell, it's been called yolk sac-like, and I'll show you why. Again, gastric cancer, very common in Japan, so much of the early literature and interesting stuff comes from them. The reason there are so many names is because it has a broad spectrum of morphological patterns. So here you can see something that looks predominantly clear cell type. On the right, you can see nested or cords or broad trabeculae with very eosinophilic cytoplasm that if I said it's a liver mass biopsy, you would think of hepatocellular carcinoma, hence the term hepatoid. Things that have this reticular, microvesicular and reticular patterns, anastomosing cords and a loose myxoid stroma that makes it look yolk sac-like. And then some parts of the tumor can look just like conventional adenocarcinoma that you have no clue that there is anything enteroblastic about it. And these, what they have in common is that they all stain with SAL4, which is an embryonic stem cell marker, and they stain variably with markers of hepatocellular differentiation. So they'll stain with HEPAR, arginase, glypican-3, or AFP, but to varying degrees. And the reason to know about them is that they also are a tumor with bad prognosis. They're very aggressive tumors with a high incidence of liver and nodal disease and lymphovascular invasion. And I'll spend some time talking about it because it might be something that you see in your practice, and there are some clues that help you identify even without doing immunostains. So why enteroblastic? Enteroblastic because it looks like the fetal endoderm. So here's an example of a 9-week gestation fetus, and you can see this looks exactly, the tumors look or recapitulate the appearance of the fetal endoderm with columnar cells with vacuolated or clear cytoplasm on the surface. Vikram Deshpande, who some of you may know, who is in Boston, tried to bring some sense to this spectrum of tumors by saying we should classify them into type 1, type 2, type 3. Type 1 that look hepatoid and stain like a hepatocellular carcinoma. And obviously, this is not in the liver, it's in the stomach or somewhere else. This is a study not just of gastric enteroblastic and hepatoid carcinoma, but throughout the GI tract, including the pancreas. And then you can have tumors that look the prototypical enteroblastic with clear cytoplasm and stain with hepatocellular markers. And then those that look garden variety adenocarcinomas, but share at marker positivity for either AFP or arginase or HEPR1. The challenge is that tumors don't really follow the rules. So here's an example of the same patient. You can see the gastric mass biopsy, which looks just like any other adenocarcinoma, but stained just like an enteroblastic tumor. And actually, we didn't stain this one because there was no reason to stain it until it went into the liver. And you can see the liver metastasis looks like classic enteroblastic differentiation. So we stained this one and said, oh, it's an enteroblastic adenocarcinoma. And then we said, oh, well, the in-house biopsy was also done here. And we looked at that and it looks like conventional adenocarcinoma, and we stained that and it stains the same way. So the type 2 and type 3 and type 1 really is not very practical unless you start staining everything. So the reason to know about them is that one, whether it's enteroblastic differentiation or an adenocarcinoma with immunohistochemical positivity for hepatocellular markers, they tend to behave the same way. So we don't really have to do this type 1, type 2, type 3 because they have the same prognostic significance. And the reason to pick them up is because compared to conventional gastric carcinoma, they have a much higher prevalence of HER2 positivity. So there's a target associated with them, which can be very helpful. These are aggressive tumors, which will behave poorly, but they can be positive for HER2, which gives our oncologist colleagues a target to treat. And as you can see, it's true for both hepatoid and enteroblastic carcinomas, and there's a minor subset that has NTRK alterations too. So there's some molecular underpinnings to this aggressive type, and we've seen at least a few that were disseminated stage 4 tumors at presentation that responded very well to either HER2 or NTRK-based therapy. So something to know about. So take-home points about enteroblastic gastric cancer: dismal prognosis. They have elevated serum AFP. So the WHO, because we couldn't have a classification that makes sense, has lumped all of these into AFP-producing adenocarcinoma. So the same thing that I mentioned about micropapillary, if you have a surgeon or your gastroenterologist colleague coming to you and saying, this was a 1 centimeter polyp in the stomach or a very superficial T1 tumor in the stomach, and the whole liver is studded with tumor and he has innumerable lung metastasis, you can be very smart and say, can you do a serum AFP? And in all likelihood, that's going to be elevated and it's going to be an enteroblastic adenocarcinoma. So that's a very simple clue that you're dealing with a morphological subtype that has prognostic significance. There's some data, very early preliminary data from China, that because they look like hepatocellular carcinomas in some ways because of the immunohistochemical positivity for heparin and arginase and even albumin-ish, maybe treating them like HCC may be helpful for these patients because there's not really much that we can do. So there's some data that sorafenib, which is a drug that we use in HCC, may be helpful in these tumors too. And then there are trials ongoing currently where these tumors also stain with Claudin-6, preferentially stain with Claudin-6. And there are trials looking at CAR T-cell therapy in this enteroblastic variant to see if we can somehow change the prognosis in these patients and identify targets that help us treat them. And then the last of the 4 differential that I mentioned, polydiff squame, polydiff adeno, polydiff neuroendocrine carcinoma. And then the last in the group is undifferentiated carcinoma. So these are carcinomas common throughout the GI tract, also at other sites that are barely carcinomas. If you did your pan-keratins, you can throw a panel of keratins and you'll find, as in this case here, a few cells staining positively with pan-keratin. And this is a tumor type that loses this or arises as a result of mutations in the SWI/SNF pathway of genes, SMARCA2 or SMARCA4 or INI1. And INI1 is probably the least common in the GI tract. I think we've seen just 2 examples so far. SMARCA4A2, much more common in this undifferentiated spectrum. So the reason to recognize this phenomena is that if you have a biopsy and it's a small tumor to work with, and you throw a lot of keratin stains and it doesn't stain like a carcinoma or a lymphoma or a melanoma, think of an undifferentiated carcinoma. And that's most likely what the diagnosis is going to be. Abbas Agami from Germany put together the first series of the GI tract. These are examples from his paper showing this multicentric tumor in the small intestine. And then they have this, what they have in common is this loss of expression of SMARCA2 or A4 or INI1. The INI1, if you see an example in the GI tract, is most likely going to be a met from the lung, not a primary. So just remember that of all the 3 genes that I mentioned, INI1 is the least common. Let's switch quickly to molecular classifications of gastric cancer. There are several. The Asian Research Group cancer genome study that tried to subclassify them based on genetic aberrations. And then the Cancer Genome Atlas study, just like every other organ, you'll hear a lot about TCGA tomorrow also. They also did a series of gastric cancers, looked at it, not just sequencing, but RNA expression profiling, and basically tried to classify them into 4 groups, which is very helpful, but more or less parallels the morphological classification. So the TCGA, every series, every tumor type that they looked at, they had roughly 200 or so cancers, and they did whole exome sequencing, looked at somatic CNVs, methylation profiling, and so on. And then in the stomach, essentially, there are four classes. The first is the one that I showed you with lots of lymphocyte. Not surprisingly, that will cluster separately. So the first group on genetic classification, if you will, is the EBV-associated gastric cancer. The second is, again, lymphocyte-rich MSI-high tumors or MMR-deficient tumors that will lose MLH1 or PMS2. And then the third important type is the genomically stable type. And if you look at histological correlates, the vast majority of these genomically stable ones are going to be the diffuse type gastric cancer, signature ring cell morphology. And then the prototypical intestinal type that I showed you will fall in this big group of chromosomal instability tumors, which is the most common type, and will look intestinal if you looked at morphological correlation. So if you looked at what's most common based on location, what subtype or molecular subtype is most common, the intestinal type, most common because, as I said, that's the most common inflammation to metaplasia to carcinoma sequence. So it occurs almost everywhere in the stomach, most common proximally, but can be in the body or in the antrum. The genomically stable type, similarly, can be present anywhere in the stomach. The EBV ones most commonly are in the body, so they tend to spare the two ends of the stomach, the proximal and distal end. And then the MSI high ones or the DNA mismatch repair deficient ones are more common distally, so they don't occur to that frequency in the proximal stomach, more common in the body and the antrum. And if you look at prognostic significance, this is from TCGA, you can see that all the other types tend to cluster together except the diffuse type gastric cancer or the genomically stable one, because it has aberrant adherent expression on histology. So some molecular correlate of the histological classification that I showed you. But if you look at how gastric cancer is managed now, and this is the last 10 minutes that I promised you at the beginning of the talk, if you have early gastric cancer, those patients don't usually see any chemotherapy. Those are treated endoscopically. We need to know which patients among that group needs additional therapy and they need a resection of the stomach to stage lymph nodes. And we'll go through that quickly in a minute. And then those that are advanced, either deeply invasive into the stomach or have positive nodes or have distant metastasis as presentation, go through this algorithm of neoadjuvant chemotherapy followed by surgical resection. We won't go through endoscopic resections because I'm not sure how relevant that is in our setting here. For those who are interested, there's this very nice review by two of my GI pathology colleagues, Greg Lowers and Priyanti Kumar Singhe, who's in Australia, showing which are the features in gastric cancer that's early that can be used to say that the patient is now cured of gastric cancer. So the criteria basically depend on tumor size, histological type, and whether or not there's an undifferentiated component and whether you see lymphovascular invasion or not. So if a patient fulfills the criteria listed here, those patients don't really need a completion gastrectomy. For everybody else, just like in the colon, you can have a malignant polyp with cancer, and the main question is, does the patient need a colectomy to stage lymph nodes? The same question arises in the stomach. And then if you have a patient where you know this is a mass lesion that's deeply invasive, those patients will see neoadjuvant chemotherapy. And then you have a lot of options in your armamentarium, and what precise chemotherapy is given often depends on what biomarker status you report along with your histological diagnosis of invasive adenocarcinoma. So there are multiple markers we use currently. So the first one is PD-L1, which is a terrible marker to use, but it's established in practice. There's no easy way it's going away anytime soon, and I'll tell you why. The thresholds we use clinically is PD-L1 or CPS score, combined positive score, more than 1 or more than 5 or more than 10. We discussed a little bit about HER2 positivity. I'll show you some examples in a second. So this is the standard right now that we use in every gastric cancer mass biopsy that we get. So the first thing is to say this is an adenocarcinoma of the stomach. We usually sign it out without waiting for the biomarker. We'll just put in a note that biomarker IHC is pending. We'll report it in an addendum. And then when it comes out, these are the panel that we report MMR IHC, whether it's intact or lost. If it's lost, which ones? If it's lost, is it clonal or subclonal? HER2 IHC, PD-L1, and then Claudin 18.2 is the most recent one that we've added about 2 years ago. So HER2, let's start with that. Why do we do it? Because there were trials showing that patients who are HER2 positive benefit from addition of trastuzumab therapy. This is the TOGA trial from many years ago, almost 15 years ago now, showing that those patients tend to do much better if you add trastuzumab to conventional chemotherapy. And then when you have this applies for GI in general. This criteria for colon are somewhat different. But in the stomach, you have to report, or you have to use two features to decide whether you're going to call it HER2 1+, 2+, or 3+. So the first thing is intensity, which is determined by the so-called Rushoff rule, based on the colleagues in Germany who came up with this, or the magnification rule. And basically what you're trying to see is whether you can see complete membranous staining, basolateral staining, or lateral staining at 5x, 10x, 5x, 20x, or 40x. So do you really have to go down on high power to look for positive staining? And if you do, that tumor is 1+ intensity. If you can pick up nice lateral membranous staining at 20x, that's 2+. And if it's very obvious at 5x, then it's 3+. And then you have to factor in extent of staining. And in the stomach, it depends on the specimen. So if you have a biopsy specimen, all it requires is a cluster of 5 tumor cells. So if you have 3+ staining in 5 tumor cells in a cluster, that's a 3+ staining, and that correlates nicely with HER2 amplification on a FISH assay or by sequencing. If you have a surgical resection specimen, then the quantification is slightly different, and you need that staining in more than 10% of the tumor cells. And it can be heterogeneous, and it can be hard because it's also based on intensity. So something that's we find very useful is to put the 3+ and 2+ controls on the same slide. So if you have a biopsy like here, trying to decide whether this is strong staining or moderate staining can be tricky at times. So if you have the 3+ control on the same slide and the 2+ control on the same slide, you can compare and say this looks more like 2+. And so this will not be called a 3+ at our institution. So there are guidelines from ASCO and CAP on how to report HER2, a reference that if you haven't read, you should. If you are trying to pick out a block for staining and it's a resection specimen, pick the lowest grade tumor because that's where the HER2 positivity is going to be most prevalent. If the tumor is very heterogeneous morphologically, it's okay to pick more than one block because there's a lot of intratumoral heterogeneity, and I'll show you an example in a second. And then if you're scoring something as 2+, it's very nice for you to mark an area that was 2+ on your biopsy for your cytogenetic colleagues who are going to report the FISH, so that they can then focus on that area when they're counting signals of HER2 and trying to decide whether it's amplified or not. So the reason I said there's a lot of intratumoral heterogeneity, and it has changed our practice in the past 2.5 years or so, is that if we have a case in which we already reported HER2 as negative and you have a subsequent specimen, either a metastasis or a recurrence, we always repeat the HER2 because it's possible that in a biopsy you missed the area where the positivity was 3+. So here's an example a few months apart where there was a residual tumor that was biopsied after neoadjuvant therapy, and we suddenly saw that this is 3+ instead of the 0 that we had reported initially. We also see examples where our oncologist will call us and say, hey, this patient was seen here, you call the HER2 0 or 1+ on the biopsy, and it's now at MD Anderson or Mayo, and they are saying the HER2 is 3+. So don't be scared. They're basically looking at intratumoral heterogeneity. PDL1, as I said, it's a horrible stain to score because the way you score it is you have to count the number of positive tumor cells. The image on the left is very easy because you know it's positive because it's tumor cells that are staining. You also have to count the number of positive inflammatory cells in and around the tumor, which can be challenging, as you can see in the image on the right. And then you add them up and then estimate the total number of tumor cells as the denominator and come up with a CPS. And we showed in a very nice global study with the investigators from all across the globe that it's the CPS scoring is really very terrible. I mean, it's terrible, and it's a very high inter-observer variability. And there's no way to meaningfully distinguish 1 from 3 from 5 and 8. The good news is that the oncologists now use it not looking for the exact CPS positivity, but looking at negative predictive values. So they really want you to tell them that this is CPS less than 1, so that they don't put through patients through immunotherapy, which has a lot of complications also. So we have shifted from oncologists pushing us towards a precise CPS cutoff to them saying, okay, we know that you are not good at doing this. We want you to tell us this is negative. So the likelihood of response in patients who have a CPS less than 1 is like 2%. So they don't want to put patients on immunotherapy if it's really low. Claudin 18, as I said, is the most recent kid on the block. Claudin 18.2 is used, positivity is used in many different ways, and I won't go through that. This is the Spotlight trial showing efficacy of zolbetuximab in Claudin 2 positive, HER2 negative, locally advanced tumors. And again, that has led to using this biomarker in routine practice. And this was the second big trial, the GLOW trial on Claudin 18.2. There are many claudins in the stomach. Claudin 18 is present in normal mucosa and in most gastric cancers, except the very poorly undifferentiated ones that I showed you. It can be expressed in other carcinomas, but very rarely. The most common extragastric one is probably pancreas. And then the cutoff that's used to call something positive is more than 75% membranous staining. The reason I said that the paradigm for treatment is changing is that there's already 2 targets that are probably going to be approved in the next year or so. Bemarituzumab, which directs therapy towards FGFR2b amplified gastric cancer, is probably going to be approved by the FDA in the US this year. So we are already validating our ISC for picking up FGFR2b amplified tumors. So this is the FIGHT trial showing efficacy of monoclonal antibody against FGFR2b amplified carcinomas. And the way we'll end up scoring these is, again, moderate to strong intensity, just like HER2. The cutoff is going to be somewhere around 10%. And again, these will change the way we approach gastric cancer that's locally advanced or metastatic at initial presentation. And then the last one, which is still in early stage, phase 1, is MTAP. So MTAP deletions are present in roughly about 5% of all gastric cancers and esophageal cancers. And there's data to show that MTAP inhibitors can have efficacy in solid tumors based on this trial, and also a recent one that was a phase 2 showing efficacy in gastric cancer. So you all are familiar with the CAP synoptic templates on how we report resections in gastric cancer, and this was this was how management of gastric cancer patients was determined in the past. And as I said early on, the way we approach it is changing, and all these parameters are, of course, important. But what's more important now is the biomarker classification of gastric cancer and what we do on the biopsy, because that determines upfront how the patient is going to be managed. So the neoadjuvant chemotherapy regimens are now tailored specifically based on the biomarker classification that we have in gastric cancer. And I'm sure that since there's a lot of molecular heterogeneity, there's going to be more and more markers being added to the list. So this is not really a classification in the true sense, putting things in different buckets, but from a patient perspective, very useful, because who cares whether the tumor is micropapillary or enteroblastic or not? They want to know whether it's HER2 so the patients can receive the right therapy. So this is how the writers are challenging the titans, because we used to think of addendum as something that's, at the end of the most important part, but that basically now is driving therapy in gastric cancer. So thanks for your attention. Happy to take any questions.
Thanks, Dr. Amitabh, for exhaustive talk. It's very informative, and a lot of changes have occurred recently. So any questions from the audience? And because we are short of time, 1 or 2 questions we can take up.
Please. So if you don't know the status on the initial one, then yes. And then even if you know the status on the initial gastric mass biopsy, and if it was negative, then I would say repeat it, because then the case that I showed you, so if it was 0, 1 plus, and you called it negative, repeating on the metastasis, just like the breast cancer people like to do, the same principle that it can be really a 3 plus that you missed because of intratumoral heterogeneity. So I would repeat it because that gives the oncologist on the target to treat. It's hard to, I mean, I understand it's hard to generalize the information that, that I shared, because this is only relevant if if the patient is going to have access to therapy based on those biomarkers. So you need to know the population and what's going to happen. Setting up an assay doesn't really help if what needs to happen after that is not going to happen. Only on oncologist requests. I mean, it's shooting in the dark to a certain extent in the pancreas right now, but because they have trials open and it's a marker that we already use in stomach, we'll get requests on patients who have failed first, second, third, fourth line, and they may qualify for a trial. I've yet to see a credible Claudin 18. I mean, one, it's not 18.2. What they approved is 18.1 and 2. So they say Claudin 18.2, but the antibody is bad, and it's not just 18.2. So Claudin 18.2 is used many different ways. There are monoclonal antibodies that are targeted specifically towards 18.2. And then there are drugs that are ADCs or antibody drug conjugates. And I'm sure tomorrow you'll hear a lot. I mean, this is revolutionizing how we give chemotherapy, because the membranous staining gives a target. So the antibody drug conjugates are basically delivering chemotherapy specifically to the membrane of the tumor cells. So we don't really need to have a monoclonal antibody against a target. So Claudin 18.2 is used that way too. There are a lot of ADC trials that have a combination of Claudin 18.2 antibody latched onto a chemotherapy drug. Thank you very much.
Thank you, Doctor.
Yes. Sorry, I missed the first part. Your oncologists are going to ask you to do a lot of things that are not really useful. So the PD-L1 story conceptually makes sense, but then it's anti-tumor. The inflammatory cells that we score have to be in response to the invasive tumors. If you have a cell block from a peritoneal fluid, it doesn't make any sense to do PD-L1. So they'll ask you to do PD-L1 on everything, but if you do, you should do it on the primary site, not on a metastatic site. All right, thank you.
Thank you, Dr. Amtad. So next talk is by Dr. Atir Singhi. He is currently in USA and time zone is different. So that talk will be recorded talk. Will be taking this talk, and in the Meet the Expert session, he'll be live. So whatever questions you can ask at the time of Meet the Expert session. So you can play. So about Dr. Atir Singhi, he is Associate Professor of Pathology, University of Pittsburgh, and Director and Coordinator of American Pathology Research and Director of the UPMC Department. He has got many publications and a lot of achievements are there, and he's got 334 publications. He specializes in GI pathology, peritoneal, liver, and pancreatic pathology. So
thank you again for the invitation to speak today, and apologies that I could not be there in person, but I'm sure
super giants, unraveling ampullary
it's going to be an excellent meeting. Thank you again for the invitation to speak today, and apologies that I could not be there in person, but I'm sure is going to be an excellent meeting in Lucknow. So I have no financial disclosures to disclose. But what I would like to talk about in the next 35 to 40 minutes, and unfortunately I can't cover everything when it comes to ampullary and periampullary neoplasms, And admittingly, these neoplasms arising from this location are very rare. And therefore, I'd like to take a more detailed approach to this talk with a focus on ampullary and periampullary adenocarcinomas, and to walk you through the steps that I take, honestly, every week, specifically an integrative approach to evaluating these neoplasms by combining careful gross inspection with microscopic findings. And along the way, discussing critical aspects that can impact patient care, such as subtyping and ancillary studies like mismatch repair, HER2 assessment, along with a few words as to where I see us heading in the future when it comes to these neoplasms, which of course is molecular testing. Before that, let's start off with a case. And honestly, there's really no better way to present a systematic approach to these neoplasms without going through that step-by-step thought process that we all take when evaluating these lesions. And therefore, it's important probably to go through this process to kind of show you how I approach these types of neoplasms. And so without further ado, really a number of years ago, a 52-year-old male presented to a UPMC cardiologist complaining of heartburn, nausea, and occasional vomiting. The patient was obese and had been started on a GLP-1 agonist, which is really gaining a lot of fame here in the United States, and specifically that of Ozempic. And although he was losing weight, the side effects of Ozempic were getting worse, which caused the cardiologist to start questioning whether this was really due to Ozempic or something else underlying in this patient. And so he drew up serum studies, which were remarkable for an elevated liver transaminases as well as elevated total bilirubin. Considering the patient's symptoms may be unrelated to Ozempic, the cardiologist referred the patient to a gastroenterologist who not surprisingly performed an EGD or esophageal gastroduodenoscopy as pictured here, which found an apple core type lesion that circumferentially wrapped around the ampullary region of the duodenum and was bile stained, consistent with likely an obstructive process. Unfortunately, biopsies of the rim of the lesion were necrotic, and due to clinical suspicion of a malignant neoplasm, the patient underwent a robotic-assisted pancreatic duodenectomy, which upon really bisection of the specimen along the pancreatic and common bile ducts, a technique that I'll go into vast detail in my talk later, a superficial mass was identified in the ampullary and periampullary region as noted by the white arrows and dotted line. Microscopically, the mass emanated from the ampulla with a well-circumscribed border that extended into but not through the muscularis propria of the duodenum. And histologically was consistent with a glandular neoplasm with a perilymphoid cuff at the leading edge, and in other areas, a syncytial growth pattern that is characterized by tumor cells arranged in broad confluent sheets where the cell borders were indistinct and the tumor cells are closely packed with minimal intervening stroma, except for really prominent lymphocytes that was, again, peritumoral as well as intratumoral in distribution. Now, before going any further, it's important to form really a differential diagnosis of mass-like lesions that can arise from the ampulla and periampullary region, which can be broadly classified into non-neoplastic lesions, benign neoplasms, and then malignant neoplasms. Now, of course, many of our benign neoplasms can transform into malignancy, and we'll get a little into that a little later. But overall, three categories of which non-neoplastic lesions often include lipomas, inflammatory type polyps, and lymphangiomas, typically those associated with chronic irritation of the ampulla. Among benign neoplasms, of course, those include your adenomas, typically your tubular adenoma or tubulovillous adenomas, very akin to that of what we see in the colon or just regularly the luminal GI tract of the small intestines, that are actually increasing in incidence. But it's also important to remember that you also have your pyloric gland adenomas of the ampulla, as well as serrated adenomas, which are also increasingly being recognized. And it can occur actually in this location, and actually the serrated adenomas can often be missed. But don't forget about your neuroendocrine tumors, and probably the coolest lesion of them all are your gangliocytic paragangliomas, or their new name, COGNET, composite gangliocytoma neuroma and neuroendocrine tumor. And finally, you have your malignant neoplasms, such as adenocarcinoma, neuroendocrine carcinomas, and although a precursor neoplasm, intraampullary papillary neoplasm, or IAPN. These neoplasms are almost always seen in association with an associated, invasive adenocarcinoma, and you just have to really look carefully. Sometimes if you really look carefully, look at that IAPN, you will find an invasive component next to it. But as I mentioned at the beginning of my talk, I can't do all of these entities really justice in the time that I have. So it's probably best to truly focus on one entity well, and probably the most relevant are the adenocarcinomas that arise from this location, and really important from a pathology perspective to just honestly just simply get it right. And like any adenocarcinoma, by definition, these neoplasms are malignant gland forming that have an epicenter in or around the ampulla. Thankfully, these neoplasms are rare, but they are associated with a poor prognosis, typically on the order of a 15 to 20% 5-year survival rate. Patients often present with jaundice, abdominal pain, pancreatitis, and sometimes weight loss before coming to presentation. And these are typically due to secondary obstruction by a resulting mass lesion at an area that's unfortunately inopportune, being right next to the pancreatic duct and common bile duct. Patients are often older adults, but we are starting to see these neoplasms pick up in incidence and may be associated with a genetic predisposition, such as patients with familial adenomatous polyposis or even attenuated FAP, along with Lynch syndrome, which is associated with mismatch repair protein deficiency. Before going into detail regarding these neoplasms, it's important to have really a solid foundation of the anatomic and histologic really features and landmarks of the ampulla itself, as I find these are one of the biggest pitfalls for a practicing pathologist to really go down the wrong road. And let's start really with what is the ampulla, which really is a complex anatomic region that represents a true junction of the duodenal, pancreatic, and biliary type mucosa. While multiple types of carcinomas arising from the duodenum, bile duct, and/or pancreas often extend into the ampulla, an ampullary adenocarcinoma must truly be centered on or circumferentially surround the ampulla to be regarded as an ampullary primary. And that honestly requires proper gross technique and examination to assess the tumor epicenter. And that all starts at the time of honestly receiving the specimen, which really honestly comes right actually at the point of time where it leaves the surgical field and the margins of resection are being evaluated by, again, that pathologist. The first step is to identify the uncinate process of the pancreas, really a landmark or a hook around the superior mesenteric vein and artery, and creates an indentation or notch on the pancreas called the vascular groove. Again, that uncinate process and vascular groove are extremely important in providing landmarks that we'll be dealing with in how to orient the Whipple specimen, and actually how to open it up along the ductal system to make sure we're actually identifying the appropriate ducts altogether. Now remember, the Whipple specimen itself comprises the head of the pancreas, a C-shaped loop of the bowel, and a portion of the bile duct. The gallbladder may or may not be attached to the specimen once received. When orienting the specimen, many pathologists liken it really to a right hand, with the thumb as the uncinate, fingers as the pancreatic knuck, and the recess between the thumb and index finger as the vascular groove. I use actually that vascular groove as a guide to identify my margins of resection. Present here is a picture of the pancreatic head from a Whipple specimen with the stomach to the left, the duodenum to the right, but obviously you're looking face at the the pancreatic specimen itself with an identifiable smooth surface, which is your vascular groove. The vascular groove is often a trapezoid in shape, where the superior mesenteric vein and artery often rest upon it. And so it's easily released typically when there's lack of involvement of those structures, but honestly just get dissected away by the surgeon, creating that nice smooth surface as opposed to the cauterized periphery around it. To the left of the trapezoid vascular groove is the pancreatic parenchymal margin that should have an eccentrically placed opening that corresponds to the pancreatic duct. The blue probe is within the pancreatic duct. And at the top of the trapezoid, again, that vascular groove is another opening that corresponds to the common bile duct, as shown here, and held open by the gold probe. Now, it's very easy to accidentally miss that bile duct and actually probe into a vascular structure. And therefore, putting that probe through the bile duct and then hitting the ampulla is imperative in making sure you are actually in that common bile duct. I've seen many people take an unfortunate pitfall in serially removing a vessel rather than the common bile duct margin. Lastly, to the right of the trapezoid vascular groove is a friable area that corresponds to the uncinate resection margin, which we won't take for frozen section, but important again as we assess margins in the permanent specimen. Now, understanding and visualizing these landmarks will make identifying the corresponding resection margins, especially the frozen section, much easier. Upon identifying the appropriate landmarks, the next step is to shave the pancreatic neck and bile duct margins. I first ask our staff to completely shave the pancreatic neck margin with at least 2 to 3 millimeters in thickness. There's often significant cautery at this margin and may require going somewhat deeper into tissue to get a good representation of the margin, but also important to make sure that tissue sticks onto that frozen section slide. Moreover, based on the new AJC 8th edition for pancreatic exocrine neoplasms only, cancer within a millimeter of a margin is considered to be a positive margin. Now, obviously, this is not relevant for ampullary-based lesions, but you never know what you're going to be dealing with until that specimen is opened, so why not be particularly important and sensitive to this area? Similarly, with the bile duct margin, we try to take the entire ring to include the surrounding soft tissue. In many instances, the gallbladder may not be attached to the specimen, and if not, 2 lumens may be present. One is the cystic duct, and the other is the true bile duct margin. Unfortunately, due to the difficulty in distinguishing between the two, when the gallbladder is not present, we actually take both the bile ducts as the bile duct margin for frozen section. So honestly, it's pretty easy for our surgeon to take another section of the bile duct going higher, closer to the liver hilum, if any of those margins and those rings are positive when it comes to the bile duct. So I don't really lose much sleep over that. Lastly, there are 2 types of Whipple specimens that may be received. First, there's the classic pancreatic duodenectomy that includes not only the duodenum, but the attached gastric pylorus. The second is a pylorus preserving pancreatic duodenectomy as pictured here. In cases of pylorus preserving pancreatic duodenectomy, we will also take that proximal duodenal resection margin. It's not too infrequent that a cancer involving the ampulla extends laterally, microscopically, to the proximal duodenal resection margin. Therefore, a positive proximal duodenal margin will alert the surgeon to remove the pylorus to ensure he or she has gotten around that cancer within this region. So very important to understand what type of specimen you are receiving and where are those margins overall. Now, while these margins are being frozen and sectioned, for which we evaluate 3 good sections for each margin that represent, again, at least 1 millimeter in thickness, another member of our staff will open up the specimen, typically the pathologist, first along the bowel contralateral to the head of the pancreas to identify any masses or lesions within the bowel and obviously the ampulla itself. And then to enter 2 probes into both the main pancreatic duct and the bile duct. Once those ducts have been probed, the specimen is opened along the ducts with a long blade using a probes as a guide. Sometimes I might even stick 2 probes into each duct and put that blade right between each set of probes that are paired together, making sure that I stay within those ducts themselves and never skive left or right or away from the ductal system altogether. Slicing the specimen straight into a half, until that literally you have a bisected specimen, opening the specimen, giving that pathologist the time or really the idea of where that mass lesion is with respect to all the anatomic landmarks while all the frozen sections are being done. In other words, are we dealing with the neoplasm arising from the pancreas, bile duct, ampulla, or small intestines, and its proximity to the respect to the margins that have been taken for frozen section? It certainly lets me sleep a little better at night calling a margin negative if I know that the tumor is grossly far away from those margins. But importantly, this technique helps identify the epicenter of the neoplasm. And for the purposes of this talk, specifically, truly, is it the neoplasm arising from the ampulla, or is it actually extending into the ampulla secondarily, again, from the pancreas, bile duct, or rather the small intestine? Now, when open, the pancreatic duct and common bile duct should be clearly identifiable, and both ducts should merge at the level of the ampulla. If they don't, this is known as actually pancreatic divisum. That should be documented within the subsequent gross report. The case shown here is really a normal specimen for reference. But when it comes to ampular neoplasms, actually many of them are exophytic, and it actually can be noted to be bulging from the ampullary orifice before even bisecting the specimens, actually at the time when you just open up the luminal GI tract, that being the duodenum and stomach if attached. However, I've seen many biliary and even pancreatic primaries present with a bulging major papilla. And so that's where it's still imperative to cut along the ducts, very sensitive to this position here. Hence why it's really important to really understand the anatomy of which that neoplasm is truly arising and where that epicenter is. Certainly, again, you can have a pancreatic cancer really presenting similarly, really undermining the ampulla and growing into the ampulla itself. But in this case, you can see that that exophytic lesion truly is emanating from the ampulla with dilatation or subsequent dilatation of the common bile duct and pancreatic duct due to obstruction. However, not all ampullary adenocarcinomas are exophytic. Some are endophytic, or rather ulcerated, and without proper grossing, it can be downright challenging to distinguish this case from a biliary or a pancreatic primary growing into and involving the ampulla itself. As further proof of cutting the ducts, really cutting along the ducts, a small intraampullary neoplasm can be easily missed without proper grossing skills. And again, I really harp on the fact that just probing those ductal systems, cutting the specimen, bivalving it completely all the way through the ampulla, not leaving it like a book to be opened at the hinges, but rather cutting through the specimen itself can really reveal a lot about what's going on with that neoplasm and where it's truly arising from. Can't be said for how important grossing technique is when it comes to these small sub-centimeter neoplasms found to be impinging upon the ducts, consistent again, in this case with the intraampullary adenocarcinoma. Now, as per the College of American Pathologists, and I know I'm talking to audience in Lucknow, but per cap, ampullary adenocarcinomas can be grossly subdivided based on location as intraampullary, periampullary, or both. And so again, this grossing technique itself really lends itself to being able to designate where the location of these neoplasms are, if they're intraampullary or periampullary, or do they encompass both areas altogether. Here's one last example of a subtle intraampullary adenocarcinoma where we slightly miss the epicenter, but it is wrapped around the ampulla and undermining the pancreatic ductal system, and in fact, growing underneath that ductal system overall. Now, not every ampullary adenocarcinoma is going to arise from the major papilla, and instead, this ampullary adenocarcinoma is actually centered around the minor papilla and growing laterally into the duodenum. But you really can't get that geography without, again, cutting along the ductal system, probing the system itself, and really examining this at the time of actually opening the specimen fresh, as opposed to fixing the specimen or inking the specimen and then losing all those important landmarks. And again, really proper grossing examination, obviously combined with microscopic examination, which I'll talk about in a second, are extremely important. But what is the actual extent of the ampulla? And I think that I get that a lot when I talk about the ampulla in the periampullary region, is that what is the definition of the ampulla itself? And honestly, and really it is arbitrary. It's based on what we've known for decades, maybe even a century. And per most investigators, the ampulla is arbitrarily defined as about 1.5 centimeters long and transverses the duodenal wall, opening into the duodenal lumen through typically the major duodenal papilla or major papilla, known as the papilla of Botter, excuse me. Of course, minor papillary ampullary adenocarcinomas can occur, and although they're actually quite rare, and often actually those minor papillary adenocarcinomas typically occur in the setting of divisum. But that being said, microscopically, the ampulla, and that being either the major papilla or minor papilla, are composed of prominent papillary folds with epithelium that transitions from intestinal type, that being the duodenal surface, to foveal-like mucosa with occasional goblet cells in the papilla region, really to eventually transitioning into a pancreatobiliary type epithelium as it goes deeper down into the ductal system. Now, small mucus glands and ductules underlie the mucosa with intervening smooth muscle, which is known as the sphincter of Oddi. Now, I hate really examining the ampulla at high magnification because it looks so busy when I look at it, especially on biopsies. But even surgical resection material looking at the ampulla, when you look at it at high power, those subepithelial ductules maintain really a very disorganized lobular appearance that can be easily confused or misconstrued as an infiltrating adenocarcinoma. And I can't tell you how many times I've seen a consult where a patient had maybe a pancreatic ductal adenocarcinoma and a pathologist took another section of the ampulla, which they should, and they're concerned that was there something pathologic occurring in the ampulla, whether it be dysplasia or even potentially a malignancy. But it's important to understand that reactive processes do occur in the ampulla and can look highly atypical from an architectural perspective. So it's essential to not only evaluate the architecture, but really the cytologic features in parallel when it comes to the ampulla, especially when dealing with biopsies of the ampulla. which leads us to really the microscopic findings of adenocarcinoma of the ampulla, where it's critical to remember that these neoplasms can arise from multiple lineages, such as, again, the intestinal, pancreatic, biliary, and easily can be found to have mixed histologic patterns. It's also imperative to look for precursor neoplasms, such as adenomas and intraampullary papillary neoplasms. And with multiple lineages, it makes sense that microscopically these adenocarcinomas can be subdivided into typically 3 types: intestinal, pancreatobiliary, and mixed neoplasms. Intestinal type adenocarcinomas typically arise from the superficial mucosa of the ampulla, which makes a lot of sense, very mimicking that duodenal type or small intestinal type adenocarcinomas, and adopt a columnar appearance with invasion that are characterized by elongated nuclei, scattered goblet cells, and sometimes even Paneth cells. In this case, one can appreciate the cytoplasmic clearing of the foveolar type epithelium, as pointed out by that white arrow, and then rare goblet cells by the yellow arrow. In comparison, the pancreatobiliary type often arises more intraampullary and often deeper down in the ampulla itself. Again, that's where that lineage, that pancreatobiliary cell type lineage, is present and makes sense, often having really the majority of the neoplasm being intramural in the ampulla itself. And characterized by cuboidal but pleomorphic cells. They look uglier, forming smaller glands, complex architecture, sometimes cribriform architecture, in a background with or without desmoplastic stroma. There are many times that a pancreatobiliary type adenocarcinoma has very little stroma itself and can actually mimic a dysplastic lesion when in fact it's really an invasive adenocarcinoma. Now, there also exists that mixed type ampullary adenocarcinoma, which shows a combination of, again, intestinal and pancreatobiliary type epithelium, as the name would imply. However, often the mixed type is really pancreatobiliary type with multifocal areas of really intestinal type areas itself. But subtyping, honestly, isn't always easy or straightforward, and therefore many organizations, and even the National Comprehensive Cancer Network here in the United States, advocates for immunohistochemical subtyping as a potentially improved or rather objective methodology of stratifying these types of adenocarcinomas. Immunohistochemical subtyping is based on a relatively large study done at Memorial Sloan Kettering, probably about now a decade ago, that defined intestinal type adenocarcinoma as positive for the intestinal markers such as CK20, CDX2, or MUC2, but strictly negative for MUC1, typically a pancreatobiliary marker. Alternatively, if MUC1 is positive, but all 3 intestinal type markers are positive, then the adenocarcinoma should be classified as intestinal type. In contrast, pancreatobiliary type is positive for MUC1, but negative for CDX2 and MUC2, irrespective of CK20 staining. And lastly, all other combinations, including quadruple negative staining, which is extremely rare, are considered to be ambiguous. Now, many authors have argued that this methodology is flawed. However, no one has presented an alternative, and it's been a decade since then. And so I'd have to say that, unfortunately, we don't have anything better. But I would say that there are a significant subset of ampullary adenocarcinomas that I would have thought would be intestinal type by histology, but are classified as pancreatobiliary by immunohistochemistry. And that ambiguous group can contain close to 15 to 20% of ampullary adenocarcinomas, depending on how well your immunostains are working in your lab and their specificity. Honestly, antibody clones themselves can show different results. So it's not perfect, and I don't blame Memorial Sloan Kettering nor Emmett Tubb, as he wasn't actually even there in 2014. He was still in Brigham. But nevertheless, we have really nothing better. But it does offer some methodology to really benchmark how we eventually evaluate these patients. And then eventually studies will come out that includes other ancillary studies, and hopefully one day subtyping will be improved. But importantly, why subtype? And that's probably the crux of the matter. Well, classic literature states that intestinal type ampullary adenocarcinomas are associated with a better prognosis as compared to pancreatobiliary type adenocarcinomas. Now, one could also argue that the prognosis of both types, especially with lymphovascular invasion and positive lymph nodes, perineural invasion, etc., is bad overall. And in fact, ampullary adenocarcinomas are not a well or improved prognosis compared to other GI neoplasms. But there is something to be said when it comes to treatment, and specifically first-line treatment. For intestinal type adenocarcinoma patients, often these patients will receive a colon-specific regimen, such as Folfox or capecitabine with oxaliplatinum. But for pancreatobiliary neoplasms or adenocarcinomas, our oncologists try to be more aggressive with a pancreatic adenocarcinoma regimen or type regimen, such as modified FOLFIRINOX or GEM plus CAPE. Certainly, all patients are treated aggressively. It's an aggressive cancer, but as this disease can affect older patients, often these patients have other comorbidities. And after a major procedure, such as a Whipple procedure, we don't want to be too aggressive with management such that it really impairs their ability to get adjuvant therapy, especially when we don't have to. Now, lastly, it's also important to mention that mixed type adenocarcinomas are often treated similar to pancreatobiliary type adenocarcinomas for the same reasons I mentioned before, that mixed type adenocarcinomas are often predominantly pancreatobiliary and only a minority of intestinal type areas are present. But subtyping an ampullary adenocarcinoma is only really half the battle. The next challenge is staging the cancer, which is not necessarily intuitive and differs from the small intestine and more importantly, the colon. The ampulla is a very complex structure, as I mentioned, and doesn't have simplified layers that we expect from the rest of the luminal GI tract. And the pathologist that I've at least dealt with often find it troublesome staging these neoplasms appropriately, primarily those neoplasms that straddle gray areas as actually defined in yellow between various T stages, such as those between T1A to T3B, can prove to be significantly challenging. But focusing really on, I guess, a systematic approach, it actually gets quite simple. So let's first focus on T1A adenocarcinomas. These neoplasms are actually limited to the ampulla, or more specifically, the sphincter of Oddi, with an absence of invasion past the sphincter of Oddi laterally and have not permeated through into the duodenal submucosa. Perisphincteric and more often duodenal submucosal invasion is really the fine line between a T1A and a T1B ampullary adenocarcinoma. But identifying that interface between the sphincter and the duodenal submucosa can be challenging, as the muscle often separates into thin bundles as it approaches the submucosa. An equally challenging area is defining a T2 ampullary adenocarcinoma that extends into but limited to the duodenum. It's important to note that the duodenal mucosa can often be disorganized, even separately or separated by variable sized globules of pancreatic tissue, but should not be confused, honestly, with pancreatic parenchyma. Remember, the development of the pancreas is a very much a multi-step process where you can have ectopic pancreatic tissue, and it's not honestly surprising where you can have what I guess you could say is ectopic pancreatic parenchyma stuck in the ampullary wall itself, and that even being the duodenum muscularis propria. So it's important not to overstage these patients, and then looking at those splayed layers of duodenal muscularis propria. That is also important in determining if the adenocarcinoma has entered the pancreatic parenchyma, which is one of the features of a T3 neoplasms. Now, T3A adenocarcinomas are defined as those that invade the pancreas, but up to 0.5 centimeters in depth of invasion. The difficulty here is that the pancreas can be atrophic. Hence, it's important to really be clean and clear when you cut those cross sections of the ampulla. Again, really, this can be facilitated by cutting along the pancreatic and bile ducts, as shown here again, where you can get really a nice ampullary cut, but only when you're really cutting through the ductal system. Again, by probing it, nicely opening up the specimen, bivalving it into two sections, and then getting nice cuts of the ampulla to show its proximity and its invasion into the pancreas, biliary system, and whatnot. Finally, it's important to appropriately measure from end of the duodenum down to determine if the adenocarcinoma is a T3A, limited to 0.5 centimeters or less, and that includes invasion into the pancreas, or does it go beyond that? Now, a T3B adenocarcinoma would also be defined as a neoplasm that extends in the peripancreatic soft tissue, or maybe even the periduodenal soft tissue and or serosa. So not only going past 0.5 centimeters, or it could be just the peripancreatic soft tissue laterally, or periduodenal soft tissue itself. Finally, similar to pancreatic ductal adenocarcinoma, a T4 is categorized when the cancer has directly invaded major arterial vessels, such as the celiac axis, superior mesenteric artery, and or the common hepatic artery. Rarely will you ever see a resected T4 ampullary adenocarcinoma, as these are often unresectable to most surgeons without significant, really sometimes morbid procedures that have to be done in order to take out these major arterioles and arteries themselves. That includes typically a vascular jump graft or anastomosis. And so I don't expect you to see these very often as far as T4 neoplasms, and when they are there, they're pretty obvious. Now, in addition to the issues that I mentioned with regards to T-staging, additional problems that may be encountered are when staging in the presence of an intraampullary papillary neoplasm, or an IAPN, that almost always has an associated invasive adenocarcinoma. These neoplasms often fill up the small ductules of the ampulla and as a precursor can involute and grow downward into the biliary and pancreatic ductal system, and are characterized by both tubular and papillary growth patterns. The old name for these neoplasms was intraampullary tubulopapillary neoplasm, but that was way too long. And so the authors wanted to cut it down, that being the WHO authors, and we cut it down to intraampullary papillary neoplasms to mimic, again, the nomenclature of IPMNs, like intraductal papillary mucinous neoplasms, or IPMBs, intrapapillary neoplasms of the bile duct, and so hence IAPN. The oddity of these neoplasms is that the invasive component of the adenocarcinoma can often grow, honestly, in the wrong direction, defying gravity. By really that wrong direction, I mean they can actually grow upwards to the surface as opposed to downwards deep in the duodenum. And it's an odd way of staging these neoplasms, but again, you have to stay true to the HACC, where you basically determine the T stage based on the layers of involvement and the depth of invasion overall. These adenocarcinomas, like their other intraductal counterparts, that being IPMBs and IPMNs, can give rise to an invasive adenocarcinoma that has mucinous features, maybe even sometimes even mimicking a colloid carcinoma. And there's some thought these neoplasms may be more indolent because of that. However, in my experience, they're just as bad as your conventional intestinal type adenocarcinoma overall. The real problem with these neoplasms is also their ability to grow into the ductal system. They can colonize like the bile duct above or the pancreatic ductal system below in this photomicrograph, where the invasive component is limited to the superficial pancreatic parenchyma on the left, but the precursor neoplasms are literally traveling down both ductal systems, extending downward significantly more than the invasive component. Now, again, staging these neoplasms is strictly based on the invasive component. And if they invade actually from another area of the precursor neoplasm, maybe that's in the pancreatic or ductal or biliary systems, they're still called an ampullary primary and would be staged based on exactly where they're located. So if that's an intraampullary neoplasm that's extending into the bile duct or into the pancreatic duct and doesn't have an invasive component till it hits the pancreas or bile duct, well, it's then staged based on where it's located. So if it's in the pancreas and it's going past 0.5 centimeters, it's theoretically now a T3B, even though it could be very microscopic disease. Finally, with regards to end staging, this is also quite different, and in my opinion, gets right at it back really significant amounts of, honestly, clinical data that subdivide the N category into N0, N1, and N2 with involvement of 1 to 3 regional nodes at N1 and N2 with 4 more lymph nodes. This is interestingly very different from small intestinal and obviously colonic adenocarcinomas. The tipping point for small intestinal is not 4 for N2, it's actually 3. And I think a lot of investigators, or rather pathologists, I should say, accidentally misstage these ampullary adenocarcinomas because they're accidentally using small intestinal systems altogether. And of course, colonic systems are the colonic system itself is very different. And I don't think many people would make that problem or actually fall through that pitfall itself, knowing that it's N1A, N1B, N1C, N2A, and N2B itself. Now, I think my time is running out, so why don't we end up by finishing up this case that I started with my talk. And if I can remind you, a 52-year-old male presenting with heartburn, nausea, vomiting, and weight loss despite being on Ozempic, that was found to have a mass that had an epicenter within and around the ampulla, microscopically well circumscribed with a pushing border into but not through the duodenal muscularis propria, and consistent with a glandular neoplasm with a paralymphoid cuff at the leading edge along with the syncytial growth pattern. Based on the data I've given you in other areas of the adenocarcinoma, including immunochemical stains, which I'll get into, the resection specimen was diagnosed as an ampullary adenocarcinoma, 2.3 centimeters in greatest dimension. The adenocarcinoma was weakly positive for CDX2, CK20, and rare positivity for MUC2, but negative for MUC1, therefore classified as intestinal type, and limited to the duodenum, and therefore staged as a T2 neoplasm. Interestingly, perineural lymphatic and venous invasion were absent, and all 23 regional lymph nodes were negative. So overall, T2 and 0. So basically the case stops there. No, not really. Now 3 years have elapsed, and the patient has developed, interestingly enough, an ascending colon cancer. And the patient gave us a little more history. That his mother and brother both also had colon cancer. And so that gets very interesting based on the case that I presented, where an astute pathologist that's actually signed up both the ampullary adenocarcinoma and then eventually that surgically resected ascending colon cancer noticed something interesting. And we've learned more and more about these types of neoplasms in that tip-off, where you had that pushing growth pattern, the syncytial pattern. I know a lot of people are probably understanding where I'm going to get with this, in that knowing that the patient has a history of colon cancer now and a family history, one questions whether this patient may have Lynch syndrome. And that is associated with loss of the mismatch repair proteins. And in this case, a panel of mismatch repair proteins were done that includes MLH1, PMS2, MSH2, and MSH6, with loss of staining of MLH1 and PMS2, while there was preservation of nuclear staining for MSH2 and MSH6. The patient subsequently underwent MLH1 germline testing and found to have a germline alteration in MLH1. So very interesting overall. The patient did actually have Lynch syndrome, which may not be as surprising as it sounds, because many patients with ampullary adenocarcinomas can present actually as initial event of Lynch syndrome. And in this case, the patient did present initially with Lynch syndrome. Honestly, at our institution, any luminal GI tract adenocarcinoma, and I know this is very aggressive and maybe in some consideration wasteful, but we do mismatch repair analysis, honestly, universally for anybody that has a luminal GI tract cancer. Now, it's done mostly for treatment because many of these cancers are advanced and these patients will often recur, and we know that. But we also do it obviously for another purpose, and that is Lynch syndrome screening. Another antibody that we often use, especially with advanced ampullary adenocarcinomas, because we know that they're associated with poor prognosis, is HER2 testing. And so HER2 testing, honestly, we find it very useful. About 10% of our ampullary adenocarcinomas have an ERBB2 or HER2 3+ positivity. And we do that simply with early FDA-approved HER2 immunostain, in this case, the Roche Ventana product itself on a Ventana autostainer. But there are obviously HER2 2+ cases, and we reflex those for FISH testing, and that being the ERBB2 probe shown in red with centromere 7, with the probe 17, excuse me, a probe covering chromosome 17 in green. So my time is a bit up, so I'd just like to summarize. Ampullary, periampullary, and pancreabiliary neoplasms should really carefully be evaluated by combining both a gross and microscopic evaluation. Now, I'm sure many of you have different methods that you've used or even read about to open up a Whipple specimen, but I find that really opening up the specimen along the ductal system, determining where a neoplasm is really the epicenter of, can really help in defining the next steps for that patient and really determining what neoplasm that patient has. Here in the United States, we're having a lot of trials that are based off where that neoplasm is truly arising from. And I find that to be definitive. I find it best to be doing it by really gross inspection first and then microscopic evaluation later. Now, in addition to determining the extent of disease, it's important to subtype an ampullary adenocarcinoma, and I've talked about intestinal, pancreabiliary, and mixed types. I do think that those are evolving in what we'll use as biomarkers for them, and that actually could be molecular alterations going forward, but we're not currently there yet. Staging of ampullary adenocarcinoma is very different from small intestinal colonic adenocarcinomas, and I hope you don't make that pitfall, which I've seen many pathologists do, especially with the N2 category. But understanding that the T staging can be very specific and is very important to get really good sections. And again, I'd like to just harp again on that gross inspection, where it's really important to really bivalve that specimen and get really good ampullary sections overall. And then similar to other types, we now have actionable targets. And it's hard to fathom that 5 years ago, we didn't have these, which not only include mismatch repair and HER2, which I've discussed, but now we're seeing an evolution of BRCA testing, POLB2 testing, KRAS, G12C, and other KRAS inhibitors that are coming down the system. And so I think that in the next couple of years, it's a very exciting area, an exciting area of really trials, research, and actually clinical implementation. And with that, I'd just like to thank again for the invitation to speak today. And I'll talk to you all during the Q&A session later today. Thank you.
So Dr. Atur is not online, so we'll be meeting him online.
Thank you again for the invitation to speak today. Apologies that I could not be there in person.
I think his talk is finished now. His talk is finished now, no? Okay. So we'll be taking his questions and meet the expert at 5, and we'll acknowledge him at that time. So now I invite our next speaker. We are Dr. Prasenjit Das. So he's professor in Department of Pathology at AIMS. He's a great researcher, has 457 publications, high quality publications to his credit. Has got many awards, and he's recently has published a book, it's a very base book, textbook on surgical pathology of the GI system. So he has got all research areas, GI pathology, all specialties of GI pathology. So we'll be talking on colonic biopsies, inflammatory bowel disease, case-based discussion, because as we know, this is a very challenging area in small biopsy diagnosis. Yesterday also with Dr. Amitabh, we were discussing in the department how to go about small biopsies for inflammatory bowel disease. So I think Dr. Prasenjit will be clarifying all these issues. Okay, over to Dr. Prasenjit.
So thank you, Professor Jain, Professor Vinita, and Dr. Neha for giving me this opportunity. And it is already late, but let us see how to make it more interesting. So I'll be covering some of these topics, and we'll show some cases how to approach the small intestinal biopsies. So let us start with what is the normal histology of colon on the mucosal biopsies that we will see. And almost all of you know how the normal colon look like when it is oriented, when it is not properly oriented. We all know we can compare the crypt arrangement with rack of test tubes. They are very evenly distributed and long crypts. This is the muscularis mucosae, and when it is not oriented also, then also you can see it is very evenly distributed. Now, when we say something, when a biopsy or the colon is inflamed, so for that, you have to divide the mucosa into two halves. This is the upper half, and this is the lower half. If it is a normal colon, normally we see lymphocytes and few plasma cells into the upper half. They are not really redistributed into the lower half. That is how the normal colon biopsy looks like. Unlike this one, where we are seeing, though the crypt arrangement is still preserved, but we are seeing the number of the inflammatory cells are more, and they have also redistributed into the lower half, then we'll say this is possibly inflamed. Now, what is the histology of the acute colitis? We all know acuteness or acute word we use when there is neutrophilic infiltrate into the epithelium. It may be cryptitis, it may be a crypt abscess, or there can be ulcers. So any of this, if they're present, then we call that, possibly if the morphology or the crypt architecture is preserved, we call that it is acute colitis or acute infectious type colitis. Also, we should not, as a pathologist, we should use this term. So, but this is also many pathologists report that it is a acute self-limiting colitis, but we don't. And when we say that the colon is chronically inflamed or the inflammation is chronic, so then we'll see this is the biopsy. What is the most important finding? We are not seeing that even distribution or even arrangement of the crypts, and we are seeing there is unevenness. There are areas of crypt loss. The crypts are branching. The crypts have become shorter. Normally, they reach up to the muscularis mucosae. Here you are seeing the short crypts. So, and there is also inflammation in the background that we have already seen. So, if we see this type of appearance, we say that it is possibly a chronic colitis. So these are all features of chronic colitis. And in addition, we can also see various types of metaplasias into the chronically inflamed colon. But many a times we see both the features of chronicity and activity, they are present together. And we call that it is a chronic active colitis or acute and chronic colitis. And this is the basic minimum requirement what we identify to entertain some of the differential diagnoses like inflammatory bowel disease, tuberculosis in Indian subcontinent, it must be a differential diagnosis. Now, this type of appearance can be caused by various other persistent inflammation like Shigella, Salmonella, all these inflammations. And in other diseases like chronic ischemic colitis, microscopic colitis, radiation-induced changes, and nowadays you cannot forget the drug-induced enteropathic syndromes. But you can ask me, what are the features on mucosal biopsies what differentiate between an IBD and non-IBD type of chronic colitis? So chronic active colitis like feature is a minimum requirement. But one of the most important feature what pathology stresses on is the presence of basal plasmacytosis, which is defined by either presence of a band of plasma cells below the shortened crypts, or at least 5 clusters of plasma cells below each crypt. At least 2 of these clusters should be there. So to call it a basal plasmacytosis. And it has been seen that if you see eosinophilic cell infiltrate along with the background chronic active colitis like features, these features are usually commonly seen in IBD like colitis. And if the segmental biopsies are usually taken, it is said that if you are seeing in 3 or more of this anatomical site biopsies, then the possibility of UC is further very high. In Crohn's also we can see basal plasmacytosis, but that is usually focal or not present. Now, basal plasmacytosis was highlighted by this British Society of Gastroenterology in 2013, and they said that in their study, it is one of the earliest feature of IBD. You can see within 2 weeks of development of IBD, when the architectural distortion is also not there, and it is one of the important, strongest predictor of IBD you can rely on. But please remember that those subsequent many societies like Italian societies and some of the American societies also stressed on the presence of basal plasmacytosis for diagnosis of IBD. We do not see many publications based on that. So we thought, let us do a systematic study to see how this basal plasmacytosis and eosinophilia that helps us based on the published literature to differentiate between IBD and non-IBD type colitis. You can see that among the large number of the articles screened, only 5 were found which focused on these typical features of basal plasmacytosis and eosinophilia. And based on the published literature, we did not find that it is a significant finding which can differentiate between the IBD and non-IBD type of colitis. But as a pathologist, we know that it actually helps. That was followed by another study by us. We found that now you can see that this is IBD type colitis and a non-IBD type colitis. We included intestinal tuberculosis because it is the most common type we commonly see. And you can see the mucosal basal plasmacytosis really helps in many instances to differentiate an IBD and non-IBD type colitis. And if you see eosinophils along with basal plasmacytosis, that also helps to ascertain that if it is IBD type of colitis or not. Please remember that only presence of eosinophilia when basal plasmacytosis is not there is never specific for inflammatory bowel disease. So now we know that to call something as IBD, we at least have to have the architectural distortion, neutrophilic activity, and there is basal plasmacytosis, and if eosinophils are identified, that will also help. Let us see some cases. So this is a 32-year-old male biopsy from the ascending colon. For us, the biopsies are but the history is actually very crisp and short, always. And that is better for me to write here. And you can see this is the biopsy fragment, what we got. So what do you think? It is IBD or inflamed or it is normal? So let us apply those questions and those criteria. If the mucosa is inflamed, we have to ask. We'll divide the mucosa into two halves, and we can see there is a lymphoid aggregate, some inflammatory cells. They are not really redistributed in the lower half. Then we'll ask another question, if the architecture is normal or not. And we know that they're evenly distributed, the architecture is normal. So we interpreted this as ascending colon biopsy within normal histological limit. Case number 2, this is a rectal mucosal biopsy. The endoscopically there were erythema, and the endoscopist asked us query IBD. What do you think? So here also we can see there is a lymphoid aggregate. We have to be vigilant when you see lymphoid aggregates in the left of the colon, but it is not always diagnostic. Let us apply the same questions and criteria. There is some redistribution, mild inflammation we can say, but architecture is predominantly maintained. But as we went to high power, we could see some of the polymorphic infiltrate. Polymorphs you can see both into the lamina propria as well as they are infiltrating the surface epithelium and the crypt epithelium. So what would be our interpretation? Architecture is normal. It is mild inflammation with neutrophilic infiltrate. So we reported it as possibly this is acute self-limiting colitis or active colitis or acute colitis. This is case number 3. Patient presented with colic abdominal pain, ileocecal biopsy was taken, and we were asked, query it is CD, query ITB. So what do you think? If the mucosa is inflamed or not? The same questions, architecture, and we have to determine if the mucosa is inflamed or not. Any thought? It is inflamed, looking like it is inflamed. Some of the focus, we can go into high power and we can see that it is really inflamed. There are lymphoid aggregates, there are a lot of inflammation. The architecture is not really normal, and we can see neutrophilic exudate also. So it is also features of activity is there. So we can say it is chronic active ileitis, at least in this focus. Now, we have to also ask really into the small intestinal biopsies when you are getting multiple biopsy fragments, are the changes are diffuse or patchy? So let us look in these biopsy fragments. We can see we have already seen these areas were showing chronic active ileitis like changes, but look at the other fragments of the ileum. They are relatively less involved. The inflammation is less dense. The architecture and distortion is also less prominent. So what should we call? This is a diffuse disease or this is a patchy disease? So this is a patchy one. So we thought it is a patchy chronic active colitis, but please remember, not in all cases we can give a etiological diagnosis. Especially in this case, we did not find any microgranuloma, macrogranuloma or other changes. That's why we said it is a patchy chronic active ileitis. We cannot tell you the etiology. Kindly investigate further for the etiology. Let us see another biopsy, similar history, ileocecal junction, query ITB, query CD, and in the low power, we can say that it is inflamed, part of the less inflamed, the other areas are more inflamed with architectural distortion. Possibly this is an area of exudate and ulceration. So chronic active ileitis is definitely there. This is the higher power. You can see this part is more inflamed. This part is slightly less inflamed. This is the ulcerated. So possibly, again, we are seeing patchy chronic active colitis. And here the other fragment, which is ulcerated, this area is pale, we'll see later. And look at the crypts into the preserved areas. You are seeing, what you are seeing here? Kind of metaplasia. So what is this metaplasia? Panaxial metaplasia, that is also a feature of chronicity other than the architectural distortion. So this is chronic active ileitis, and that is possibly patchy. And this is the pale area on high power. What we can see, this is a large epithelioid cell granuloma. There is not only one. This is also epithelioid cell granuloma. These are the other focus. We can see there are multiple large epithelioid cell granulomas, and the granulomas are coming close together, what we call confluent granulomas. So these are actually patchy chronic active ileocolitis with confluent granulomas. Let us go through some of the differential features or common features of Crohn's and TB, because that is the most common questions we always get. So both of these diseases, the question is always query CD, query ITB, because they both most commonly involve the ileocecal junction. And also the rectum is not uncommonly involved by both of the diseases. So you can say more or less they involve the similar areas. And in most of the biopsies, we see chronic ileitis-like feature with activity. These are again patchy changes, more inflamed, less inflamed. This is again architectural distortion. These are the again other areas, less inflamed, more inflamed, features of activity. Sometimes ulcers in both the diseases can be deep burrowing ulcers or rail tract like ulcers, and they can go into the muscle, and they can sometimes also perforate. Crohn's perforate more. They form more fistulas. Their features of chronic active colitis, basal plasmacytosis. Please remember, the one caveat we have to always remember that basal plasmacytosis sometimes physiologically can be seen at the ileocecal biopsies. So if you are not getting segmental biopsies, just you cannot pay too much attention to the basal plasmacytosis only in the ileocecal junctional biopsies. If you are getting segmental biopsies, you can look at the other areas and decide if basal plasmacytosis is present in other areas or not. So this is one caveat you have to remember. In both the diseases, we can see deep inflammation into the deeper layer. We can see fibrous strictures. But most importantly, what differentiates them? We have to remember these typical terms. One is large granulomas or macrogranulomas. We have one size more than 400, 500 micrometer in size, but you can at least say if the granulomas are more than a diameter of a normal intact crypt or not. Those are macrogranulomas. So the features which can differentiate if you are getting macrogranulomas, if you are getting macrogranulomas in the deeper layer of the intestine, if the granulomas have lymphocytic cuff, if you are seeing more than or at least equal to 5 granulomas, then more number of granulomas, chance of being tuberculosis is high. Okay, and giant cells though can be seen in both, but in tuberculosis we see more number of giant cells. So you will say tuberculosis based on these features. If you are seeing large granulomas into the deeper layer, confluent granulomas, if you see necrosis, possibly this is tuberculosis only, more giant cells and more number of granulomas, again chance of being tuberculosis is high. In Crohn's disease, all of you know, in 20-30% cases, up to 20-30%, we can see some granulomas, but in Crohn's granulomas, they are usually smaller, seen in the mucosa, just next to an intact crypt. We call that non-cryptolytic granulomas. And these granulomas, unlike tubercular granulomas, they're ill-defined. They're formed by epithelioid or normal histiocytes and inflammatory cells, but less circumscribed, okay? So these are pericryptal microgranulomas. Microgranulomas can also be seen in the tuberculosis, but they are usually relatively well defined. And if AB is positive, then it is tuberculosis, obviously, but positivity is very low because intestinal tuberculosis is a paucibacillary disease. So what is the diagnosis in this case? Look at these different colored words because these are the terminologies we should use. So this is a patchy chronic active ileocolitis with multiple large confluent epithelioids and granulomas in the submucosa. Features are favoring of ITB. So that was the diagnosis in this case given. But please remember, in Crohn's disease also, this is the Crohn's and this is tuberculosis, we can see macrogranulomas in few cases. So there will be some scenarios when the patient is phenotypically Crohn's, but you can see large granulomas. But in practice, most of the cases, in 90 to 95% cases, large granulomas, if you see, first possibility you have to suggest favoring tuberculosis. Later, if the patient don't respond to ATT, the diagnosis can be reversed on for subsequent MDT. So that is very important. And it is also important to know the site of biopsies and the number of the biopsies. We are highly dependent of the biopsies where from it is being sent. Look at this area of the ileocecal junctional mucosa, and this is the XI specimen. You can see if the biopsies are taken from this area, will not see anything. If the biopsies are taken from this ulcerated area, where you are seeing deep ulcers, and the granulomas are also more condensed in that area, okay? So you are seeing so many granulomas in this area. So if a biopsy is possibly taken from this area, so you are possibly going to get those granulomas on mucosal biopsies because these are very superficial. And if they're taking from the other areas, then possibly will not see the granulomas. And it is always said that now, number of the biopsies are very important to differentiate tuberculosis, identify tuberculosis. Normally, it is recommended to take 6 to 8 mucosal fragments from these areas. That will help you to identify more number of granulomas, and also some of the fragments can be sent for the other ancillary tests like culture. Case number 5. This is a patient present with rectal bleeding and tenesmus. Multiple colonic biopsies were taken. And you can see this was a segmental biopsy. And most important, we know this is a chronically inflamed colonic biopsies, and all fragments are almost equally involved. So based on these findings, we can say that this is not patchy. This is possibly a diffuse chronic colitis. Okay. And let us see in high power what we are seeing. So there is architectural distortion, crypt loss, and look at the basal zone. We are seeing lymphoid aggregates. Lymphoid aggregates into the basal zone near the muscularis mucosae is another feature of ulcerative colitis, but that is not very dependable. But if you see in the other areas, you can see the basal plasmacytosis, and here you can see better both the eosinophilia and basal plasmacytosis into the zone, and it is a diffuse disease, chronic active colitis. There are ulcers. There is no granuloma. So we can say that this is a diffuse chronic active, sorry, it is my mistake. This is a colitis with basal plasmacytosis and mucosal eosinophilia. The features we are favoring of ulcerative colitis. So that should be the wording we should use. We all know how to differentiate UC and Crohn's. In UC, we always see a right to left gradient. The left colon is more commonly involved if you go from the ileal areas. And in the Crohn's disease, we know that disease can be patchy. We have already seen that. And this is the differentiating features already we have talked about. But it is also important to know that neutrophils, presence of neutrophils and identifying an IBD is not sufficient. Neutrophils also we have to grade. That is an activity for us. And presence of neutrophil also, correlates with the fetal calprotectin positivity, endoscopic presence of erythema ulcers, and histologically also basal plasmacytosis. Because basal plasmacytosis in more commonly has been identified in active IBD. There are many scoring systems which is available. GBOY score is very well validated and can be used for the clinical trials. But for routine use, Nancy index we commonly use because this is very easy to use. On the other hand, DCS score, which has been reported of late in 2020 or so, there are 3 features which rely on. One is diffuse pattern of if the disease is diffuse or it is very patchy, less than 50% or more than 50% of the all segment involvement. Then chronicity. Chronicity means either mild crypt distortion or there is marked lymphoplasmacytosis C2 like this, and activity. Are there neutrophils in the lamina propria or presence of crypt abscess or ulcers A2? So like this. So in our case, what should be the grading? After writing all this, we have to grade, we know. So the activity score, histological activity, it is Nancy's grade 4 because there is ulcer, and it is DCA, diffuse involvement D2. It is C2 because significant lymphoplasmacytic infiltrate, and there are presence of ulcers. So it is activity 2. So thus it should be graded. Let us see case number 6. This is 42 female presented with abdominal pain and multiple ileocecal junction superficial ulcers. What you can see? Do you think this is tuberculosis or Crohn's or anything? So what are the findings? So these are the ileal fragments. These are possibly from the cecal area. Inflamed or not inflamed? So at least we can say that the cecal fragments or colonic fragments are possibly inflamed. There is some chronicity, some branching we can see. The ileal fragments are possibly not very much inflamed. This is the high power of the cecum, and this is the other fragment we can see. So it is a patchy colitis or patchy chronic active colitis. So would you jump to make a differential diagnosis of either TB or Crohn's? So what is your idea? So we also thought it is a patchy chronic active, but always we go into high power. and look for if there is any other etiology we can produce patchy chronic active ileocolitis like change. What we can see, these are the amoebic trophozoites. So this is just to give you an example how the features can be mimicking, okay? So this is the amoebiasis, which is presenting with acute chronic active colitis like change. This is another case, 53 male, so since 3 to 4 weeks, there is abdominal pain, presented with multiple ulcers, and we were asked query IBD. This is the transverse colon biopsy. What do you think? It is chronically inflamed or it is normal? Mostly it is looking like normal. This is the descending colon biopsy. What do you think? It inflamed or not inflamed? It is inflamed. It is chronic inflammation or acute inflammation. Somewhat chronicity is there. There are some crypts which are dilated, and we also identified some crypt abscesses and apoptotic abscesses. So this is focal changes, but look at the rectum. It was mostly ulcerated. Okay, there was no preserved mucosa, but we tried to see if there is eosinophils. That is not there. We tried to see if there are basal plasmacytosis. We could not determine if basal plasmacytosis is there or not. While we are examining and thinking if it is IBD or not, we found this type of inclusions. What is this? This is a cytomegalovirus inclusion, and it has to be confirmed by CMB stain. And always please remember, whenever you are identifying CMB and doing an IHC, try to say per segment biopsy means one biopsy is taken from one segment, or two fragments are taken from one anatomical area. You have to say if you are seeing more than 5 inclusions or not. That is very much important. That usually correlates with the CMB titer, and that helps in deciding the treatment. So this is the CMB inclusions. So this is not an IBD. This is a CMB colitis, and which is mimicking like an IBD. This is the 43-year-old male post-renal transplant presented with diarrhea. What do you think? Colitis, chronic colitis? Looking like there is crypt distortion, but look at this area. Eosinophils are not there. Basal plasmacytosis is not there. Crypt distortion is there. Here, what we could identify, there is a patch of mucosa which is totally devoid of any crypts. But what are lying there? There is the crypt basal cells and the neuroendocrine cells. These clusters are only lying there. So what is the diagnosis? So this is in that typical clinical information. This is a feature of grade 4 GVSD. Okay, so not only the chronic active changes, you have to look at the other features, which is very important. If we talk about the mimickers, anything which can cause a mucosal regeneration in a background of mucosal damage in the form of neutrophilic infiltrate, that may mimic an IBD. Okay, that can be an infection, that can be a drug, that can be a chronic ischemia or anything. These are some examples I will just rush through. These are chronic ischemia, acute and chronic ischemia rather. You can see that there are features of crypt distortion here. This is radiation-induced colitis. You can see a lot of crypt distortion and activity is there. These are diversion colitis. You can see mucosal ulcers. Diversion colitis, one helpful feature is identification of this type of prominent lymphoid aggregates into the mucosa and submucosa. But here, basal plasmacytosis is usually not seen. This is a CVID colitis, and you can see just neutrophilic activity and all you can identify along with prominent lymphoid aggregates into the small bowel. So this is another mimicker, but most importantly, you should not forget drug-induced colitis, which can mimic an IBD, especially mycophenolate and immune checkpoint inhibitors. Nowadays, we should not forget. So whenever we are seeing chronic active colitis like changes, always look at the form. We usually don't get the history, but we usually, in all discrepant cases, MDT is done. That's why we came to know. This is one case, but for 23 male presented with a recurrent large bowel type of diarrhea. What he will say, this is a chronic colitis or chronic colitis, looking like there is architectural distortion. But what is very important to identify, the other features are there or not. We cannot jump to a diagnosis of IBD. Let us look into this part. Though the crypts are short, the basal plasmacytosis is missing. There is not many eosinophils. But what we identified, all the crypts are showing prominent lymphocytic infiltrate, as well as there are apoptotic bodies. Can you identify this? So And we asked the clinician if there is any history of immune suppression or transplant. It was not. It was discussed in the MDT, but these features were very prominent, unlike conventional IBD. Then what it was decided to send for the exome sequencing, and what we found that it is CTLA4 gene mutation this patient is having, and this is actually a CTLA4 mutated colitis. CTLA4, so if you are giving a drug and blocking the CTLA4, you will see the same thing, okay? That's why drug-induced colitis is also, you have to remember, and CTLA4 gene mutation also predispose the patient to develop autoimmune inflammation and also IBD, and it can mimic a Crohn's disease. We have to remember that. This is possibly the last example. This is a 43-year-old female, and it was a referred case. She presented with recurrent hematochezia. The diagnosis was revolving around the Crohn's and ITB. She was symptomatic since 2 to 3 years of her life. She is 43 now, and it came from 2 hospitals where it was identified as Crohn's disease. And in our hospital also, one of our assistant professor thought it was Crohn's disease. See this section, we got 4 blocks. This part of the ileum is looking normal. This part is totally ulcerated, and there is a stricture. So it is an ulcerostricturing disease. So there is nothing wrong to think initially that it may be Crohn's disease. You can see some distortion. So you can also say, sir, this is patchy chronic active with strictures. I will agree to that. But what was very unlikely, why this patient was not fitting clinically into the Crohn's disease, because there was no increase in the inflammatory markers, there was no hypoalbuminemia, no signs of intestinal failure, no creeping fat, while the patient was having intestinal resection. The blocks I was showing, the intestinal resection was done in last year for recurrent hematochezia only. What was not medically manageable, then a resection was performed. So what is the diagnosis? In this case also, MDT was performed, and we said that though it looks like Crohn's, it is not fitting clinically into a Crohn's disease. Let us look back to the other blocks. If anybody can suggest what you are seeing, anything abnormal, these are the other blocks, not that block what I just showed. Anything? So you can see the mucosa is totally normal, but what is very abnormal? Look at the muscle layer. It is gradually becoming thinned out, okay? It is almost lost here. And you have to also remember that the intestinal wall has to be oriented, okay, to identify these changes. So looking like the muscle layer is rarefied. In SMA and Desmin stain also, we can see the muscle layer is lost. This is the internal control, muscularis mucosae. You can see that is present, normal. So this is the high power. You can see the muscle layer is possibly replaced by fibrosis. This is the high power. You can see it is rarefied, and there is fibrous infiltration, which was identified or confirmed on serious red stain. These are the collagen, which you can see infiltrating the muscle layer. We have to always remember that there are other things which can also cause intestinal ulceration, intestinal strictures. One of the paper will be presented by one of our assistant professors today. You can see that also has a genetic abnormality that mimicked Crohn's disease. And always remember, those ulcerations or strictures can also be caused by a myopathic disease, which is causing peristalsis since over the years, and that is causing bacterial overgrowth syndrome. So this is actually what we are seeing. This is an atrophic type of myopathy. There are 3 variants. The third variant, this is autosomal recessive, and only intestinal involvement is usually seen. This patient did not have any other symptoms. The urinary bladder was absolutely normal, okay? So then we decided to send for the exome sequencing, and what we found that it is actually a visceral myopathic pattern. The pathogenic variant was found that this is the actin, gamma actin gene 2 mutation. Okay. In myopathy, this type of familial visceral myopathy, you can see alpha actin, gamma actin, or myosin gene mutations. So this is a rare case where you could see the histological features mimicked Crohn's disease initially. So what is the diagnosis in this case? This is a familial visceral myopathy, atrophic type, with possible bacterial overgrowth syndrome at the IC junction. Please remember, though it looked very simple today, but we did a nationwide survey-based study where we could identify there is a lot of variability among the pathologists, and these are the pathologists who usually handle the GI biopsies, which comes with the diagnosis of query IBD. See, in all segments, you can see variability. So we have to follow an approach. What should be the approach? Like what we have seen today, we have to first ask if the mucosa is inflamed. Architecture we have to see. We have to decide if it is only chronic or chronic active. If we have to see basal plasmacytosis and eosinophilia are there or not. We have to then decide if it favors IBD or not favor IBD. Then always we have to correlate with the clinical, endoscopic, and radiological correlations, because it may be Crohn's to me. I have seen you example, it is not phenotypically Crohn's and not responding to treatment. That you have to always see. You have to see the disease is patchy or diffuse. We have to see if there are microgranulomas. If it is fitting into one of the types, you have to classify, or you can say this is unclassified. Look for associated infections and look for dysplasia, which I am not covering today. So as a pathologist, you have to always know and guide your clinician that it is always best if the segmental biopsies are separately labeled and separately sent to us. That is very important. It is also important for us to identify but to get the biopsies mounted on the filter paper. That is usually not done. Sometimes even in our institute, it increases the time, it increases the cost of the procedure, because that is related to the time. This also increases the cost in private setup. But if you get an oriented biopsy, we can see that you can identify the basal plasmacytosis very well, and it is always desirable. And also remember that where from the biopsies has been taken, we have to know, because it has been seen that if the biopsies are taken from endoscopic areas of erosion or ulcer or granular mucosa or erythematous mucosa or loss of vascular pattern, see how the identification of basal plasmacytosis and neutrophilic activities are varying. On the other hand, if you are taking only from an area where other changes are not there, only loss of vascular pattern is there, you will possibly identify less basal plasmacytosis. So for mapping, we have to get segmental biopsies from different sites, if possible, not always possible, but if possible, that is very desirable. And as a pathologist, you have to know that if you are getting separately labeled vials, then separate description for each site we have to give. Number of the biopsy fragment examined you have to mention. Are the changes diffuse focal? Basic histological changes of chronic active colitis are there or not? Additional histological changes, all we have discussed today should be described. Then you have to say, you have to mention everything in detail. Then you'll say it is favoring IBD or not favoring IBD, what is the type, and histological scoring you should not forget. Scoring is important also for the follow-up biopsies. We have to remember that if you are not doing scoring on the baseline biopsies, how to compare if it is improving or not. Look at how do we classify the follow-up biopsies. If the architecture is normal, has become normal, there is no neutrophilic activity, not much inflammation, we say that it is complete normalization. If we see the architectural abnormality is still persisting, there is not much inflammation or activity, we say that it is quiescent colitis. Or if we see along with architectural distortion, neutrophils are there, we say that it is active colitis. Please also remember that we have to follow this 5-tier system. It was described by Dr. Pai's group, and this actually helps, because in quiescent colitis, you have to also comment if basal plasmacytosis are there or not. If a patient has quiescent colitis with basal plasmacytosis, it is very likely that there will be an active clinical relapse in very near future. On the other hand, in a patient of quiescent colitis who don't have basal plasmacytosis, further complication or hospitalization is expected to be low. And in all cases of clinical flare and steroid dependent UC, we have to always do CMB IHC. Histology alone is not enough. or PCR if the facilities are there. So what we learned today, we have to have some criteria also that you have to discuss with the gastroenterology colleagues. When the endoscopic mucosal biopsies are adequate, as a segmental taken from the areas of mucosal pathologies as well as uninvolved region, at least 3 to 4 weeks after the symptom onset. That helps because I told histological architectural abnormality, that appearance usually comes after a month or so, and the biopsy fragments are oriented. Histological interpretation in those cases yield good result. What is needed? Mentioning the site of biopsies, separate labeling, endoscopic and radiological detail must be there. Important for pathologists, we have already discussed, we have to score, we have to do the CMB staining, we have to see if there is any other infections or not, and then we have to follow that particular approach and interpret. Histological evaluation of follow-up biopsies, everything will be same, but always please remember basal plasmacytosis present or not, that we have to always mention. But what I want to stress through the cases I have shown, not all chronic active colitis are IBD. There are many mimickers, and in many times an MDT meeting only can give you that that information that it is not clinically fitting and we need to do more. So with that, thank you so much for the opportunity again.
I'm sure it was a wonderful, wonderful explanation for all the complexities of ulcerations and Crohn's versus TB. We have such, very commonly we encounter such clinical problems. So you have given a wonderful illustration of how to go about methodologically to differentiate.
Yeah.
I'm really happy with that.
Actually, we are a guideline for pathology is coming. That is a collaboration between the Pathology Association, Indian Society of Gastroenterology, and Crohn's Colitis Foundation of India. That is coming very soon.
Thanks, Dr. Prasenjit, for a very nice lecture presentation, case-based. I think this has simplified and it's resolved many issues in the audience. One or two questions we can quickly take up, if any.
Somebody is online, I guess. Yes? Yes, it can coexist. See, many a time interferon anti-TNF blockers can also develop tuberculosis, and sometimes de novo also, both of them can be together. So for pathologists, it is very difficult to suspect both of these diseases together, but these informations will come up when the disease, there are necrotic lymph nodes or not. All these informations you have to discuss, the clinician will tell you, and these things are comes up only on subsequent MDTs. Yes, please. See, all other scoring system, what we discussed, Nancy, G-Boys, they were made for ulcerative colitis. So DCS score was somewhat validated on both UC and Crohn's. So you can use for routine purpose, you can use the same for both of them. So we commonly do Nancy for UC, and sometimes we do DCA if we feel it is Crohn's. The indeterminate colitis is a diagnosis on resection specimens. So if you are not able to classify, that will happen in many cases on biopsies. So then it always remain as unclassified.
Dr. Amitabh,
I just wanted to make two quick comments. We were talking to the trainees yesterday and emphasizing, and I said something like that diagnosis and management of IBD is a team sport. You cannot do it alone, right? So you're as good as your gastroenterologist is, and you're as bad as your gastroenterologist is. So all the features are suggestive. So even if there's a feature that's accurate or helpful 95% of the time, you're going to be wrong 5 times out of 100. And that's a huge risk in when you're saying IBD, because that diagnosis never goes away. If you look at good registry data from Germany, if you follow these IBD patients for a long period of time, 10% of the patients will have diagnosis change from UC to Crohn's or Crohn's to UC because the disease evolves over a period of time. But 5% of the patients will have diagnosis change from IBD to no IBD. And once you make a diagnosis of IBD, that never goes away. Those patients will be on surveillance for dysplasia diagnosis and detection. And it's very hard to change that diagnosis. So my suggestion is to have a very high threshold for calling things chronic colitis. The worst that'll happen is you'll delay the diagnosis. If it was an infectious colitis to begin with, and you say chronic colitis, and the patient becomes better after they started some treatment, then the diagnosis of IBD is established. And it's going to stay with the patient for a lifetime because infections resolve on their own. It's acute self-limited. And if you have a high threshold and you don't make a definite diagnosis the first time, a month later, 2 weeks later, the patient will have another biopsy. Those features will be well established. And then you'll be sure about that this is truly IBD. One thing that I think we didn't discuss is that no feature is absolute, and even a third of focal active colitis can be Crohn's disease. So you don't have to have, so the simple message is not every colitis is IBD and not every IBD has to have a chronic colitis. So it's really interaction between you and your clinical colleagues that's helpful in establishing a diagnosis.
And especially in treated cases and in children, those variabilities are more
Right,
common.
we discussed that yesterday, that pediatric IBD is a totally different disease. Immunotherapy colitis can be IBD-like, GVHD-like, lymphocytic, collagenous-like. So there's a whole spectrum of things that mimic. And yes, it's good to do studies because we are pathologists. We like to say, this is more helpful, that's more helpful. But in a given patient, all those things fall apart. So if you have us look at a study of IBD and its mimics, it depends on how many diverticular disease-associated colitis they had in their study, how many divergent colitis they had, how many solitary rectal ulcers, prolapse type patients they had. If you only have IBD, UC, Crohn's, and TB, that's a very simplistic, that's not really the differential that you struggle with. So it really depends on what the pool of patients was in which they came up with all these features. And I mean, we've been doing this for a long time, and I've never used a Nancy or a Robart score because I refuse to do it, because the best way is to compare the previous biopsies to the current one and say, is this better or worse? Putting numbers just makes it look a little more objective, but it's very subjective and not very helpful.
Just to add to what sir said, Crohn's, it's not a simple diagnosis. It's a clinical, endoscopic, biochemical, radiological, and pathological combination that you are able to diagnose Crohn's. If a patient has history that is of less than 6 months, 2 to 3 months, then probably in the same setting, TB would be higher than Crohn's. If he has a history that is more than 6 months, lasting for a couple of years, multiple exacerbation, with the same biochemical profile, radiological profile, you suspect Crohn's more than TB. Patient on interferon, you will not get the same segment TB that you are going to biopsy for Crohn's. Most important things are he will develop ascites and necrotic lymph nodes. More than 1 centimeter lymph node and ascites, it is probably TB on Crohn's. So there are many multiple clinical factors, radiological factors, biochemical with pathological. So it's very, very difficult to comment as it's inflammation would be there. We are looking at inflammation, various sets of inflammation. But apart from inflammation, biochemical, clinical is very, very important. Duration of symptoms. You go back to the history, so last 2-3 years, multiple biopsies done, patient symptomatic, unlikely to be TB. The duration is very, very important. So it's a combination of multiple things that helps ultimately the clinicians to decide it's one way or the other.
And
but still 20% it's indeterminate. Give a trial of ATT and then you burn your fingers.
Radiology, short segment, long segment, thickness of the fat. These are very important findings.
Then visceral fat versus percutaneous fat at L4 if you take a CT scan. So many things are there. Thank you so much. Wonderful.
So wonderful presentation. Thank Dr. Prasenjit again. Thanks. No, we conclude this session.
Thank you to chairperson and speakers for such an engaging session. Before we proceed for lunch, we would like to welcome Professor R.K. Gupta, sir, who was one of our stalwart of pathology, who has joined us today I request Dr. Akansha to welcome him. Welcome you, sir. We now request everyone to proceed for lunch. Since we are running short of time, our lunch break will be only of half an hour, and we'll gather back here after half an hour. 2:30 p.m.
लगा देना लगा। कर टाइमिंग सेट करना है ना पहले, ये टाइमिंग चल रही है ना।
अपना भी देना मिला
हाँ मैम सोच रहे थे इसमें टाइमर लगा दिया मैम इसको पॉज कर देंगे
ठीक 40 मिनट ठीक ये आपने जो ये चलाया हुआ है ये आपको टेप वो कर रहे हैं रिकॉर्ड कर रहे हैं ना
लाइव प्रोग्राम
हाँ अभी लाइव में डाल दें ताकि ये आ जाता है ना दिख रहा है ना अरे फोल्डर को वो भी कर लेती हूँ, कॉपी कर लेती हूँ पूरा, फिर आपका कल, अब इसके बाद 2 लेक्चर्स और है ना। आपके पास प्रोग्राम की कॉपी
आप फाइल कहीं ओपन होगा ना, इसलिए नहीं लगा हुआ। कोई पीपीटी खुला हुआ है इसलिए नहीं लगा हुआ।
एक मिनट रुकिए। आपकी रिकॉर्डिंग नहीं होगी तो फिर आप बैठ। अरे कोई दिक्कत नहीं, वो रिकॉर्डिंग हो, अब अपनी प्रेजेंटेशन आप चलाओ।
Next, we would like to invite Professor Ashok Kumar, Professor, Department of Surgical Gastroenterology, SGPGI. And next, we would like to invite Dr. Neha Nigam, Additional Professor, Department of Pathology, SGPGI, to chair this session. I will request the chairpersons to introduce our speakers for this session.
Good afternoon, everyone. Welcome back after a lavish lunch. So for now, we have our speaker. We have already, he has been introduced in the morning, Dr. Amitabh Srivastava. He is a pathologist at Memorial Sloan Kettering Cancer Center and a former resident of SGPGIMS, Lucknow. He has more than 180 publications to his credit, and he's a very famous GI pathologist who has written many famous chapters and books. Welcome, sir.
Thank you, Neeraj. Welcome back after lunch. It's a risky time to talk because usually they have a postprandial somnolescence, so I'll try and keep you awake. We'll try and finish the talk and the next session sharply around 4 because we'll have our remote speakers joining it from the US. So we don't want to keep them waiting. Dr. Manoj requested me to talk something basic. Colon cancer, as you know, giving a talk can go different ways. It's an area that has a lot of molecular data that we can talk about. But the request specifically was something that the junior members in the audience, trainees, and junior faculty may find helpful. And so if you don't like and you find this too basic, you can blame Dr. Manoj, not me. So what I'm going to do and try and do it quickly is focus on a few key aspects, most of them revolving around how do you fill out your synoptic template if you use the CAP reporting guidelines and you use the current standard of care. What is important even before histology? So just like the stomach cancer story, colon cancer management also revolves heavily around us as pathologists. So if you get a colon polyp or a polypectomy specimen with cancer, the clinical issue at stake is, does this patient need completion colectomy or is this curative? And if you get a resection for colon cancer, the key clinical question is, does this patient need additional therapy, either more resection for positive margins or chemotherapy because you have positive nodes? So essentially everything we do revolves around those two key questions. So diagnosis of colorectal cancer, again, that's a morphological differential diagnosis that's very important. Misplacement, we are not going to talk about it today. We are going to focus mostly around staging colorectal cancer in resection specimens, and I'm not going to talk about screening for Lynch because that'll be the next panel discussion section. So this is going to be pretty much the outline. Talk a little bit about malignant polyps, just so you know that we covered it, and then focus the rest of the talk on staging. So there are a few key features, just like in endoscopic resections of gastric cancer. As a general rule, the deeper the invasion of adenocarcinoma, the more likely it is to spread to nodes. Roger Haggett, by whose name the US GI Path Society runs, was the first to identify this fact that if you have pedunculated polyps, meaning polyps with a stalk, the risk of nodal disease really increases as you go from the head of the polyp to the head of the stalk to the native submucosa. So these go by Haggett level, and the risk of nodal disease doesn't really increase significantly until you're down to level 4. Of course, the Haggett levels don't really apply when the polyps are flat or sessile because they don't have a stalk. And so different criteria are used, but basically the same principles. So depth of invasion is important. And if you have a endoscopic resection of a flat polyp, then depth of invasion more than 1,000 microns is a high risk feature. So depth of invasion, rate of differentiation of the tumor, presence or absence of lymphovascular invasion, distance from the margin, the deep margin, and tumor budding are the features that we look for when we are trying to decide, is this a curative polypectomy or is this patient requiring completion colectomy? The SM2, 1, 2, 3 criteria, the submucosal invasion 1, 2, 3 are heavily used in Japan and also many parts of Asia. The challenge with them is that when you get endoscopic resections, you don't really have the muscularis propria. So the SM1, 2, 3 basically refers to divisions between the submucosa and the muscularis propria. So you arbitrarily roughly divide it into thirds and then say whether the depth of invasion is SM1 or 2 or 3. But because in endoscopic resections, you don't really have propria, you don't know what that thickness is. So you don't really know what SM1 is and what SM2 is. And hence this shift to not report things as SM1, 2, or 3, but actual depth of invasion, which you can measure from the muscularis mucosa, and then give your clinicians information that they really need to decide what to do next. So this is kind of the basic report that will look like if you have a malignant polyp with cancer. If it's pedunculated, give a Haggett level. If you have a sessile polyp, you have a choice. You can give SM levels if you feel comfortable, or more accurately, give the depth of invasion. Tumor grade, lymphovascular invasion, tumor close to the margin, meaning less than 1 millimeter from the margin, and then high tumor budding. The difference, so when you stage colon cancers, budding is divided into 3, low, intermediate, and high. And so for polypectomy questions, the high tumor budding is not more than 10, it's more than 5. So remember that. So all these features kind of decide whether a patient needs. Obviously, this is not the only thing. We don't decide what to do with the patient based on just histology, like we were discussing in the IBD talk. You need to know what the patient demographic is, what the patient's age is. If it's an 85-year-old man with multiple comorbidities and you have one feature that's high risk, you're not going to do a colectomy in that patient. So it requires, again, a team approach to deciding what's best for the patient. So this was some changes that were made in the 7th edition, which have stayed put in the 8th. T4 was divided into A and B, which we still use in the 8th edition. The nodal stages were subdivided. One change that was made in the 7th edition, which was a source of a lot of confusion, was tumor deposits. And we'll talk about what we are trying to do when we say tumor deposit. And then the M stage was also divided into A and B, depending on number of sites involved. So let's start with the basic depth of invasion. So the PT stage is the deepest invasion of the cancer in the colonic wall. And of course, if you have perforation of the visceral peritoneum, that's a T4A cancer, but it's easier said than done. Some cases will be simple, straightforward. Some may be challenging. The definitions and how we apply them have changed over a period of time, and we'll go through those in a minute. T4B is relatively easier to diagnose, so we won't spend too much time talking about it. I want to emphasize just 2 things. One, contiguous spread through the wall is not T4B. So if you have a cecal cancer that's spreading into the ileum by way of muscularis propria, that's not T4B. To call something T4B, the tumor has to perforate the peritoneum and then involve an adjacent organ. Only then will it have the adverse prognostic significance that we associate with T4B. So think of a sigmoid tumor going through the peritoneum and then adherent to the ovary or the bladder or the uterus. That's a T4B. If it has a contiguous mural spread, cecum going to the appendix, cecum going to the ileum, that's not T4B. And then you can have clinical T4B, but not a pathologic T4B. So you can have bowel loops adherent to each other or a bowel loop adherent to the bladder or uterus. that's a clinical T4B. But when you take sections and it's an inflammatory adhesion, you don't find actual tumor in it, then it's not a pathological T4B. So you still stage it as a PT3, and it's a clinical T4B. So just remember that those two things are important when trying to decide T4B versus T3. All right, so as I said, some T4As are simple. You have a colon, that tumor that's perforated, it's you don't need a slide to stage this as a T4A. It's gone through the peritoneum. Something like this, a transverse colon cancer adherent to the abdominal wall, you don't really need slides to say that, yes, you cut through the specimen, you can see tumor going into the skin. It's a T4B. The challenge is when you have an inflammatory and fibrotic response at the advancing edge of the tumor, and then deciding what's actually breached the peritoneum and what's still within the peritoneal confines can be challenging. So Neil Shepard, a good friend of ours in the UK, came up with this idea many years ago and tried to subdivide depth of invasion of tumors close to the peritoneum into 4 groups. Group 1, which was well clear of the peritoneal surface, 2 that was close but not actually involving the peritoneum, and then 3 and 4 were basically what we now call T4A. So the current definitions say that the tumor should be at or on the peritoneum. And it's a little silly, but I'll tell you what they actually mean. So at the peritoneum would be something like this, where you have tumor really sitting on the mesothelial surface. And then on would mean that it has breached and you can find tumor cells really floating in the peritoneal space. And then the others, 1 and 2, would be where your peritoneal surface is here and the tumor cells are here. There's a fibrotic inflammatory response, but the tumor is really far away. So this is another good example of tumor at the serosal surface. This is a consult case. We never ink the serosa. You should not ink the serosa, only ink true, real margins of resection. And we'll come to what an actual margin is in colon cancer resection. And then this is a good example of tumor perforating through. Whenever you have a colon cancer that's either close or perforating or about to perforate, you will always see a reactive mesothelial proliferation, a lot of hemorrhage and inflammation. So this is not tumor, this is reactive mesothelium. So what looks like tumor, this papillary proliferation here, is all reactive mesothelium because the tumor is actually going through and seeding the peritoneum. So those are clues that if you see mesothelial reaction and the tumor looks far away, you should worry that there is some perforation or some breach close by. So either take more sections, cut deeper levels into the same block, because you're more likely than not, you're going to find a T4A. One thing that's relatively under-recognized is that you can have a T4A in the rectum. When we come to mesorectal coverings, we'll talk about peritoneal coverings on the rectum, but remember that in the upper part of the rectum, the anterior surface is completely covered by peritoneum. And so you can have a T4A even in the rectum. The rest of it is soft tissue margin. So you can have a T3 or a T4B, but not a T4A because there's no peritoneum. And it's been shown in many nice studies, including this one, that it's a good marker of local recurrence, not of systemic recurrence, but breach of the peritoneum predicts pelvic recurrence down the road. So it's an important prognostic factor for us to recognize. So the first thing to do, as most of my mentors used to say, emphasize grossing and say garbage in, garbage out. So the key thing for you to do is make sure you're sampling the specimen from the right place. If you don't do that, there's nothing you can do on the slide, and I'll show you some good examples that's going to fix that error. So the first thing is how to recognize breach of the peritoneum, that this is a tumor on gross that looks like it should be a T4A. And there are a few key features you can see. So one is this puckering. So you can see this whitish area here. This is the smooth surface is all serosa. You can see this puckered or pulled in appearance. So this is very helpful in saying this should be a T4A. Kinking of the bowel. So you can see the serosa again puckered in or pulled inside. It looks almost like a stricture. That's very suggestive of a T4A. And this is rectum. Again, you can see the same dimple on the serosa. So this is all peritoneal covering. And identifying these areas in mucinous carcinomas, you can see little droplets of mucin on the serosa. That's very helpful. So any abnormality on the surface that makes you think that this could be a T4A is where you have to sample. And we use this, I've used this for more than a decade now to train our first year residents and pathology assistants who help with grossing. So this is obviously, you can see a serial section of a colon mass. And the question that I ask them is, which is the slice that you would put through for microscopy to decide the greatest depth of invasion? And because we have this idea in our head that the depth of invasion goes through mucosa, submucosa, propria, perimuscular connective tissue or fat, and then serosa, most of the trainees initially at least will pick this slice and say, well, this looks like it's invading the fat, which is true, but you have to remember that not all parts of the colon, it's not a circumferential fat pad all around the colon. So because the colon outer longitudinal muscle layer comes together in 3 broad bands, the tinea, the entire circumference is not surrounded by fat. So there are parts of the colon where the difference between a T3 and a T4A is literally a few millimeters. So if you have tumor going through into pericolonic fat, that's a T3. So if you put this section through for your staging purposes, the final diagnosis will read a T3, as opposed to the fact that you put through a section here. It's going through the muscularis propria and it's breaching you don't need a slide, you know that it's gone through. So this is the T4A. So there's no way around sampling accurately in a colectomy specimens for depth of invasion. So remember that the deepest extent of invasion may not be through fat, it could be directly through the parts of the muscularis propria that are not surrounded by subserosal adipose tissue, and that's going to be your deepest invasion. The other thing to remember, which again, if you look at the AJCC diagrams, they're pretty annoying because they show things very linearly. So if you look at the diagram of mucosa, submucosa, propria, and serosa, they're all straight horizontal lines. The peritoneum doesn't exist as horizontal lines. It follows the contours of the bowel and the organs. And so crevices are very important. So all these enfoldings that you can see here, so this is subserosal adipose tissue, and part of the colon where there's no subserosal adipose tissue, there's obviously an interface, and they usually are these narrow triangular slit-like spaces that go in. And more often than not, you will have a deeply invasive tumor that's going to breach these little grooves or crevices. So if you sample the colectomy specimen and you take a section from here, what stage that's going to be? It's going to be a T3 because what you'll document is tumor going through subserosal adipose tissue, because you left out the more important area, which will help you diagnose it as a T4A. So here is the corresponding section just to demonstrate that fact, that if that was your gross, this is your microscopy counterpart, a section going through here, you will never know what was in that little crevice, and you will stage it as a T3, whereas it actually was a T4A, which you can see tumor here at the peritoneal surface. So very important to make sure, one, look at areas that are very likely to have serosal perforation and growth, and two, never forget the crevices. And it's an important pitfall. Every week we end up upstaging cases that were called T3 outside that are actually T4As. And why is that? Because, as I said, the peritoneum goes into these little crevices, and in advancing tumors will sometimes breach, and then there'll be a fibrotic response, so they will be sealed, and there'll be little pockets of mesothelium within the tumor that you can identify, and you know that this was a T4A that has basically sealed off after perforation. So remember that I said the serosa doesn't exist as a linear line, and this is what I mean, that sometimes the tumors can look actually far away from the peritoneal surface, but because these crevices go in very deep all along the crevices, the peritoneum is actually not far away from the tumor. So you can see here the adipocytic lobules that surround the colon and these penetrating little crevices that are all mesothelial lined. And if you do your mesothelial markers, you can actually demonstrate that this is mesothelium going in deep into the subserosal adipose tissue. So why is that important? It's important because in cases like this, you can see this is a consult where, you know, there were marks made on the slide. At a cursory look, this will look that this is T3 because this is tumor going into subserosal adipose tissue. But if you look a little more carefully, you'll see these little crevices and clefts going in that I was pointing out in the previous slide. So this is one cleft or one groove. Here's another cleft or another groove, and here's another one going in. So I'll show you a high part just to convince you that this is actually tumor at the peritoneum, even though it looks that it's far away. And it looks far away only if you have that linear concept in your mind. So the same hemorrhagic inflammatory response that I was talking about, you can see here. And if you're in doubt, you can actually demonstrate. If you have colleagues who are not convinced, you don't have to argue. You can do an immunostain and actually prove that you're right. So you can do WT1, calretin, whatever your favorite mesothelial marker is, and actually show that this is tumor sitting in the peritoneum and it's outside, not in fat. So the adipose tissue can be actually a little misleading. There was some interest. I'm just going to talk about it quickly just so that you know what the controversy or the discussion in literature is around elastic lamina invasion. There was a time some years ago where there was a lot of interest in using elastic lamina invasion to identify T4A tumors. We still don't do it. The data is still not convincing enough to switch from our routine H&E diagnosis. But the basic idea was that like all serosal surfaces, whether it's pleura, pericardium, the abdominal peritoneum also has a delicate lining of elastin underneath the mesothelium. And just like in lung, where you can use elastin stains to say whether the visceral pleura is breached or not, you can do the same thing in colon. And there were some very nice studies done initially in Japan and also in the US and in Europe, showing that tumors that look far away from the peritoneal surface are actually not that far and or may have actually breached the peritoneum because of the phenomena that I was talking about, that when tumors invade, they have a desmoplastic stromal response around them. And if they breach the peritoneum, you'll see the same desmoplastic stromal response. And sometimes that will actually seal off the tumor from perforation. So there were two kind of arguments going back and forth. One was that, oh, this is tumor that has breached the peritoneum, so why not call it a T4A? And the counter argument was, well, it's incited a desmoplastic response, so it's actually holding the tumor back. So why do we want to call it the same way as T4A without a desmoplastic response? And so we have stuck to the H&E definition. We don't use elastic lamina, but just to show what people were talking about. So this is a tumor that looks at, it has nothing to do with the peritoneum. You do an elastin stain, you can see that it's actually sitting right at the elastic lamina of the peritoneum, but it has a lot of fibroinflammatory response that makes it look spuriously as if it's far away. Same thing here. This is again a tumor, the peritoneum. You can see this black ink again here, which looks as if it's far away. And here you can actually see tumor on both sides. So this delicate black rim is the elastic lamina, and you can see tumor on both sides of it. So this is breach of elastic lamina or elastic lamina invasion. And you can see that if you have the LPI refers to the Neil Shepard group 1, 2, 3, 4 that I showed you, that even group 2 tumors that seem very far away, if you do elastin stain, you can see in roughly half of them evidence that the elastic lamina has actually been breached. And it seems that, at least in those early studies, that this may be of prognostic significance in predicting peritoneal recurrence, if not systemic recurrence. And also in that, the same studies showing that cases that are called T3 by conventional criteria, but have elastic lamina invasion, tend to do worse compared to those that don't have any elastic lamina invasion. And if you look at overall survival, cases that were T3 with elastic lamina invasion tend to behave similar to PT4 or T4A conventional criteria cases. And the challenge has been that it's a very delicate structure. The elastic lamina is very thin, almost like the elastic lamina in a vein. So if you're using elastin stains to pick up vascular invasion, that's challenging. The same thing holds true for peritoneal lamina. When it's so delicate and completely breached, there is no way for you to actually detect. So in many cases, you don't see any black staining of the elastic lamina. And then the studies that were done to explore this concept over a decade showed contradictory findings. So the current AJCC CAP guidelines don't require you to do elastin stains to stage PT4. Moving on to lymph nodes, again, there's a lot of literature showing that the number of positive nodes is of prognostic significance. It's the biggest triage in colon cancer resection. Patients who are node positive get chemotherapy. There are some modifications to that paradigm, largely based around MSI high cancers. We won't go into them. But node negative versus node positive is a huge deal in colon cancer. So you want to get that right. The number of positive nodes are of prognostic significance, but they don't change therapy. So yes, you want to do an accurate job there, but the most important thing is making sure you're not missing a positive lymph node. And the QA criteria that have evolved in the US basically say that somewhere between 12 to 15 lymph nodes is what you require to adequately stage a colectomy. Because it was shown in early studies that the colectomy specimens that had less than 12 nodes examined, those patients tend to do poorly, and they tended to do poorly because they were not properly staged. So it's nothing to do with the tumor, it has to do with pathologic examination of the colectomy. And then you can see nicely that the node positive ones can be stratified into N1 and N2, and that has prognostic significance. Obviously, it's an indirect measure of tumor burden. The more positive lymph nodes you have, the poorer the prognosis is going to be. So the number of lymph nodes is important. The QA criteria that we currently use make very little sense, and I'll tell you why. And that holds true. The number of nodes examined in a colectomy is important, not just for stage 2 node negative ones, but also for stage 3 tumors, which you can see in this study, where the greater the number of lymph nodes, the better the outcome. And that's because we are appropriately staging the colectomies in those patients. So we know from experience that the number of lymph nodes that you enter as the denominator in your synoptic reports depends on a lot of things. What time of the day you were doing the grossing examination, how tired you were, how many other colectomies you had to gross that day, did you have a Whipple to gross the same day along with it, and so on and so forth. So the diligence, it's a manual, tedious task, so it takes time to do it well. Obviously depends on tumor characteristics. If you have a colectomy that you find very easy to find lymph nodes and you found 50 the first time around, I can guarantee those are all going to be negative because that's an MSI high tumor. So microsatellite unstable tumors, remember the lymphoid infiltration I was showing you in the gastric cancer, the same thing holds true in colon. MSI high tumors have very large, bulky, juicy lymph nodes, which are very easy to identify. Your counts will be very high, but they're all going to be negative. So the hard part is finding those small 5 millimeter or less in size lymph nodes, because those are where you're going to find the positive ones. Surgical technique, obviously, if you have a bad surgeon who didn't do a good job clearing out the lymph node basin. Patient variation, you may have an asthmatic or somebody who's on steroids, the lymph node becomes small, harder to find. Post-neoadjuvant chemotherapy will shrink those nodes down, so it requires a lot of effort to find lymph nodes. And then obviously the anti-tumor immune response, which I said is going to make it easy, but it's not going to be helpful in finding the positive nodes. So there were some studies done looking at whether fat clearing agents can help, because colectomies have a lot of pericolonic adipose tissue, so it's hard to find lymph nodes. So they showed that if you use fat clearing agents, obviously the yield of number of lymph nodes that you see goes up. The important thing to remember from this study is that 75% of all positive nodes were actually small ones. So you cannot use size and sample the large ones preferentially, thinking they are going to be likely the positive ones. Actually, the small nodes are going to be more likely to be positive. So why did I say that the number of lymph nodes examined is a bad QA criteria? And it's a bad QA criteria because you can see that since the late 80s, really in the 90s, we started pushing this QA criteria that if you are not examining at least 12 lymph nodes, you are doing a bad job. And that's true because it's a surrogate marker. The denominator of lymph nodes is a good surrogate marker of the quality of examination. But you can see that this green line represents the number of colectomies in the US in which more than 12 lymph nodes were found. And you can see this very dramatic rise from kind of the mid 1990s to around 2010. But look at what happened to the number of cases staged as stage 3 or node positive cancers. That remained almost flat. So you would expect this curve to be budging upward. It's not obviously going to track the same way, but there should be an upward trend, which is missing because the QA criteria makes very little sense. And this is another study looking at the same thing, this one from Europe, that you can look at the number of cases in which 12 or more lymph nodes were examined, kind of gradually increasing over time. But the number of cases staged as node negative is essentially flat, no change whatsoever. And so why is that? It's because where you sample those lymph nodes from is also important, right? So you want to sample preferentially and thoroughly from around the tumor because that's where the first lymph node metastasis is going to be, right? So it's intuitive. So the denominator doesn't really tell you where those lymph nodes were from. So imagine two scenarios, one in which you have 5 lymph nodes in these 3 stations, and another in which there are 11 from the peritumoral zone and 2 from far away. Your report will say 0 or whatever out of 15. This is a thoroughly understaged colectomy specimen. In my opinion, this is also thoroughly understaged because it's not hard to find 30 plus lymph nodes in a colectomy specimen, but at least you have a better job looking at tumors in and around the tumor. And we've tested this many times in many different institutions, and it holds true. So many years ago, this was the first trial looking at a consecutive series of colectomy specimens where we arbitrarily divided the tumor basin for lymph nodes into primary and secondary, and that 5 centimeter was just an arbitrary number to come up with, where we said we look at lymph nodes separately in and around the tumor and those that are far away and see what happens. The second thing we did is that we are not going to sign out anything as N0 without having a second look at whatever fat was left behind, because that's the perfect QA measure that you can do. Because of the reasons that I first said, it's a tedious job. You could be tired, the PA could have been tired, and you don't put through every single lymph node the first time. And I've had this practice for almost 15 years now where I don't sign out anything. You give me 50 lymph nodes the first time, I'll still ask the PAs to go back and they dislike you, but then they have a conversion. I've had conversions at every level you can think of, at 15, at 25, at 35, at 45. And so it takes time to make them into believers, but once they buy in and they see a case converting from N0 to N+, that practice stays. So this is standard practice at our place, where we don't sign out anything as N0. If you do a second search in every case that's N0 at first attempt at looking at lymph nodes, you'll find on average about 10 lymph nodes in the second search, about 6 or 7 in the primary basin, and about 4 or 5 in the secondary basin. And more importantly, what you end up doing is you end up staging roughly 4 to 5% of node negative cancers. And this has held true at every place I've ever worked. It held true at Dartmouth, it held true at Brigham, it holds true at Memorial. And it's not always going to be one lymph node. You can have conversion from N0 to N2 for the reasons that I discussed, that it's a tedious job and it's easy to make that mistake. And most of the metastases are going to be in small lymph nodes that are more likely to be missed in your search. So be as thorough as possible. Don't hesitate to go back. It's not a criticism. It's not a critique of the person who did the first. Actually, we have a protocol where the second search is done by a different person. If there was a resident who did it, there's a PA who's going to do the second search. If it's a PA who did the first search, we'll have a resident go back and do the second search. And the idea is to have it's no different from having your colleague look at a slide and say, hey, what do you think is the diagnosis? So it's the same kind of concept, that you want another pair of eyes looking at the same thing, trying to figure out, did I miss something? All right, what about tumor deposit? This is something that has created a lot of problem in everybody's mind. and it has gone through different iterations. In the 5th edition, it was size criteria, 3 millimeter or more, or versus less. In the 6th edition, it was a contour, meaning that if it's a rounded deposit, call it a lymph node. If it's irregular, call it vascular invasion. And then in the 7th edition, we came up with this N1C categorization. So the basic idea or the challenge is that what to do with a chunk of tumor sitting in fat with no direct extension or connection with the tumor up in the wall. And of course, if you have something like this, it could be venous invasion, it could be lymph node invasion. So when you're lucky and you find a delicate rind of lymph node tissue, it's easy. You can say, yes, it's all necrotic, but there's a rim of lymphoid tissue, so I'll count this as a positive node. When you don't have any lymphoid tissue and you don't have any other structure left, it's hard to know whether this was a vessel to begin with or this was a node to begin with. And that's the challenge that, that created this concept of a tumor deposit. So when you're lucky, you can see some remnants. Here, there's a wall of a vein left and a little bit of lumen. Here, there's a little bit of lymph node left. The contour rule never made sense because you can have tumor in a lymph node that breaches through, so it's irregular in outline. Tumor in a vessel can be perfectly round, so just using shape doesn't really make sense to decide whether it's node or vessel or something else. So there were two things that we wanted to be careful about. One, there should be no connection to the tumor up in the wall. So it's a T1 or T2 tumor or even a T3 tumor, but what you're looking at is far away from the main tumor mass. If it's hooked up, you use it in the T stage for depth of invasion. You don't use tumor deposit. The second important thing is if you already have positive nodes, you don't use N1C. So if there were two conventional positive lymph nodes, you use those for staging. You mentioned tumor deposits in your report, but they don't qualify for the N1C designation. So why did we come up with this separate categorization? The challenge was that most oncologists use the nodal status to decide which patients need chemotherapy. Extramural venous invasion is a known prognostic factor that predicts distant metastasis. And in the current guidelines is one of the features. If you have node-negative cancers, there are some indications on histology that qualify patients for adjuvant chemotherapy despite the nodes being negative. One of them is T4A, which is why we are spending so much time on those parameters so that you get them right. And the second one is extramural venous invasion, because it predicts, not surprisingly, you have a large vein sitting in pericolonic adipose tissue. Those tumors are more likely to go to the liver or to the lung. So that's an indication for adjuvant chemotherapy. The challenge was that most oncologists were not using it as a parameter to recommend adjuvant chemo in node-negative patients. And so to get around that, we created this nodal staging to put tumors in the N category so that patients could get the right treatment. But it has been a circle because, I mean, we know it's either it's extramural venous invasion, but we are putting it in the nodal category and calling it N1C. Quick words about radial margin again, because we go back to the grossing issue. Remember that we think of colon as one thing, but in terms of peritoneal coverings, they are very different. So the cecum, transverse colon, sigmoid colon, they are all intraperitoneal. They hang freely by a mesentery. So the only true margin in those resections will be the mesenteric margin. If you read the synoptic template, it's confusing, and we struggle with our trainees all the time trying to help them determine what's a mesenteric margin and what's a radial margin. So anything that a surgeon has to cut through to get the colon specimen out is a radial margin. So in cecum, transverse colon, sigmoid colon, the only thing they have to cut through is the root of the mesentery. So that's your only radial margin. So radial and mesenteric are the same at those three sites. In the right and left colon, the anterior and lateral parts are covered with peritoneum. So this whole blue on either side is peritoneal covering. And then the posterior aspect sits right against the retroperitoneal soft tissue. So the posterior part is a true radial margin. So if those of you have done autopsies, have seen, when you drag the colon out and you rip the colon out from the abdominal cavity, that's a radial margin. You're freeing the colon up from the attachment to the colon, to the retroperitoneum. So in right and left colon, there'll obviously be a mesentery because they have to cut through the mesentery, but there'll also be a true posterior radial resection margin. The reason we get away with not doing a good job is that that's seldom going to be positive, because if it were positive, the surgeon is not going to cut through it. You may see it in palliative cases where, it's being done because the colon is about to perforate or is obstructed completely, so they're taking it out, but the surgeon will know it's a positive radial margin, so you don't really have to tell them. But that's also in circumferential tumors in the right and left colon. Pay attention to the posterior margin too, because that could be positive. If it's positive, those sites will get additional radiation therapy, so it has clinical significance. And that's how a circumferential radial margin, remember the picture that Atur Singhi was showing of the uncinate margin, the ragged, rough surface, the same thing holds true here. So this is the shiny, glistening surface here is all peritoneum, and you can see this transition from this smooth, glistening surface to a more raw, ragged, soft tissue. Usually there'll be little threads here because they have to tie off bleeding vessels. So that's your true radial resection margin here. Sometimes you'll see a positive radial margin because there was a positive lymph node close to the radial margin and the tumor breaches through. The implications are not quite the same as a positive radial margin of the actual tumor going through, because there's not much the surgeon could have done about this scenario. So just to show you some examples, this is a sigmoid colon resection again for the trainees. The glistening, shiny surface here is all peritoneum. So don't ink this, because once you have a section separating the peritoneum here from the true radial resection margin is going to be very challenging. So don't ink anything that's not a real resection margin. So only ink this area here, which you can see this rough surface with ties that are bleeders, and that represents your true radial resection margin. Rectum, as I said, we'll come to it in towards the end of the talk. So remember the rectum on the anterior surface, the upper half is covered with peritoneum. So you can see this nice shiny peritoneal covering going up. So that's the posterior aspect. The posterior aspect is all true radial soft tissue resection margin. So here, what you have to ink is the posterior aspect and only this aspect here on the anterior surface and the lateral side, because that's your only true radial resection margin. So you can get a T4A here, but not here because there is no peritoneum. So you can get a T4B, as I said earlier, but you cannot get a T4A. So even knowing where the tumor is location-wise, whether it's below the peritoneal reflection or above the peritoneal reflection, will tell you what's the maximum T stage that you can expect in your specimen. It's also important to know because high rectal tumors that are much above the anterior peritoneal reflection can be treated almost like sigmoid colectomies. Vascular invasion, similar to the elastic lamina invasion issue. Again, if you have a T4A tumor, you don't have to be very particular. Even if you miss extramural venous invasion, it's okay because it's already high risk. If you have node-positive tumor, it's okay. In patients who don't have any high-risk feature, doing whatever you can to make sure you're not missing extramural venous invasion is very important. Because as I said, that's the whole idea. It's a high-risk feature, and those patients should get adjuvant chemotherapy. Finally, tumor budding is something new. It's an optional criteria, not mandatory, recommended in malignant polypectomy specimens, not in colectomy specimens. I just put it here just for completion. Essentially, the idea is that if you have, it's a risk factor for local and distant metastasis. The idea behind it is that gland-forming tumors, a subset of them, at the advancing edge will give off these little clusters of tumor cells, and that's a high-risk feature. Is part of the epithelial mesenchymal transition. And if you do your keratin stains, you can actually highlight those buds very nicely. So that increases the risk of nodal disease, and hence it's an important feature to report, but again, optional at the current time. tumor budding is recommended in polypectomy specimens because it's a very robust predictor of lymph node metastasis. As I said at the beginning of the talk, the threshold that we use is slightly different. It's not more than 10, it's more than 5. So if you have cases like that and your surgeons follow the guidelines, they will often ask you, what is the tumor budding? If you don't have LVI, it's not polio differentiated, it's far away from the margin, high tumor budding might tip them into doing a colectomy, especially in young patients. Finally, post-neoadjuvant resections, we won't spend too much time. Often the tumor has shrunk, it regressed, so all that's left is a scar. You may not actually see much of the tumor, but essentially you have to block out that entire tumor site to make sure you're not missing tumor. There's many grading schemes for post-neoadjuvant specimens, depending on how much tumor is left. This was one of the first. What's used currently is the current CAP criteria, where you have grade 0 to grade 3, depending on the amount of residual tumor left. One important thing is acellular mucin pools don't change what needs to be done to the patient. So you count them as tumor response. If you have acellular mucin at a margin, it has no prognostic significance. If you have acellular mucin in a lymph node in a post-treatment setting, don't count it as a positive node. That qualifies as treatment response because you cannot get rid of the mucin. So if all there is left is acellular mucin with no tumor cells, it will be a YPT0. And then finally, there's something in your template about rectal resections. If you get total mesorectal resections, the quality of the mesorectal fascia is very important because it changes the risk of recurrence from less than 10% to actually 30%. And how you report this is these 3 categories: complete, near complete, and incomplete. And essentially what that means is how good the surgeon was in taking the rectum out. So complete would be the whole surface has this smooth fascial covering around the fat. Near complete would be where mostly fine, but you start seeing little holes. And incomplete meaning that you are seeing parts of the muscularis propria. So is the clearance of the perirectal nerve plexus and lymph nodes was not done nicely, and that's a risk factor for recurrence. Final slide, just to show the holy grail of colon cancer staging, which we still don't have a good answer. Part of the answers were in the talk that I gave you, and the holy grail is that if you look at outcomes, both in the 6th and the 7th editions, there is this paradox that the stage 3A patients, the outcome is actually better than stage 2B. And the reason that happens is that there is a subset of 2B patients, the so-called node negative patients, that are actually not node negative. So they don't get the chemotherapy that they need, and that drives the outcomes. So about 20% of stage 2 node negative patients will relapse on follow-up. Many of them will be because it was T4A, understage as T3. Many of them will be because they were node positive, but were called node negative. And hence, everything starts with the first-year residents and the trainees who are grossing the specimen. And if you don't do a good job, there's not going to be a good diagnosis at our end. Thank you so much for your attention.
Nice presentation and it's wonderful coverage of the topic, and both colon and rectum you nicely covered on pathological aspect. Any questions from the floor?
Yes.
Regarding the extramodal muscular invasion, are you doing any staging, or outer arterial side is good enough?
Again, depends on what else is there in the specimen. So if we, as I said, if you have a patient that's a T3 nodes negative, then yes, we'll do elastin stains to try and pick up extramural venous invasion that we did not see on H&E. If you have something that's classic where you can see the lumen, there's part of the wall that still remains, we don't really do the stains. We just call it extramural venous invasion. So what Dr. Das is referring to is the so-called orphan artery sign or isolated artery sign, which means that in the colon, the arteries and veins travel together. So if you have a large artery and you don't see the adjoining large vein, that means that there must have been some breach by the tumor. And to pick them up, to highlight them, you can do the elastin stains, but it's the same thing as the peritoneum, that the lamina is so delicate that if you're not sure on HNE and you do the stain, it's seldom helpful because the lamina is disrupted and gone and it's replaced by fibrosis. So it's the elastin stain can be helpful, but it's helpful in cases where I didn't really have a doubt on the HNE. So
you can ask Bandana.
We actually follow first 5 sections, then we take a lead, and then if it is not showing any tumor, we cut it to 3 different levels from the top. Is that adequate or what is the...
now, if you did that, we would sign out 1 colon cancer a day. So we don't level. So if you don't see, if you have blocked out the whole tumor bed, we don't level to find, because at that point, you are basically trying to distinguish 0 and 1. And that distinction is not really that important. In post-neoadjuvant setting, the most important prognostic parameter is positive lymph nodes. The tumor bed response is not going to predict either need for additional therapy or prognosis. They really know right now, they have a very good sense. We were talking about neoadjuvant resections at lunch. If they see a very good response or a near complete response, they don't even operate now because they just keep the patient under surveillance till the tumor starts growing, because surgery doesn't really add much in patients who have a great response to chemotherapy. So if you know the rectal cancer story in Lynch patients, where basically they are cured by immunotherapy, those patients don't get their rectum out, and that's the whole idea. So trying to separate, I mean, yes, as pathologists, we want to do things that we like to do and grade and stage, but in terms of practical importance and clinical significance, separating 0 from 1 to 2 to 3 to 4 and then 5 is not really necessary.
Dr. Srivastav, I have one question.
Sure.
What is the role of ISC in pathology assessment of a pathologist while making a correct diagnosis of CA rectum or CA colon?
Not so much in diagnosis of carcinoma. I mean, we can talk about pseudo-invasion versus true invasion, maybe presence or absence of LVI, but nothing really in the actual diagnosis of cancer. That's really a bread and butter H&E diagnosis. In terms of management, yes. I mean, the next session is going to be about MMR, and that's like the huge.
Obviously, they are going to have a discussion on Lynch syndrome, so that part would be discussed. I have one more question from surgeon's perspective.
Sure.
How many minimum section and how millimeter thick section should be for a pathologist to have a perfect, I mean, histopathological assessment and tumor site?
You mean when you're doing a biopsy for the first
Yes,
diagnosis?
sectioning, yeah, micro sectioning.
That's usually I mean, you know, we always say the adequate specimen is one that helps you make the diagnosis, right? So there are no guidelines, and it's hard because if you have a big bulky mass, you may be nibbling at the surface and you may get the adenoma precursor, not the cancer. Surgeons, gastroenterologists always want us to make the diagnosis the first time because, you know, the management can then proceed according to the diagnosis. So in general, I think trying to focus on the attachment to the wall and trying to get as deep a biopsy, getting a bit of the submucosa as possible is going to help you, not going around the head of the polyp or the circumference, because that's where most of the precursor is going to be. So again, the polyp stalk where it joins to the wall of the colon, or where you can do multiple bites at the same site to kind of dig in, or the tunnel through the tumor to get the deeper part to help your pathologist make the diagnosis.
Thank you very much, Dr. Srivastav, for wonderful presentation and the participant for good discussion. Now we close this session and we'll move on to the other session.
So moving ahead with the next program, quickly, we would like to invite the moderators for the panel discussion. Professor Vinita Agarwal ma'am and Dr. Neha Nigam ma'am. We would like to welcome the panelists for this session. Dr. Amitabh Srivastava, Dr. Manoj Jain, Dr. Shagun Mishra, Additional Professor, Department of Radiotherapy, SGPGI, and Dr. Ashish Singh, Associate Professor, Department of Surgical Gastroenterology, SGPGI. The panel discussion will be on minimal data set reporting in colorectal cancer and diagnostic evaluation of hereditary colorectal cancer.
Thank you, Dr. Rahul. So we have Dr. Bell who will be waiting online. So we'll try to wrap up the session within 15 minutes. The idea behind this session was to talk about the common conditions that we face as regularly while diagnosing colorectal cancers. So the first question we like to ask, there is a 30-year-old man who is diagnosed with colon adenocarcinoma on biopsy. So this question is for the clinicians, Dr. Shagun and Dr. Ashish. What factors will determine the genetic testing for hereditary colon cancer in this scenario with a 30-year-old man?
Sorry, ma'am, particularly in this case, actually patient is a young age male. And that itself is a factor which determines like at least some genetic testing, because this may be associated with the genetic syndrome, especially Lynch. So this patient qualifies for this examination. In fact, present scenario, in fact, all cases should be evaluated with the MSI and mismatch repair assessment.
Dr. Shagun, would you like to add?
So if you talk about genetic testing, so you have two criterias which guide you regarding genetic testing. And one of them is the Amsterdam criteria. And the second one is the modified Bethesda criteria. And both these criteria look into two major factors. One of them is age, and the second thing is family history. So, and of course, the risk, how many affected family individuals did have a risk of colon cancer or Lynch syndrome associated cancers like endometrial cancer or small bowel cancer in the family. So that is how they assign a risk and then, decide regarding hereditary testing.
So can I ask a show of hands in the audience? I'm just curious. How many of you are doing universal screening by IHC for MMR proteins at first diagnosis? So few, right? So if you look at Lynch, there's two things that are happening. One, universal screening is highly recommended. If you don't do 4 stains, at least do 2. Because you can predict if you do the minor partners, MSH6 and PMS2, you can actually, if they are intact, then you know the mismatch repair machinery is intact. And the reason to switch to universal screening was that at least half of Lynch-associated cancers occur in patients older than 50 years of age. So we use different cutoffs, we use the criteria that were just mentioned, and those still lead to a lot of Lynch patients being missed on screening. So it's really good practice if you can, because this impacts not just the patient, but for every proband that you pick up, you save at least 6 to 7 colon cancers down the road in the family. So the second, third generations will not get colon cancer because you screened the first patient well. So the dividends are long-term. So I would heavily recommend that if you have a colon cancer first diagnosis, regardless of age, I mean, you can think about not doing it in more than 70, but we've seen first diagnosis of PMS2 Lynch in 75-year-olds, 80 years old. And then the second thing is the young generation is doing something to their colons and to their bodies in general. So in the US, if you were born after 1990, you have a 3 times higher risk of colon cancer and a 4 times higher risk of rectal cancer. So the incidence in young patients is increasing. So more and more we'll see these 20, 30-year-olds. 3 months ago, actually an 18-year-old with colon cancer. So that has thrown up a lot of questions about screening for colon cancer, because current guidelines are 45 years of age or 50 years of age is when you need your first colonoscopy. But now with this rising trend, we don't know what the right approach should be. Luckily, the absolute numbers are small, so the 3 times high and 4 times high sounds scary, but the absolute numbers are still small because it's a rare cancer in young patients. So the reason I bring this up is that you can have a 30-year-old now with you screen them with MMR stains or MSI or sequence them, and they'll not have Lynch. And these are sporadic, environment-driven, young onset colon cancer. So there's a lot of interest now in why that's happening.
In resource-limited country, which cases can be excluded? Maybe multiplicity or polypoidal tumor. Can you suggest something like that?
I mean, that's the reason we switched to universal screening is because we went from the clinical criteria, the Amsterdam, the Bethesda, then morphology, mucinous carcinoma, MSI highlight morphology, increased intratumoral lymphocytes, and they're all predictive, but they don't work well overall. So you can have typical gland-forming tumors with very little lymphocytes, and those will be MSI high tumors and MMR deficient tumors. So short of doing the immunostains, there's nothing that predicts. Hopefully, we've switched the role of MMR stains in GI cancers has switched now from just screening for Lynch to now driving therapy. So all the immunotherapy implication that we have now. So I'm hopeful that that will drive more and more labs to actually start doing the stains, and then you'll do, get 2 for the price of 1.
So this is about the next question. We're going to the next question. So this the first one, I think Dr. Amitabh, we have already answered. So for the house, it is generally required to do the MMR staining at least by immunohistochemistry for all colorectal cancer, irrespective of the age. So that is what we need to convey. When will you advise other markers? Dr. Amitabh, would you like to take this? Like we are doing by IFC, BRAF, V600E. So what is the implication and when it has to be done?
BRAF you mean IFC or sequencing?
This is for immunohistochemistry that I'm asking.
Yeah, BRAF IHC works well in melanomas. It's a crappy stain to do in colon cancer. So we don't rely on the BRAF IHC. It's hard to interpret whether it's a blush or background. It's real, so it's not something very robust, especially if you're trying to use it to triage patients into germline testing versus no testing. The reason that's important for the trainees is that Lynch cancer, so you can get the same MSI high cancer in an inherited setting, and you can get the same MSI high cancer in sporadic setting through methylation of MLH1. So it's not a mutation, but it's silencing of the gene by hypermethylation. And those two are very different. Sporadic MSI high cancers, typically elderly white woman who smokes is the kind of demographic that where you'll see it. And those tumors start with the serrated polyps, the sessile serrated polyp or small hypoplastic polyp, as opposed to Lynch that begin with adenomas. And BRAF almost never occurs in Lynch patients. So if you detect an MSI high tumor or MMR deficient tumor and your BRAF mutation is positive, then you don't need germline testing for Lynch syndrome. So it's just another step. If you want to minimize germline testing, that's another step that you can do. But again, we've stopped that because there are rare patients that have BRAF but end up being Lynch. BRAF IHC is not good. People have kind of stopped doing standalone BRAF testing because of multiplexed sequencing now. So we go straight to either tumor sequencing or germline sequencing, depending on the patient.
But sir, it may be important for the family counseling and screening of those families. In case you find BRAF, probably that patient is not having Lynch syndrome. In that case, you can counsel the family that you may not necessarily require this kind of a screening and you should not worry about the family. Isn't it like?
Yes, I mean, it depends on what BRAF if it's IHC, I would not reassure the the patient or the family because the stain really is not robust enough. If it's sequencing, yes. If you show that the tumor has a BRAF V600E mutation that we typically associate with sporadic MSI high colon cancer, then yes.
It means like not only metastatic cases, you would offer genetic analysis in all patients, NGS and all?
No, we don't do NGS in all patients. So the algorithm is first diagnosis of colon cancer, you do your MMR stains. You can choose the panel of 4 or the panel of 2. And if that's intact, you don't need anything more. If you find a deficiency, and again, it depends, it's not all one pool. It depends on what deficiency you're identifying on ISC. If it's MLH1, it can be inherited, it can be sporadic. But if you find deficiency in MSH2 or MSH6 or PMS2, it's almost always going to be Lynch. It's not going to be sporadic. There's no sporadic. You can get somatic mutations of MSH2 or other genes in colon cancer. So those are almost always going to be germline. So it depends on what abnormality you pick up on your ISC screen. So everybody gets an ISC screen, and you basically don't do anything for the 97. Lynch is 3% of all colon cancer, regardless of which part of the globe you are. So 97% of the patients, you don't do anything beyond the just ISC. So it's just the 3% you want to pick up and triage into finding the Lynch patients.
Yeah, just to add to that, it's basically the isolated loss of MLH. If it is there present when you look into your MMR genes, there you need to do a BRAF V600E, and that's what dictates whether it is a Lynch or a non-Lynch.
I would like to just add for the trainees that whenever you're doing these MMR proteins, you need always to have a control. There is an internal control, and you have to look at the normal mucosa. If you do not have an internal control, you have to have a control before you say there is a deficient MMR or a positive. That is a very important point for
Okay,
MMR.
quiz question for the trainees. What if you actually see no staining in any cell and it's not a technical glitch?
So the question is, there is no staining in any cell. And it is a negative or
Louder. No. I mean, germline is Lynch, right? But you see staining in lymphocytes, endothelial cells. And constitutional MMR deficiency. So those patients will, you may see no staining any cell, and it's actually real. You can repeat it multiple times. I'm just saying that rarely you'll see. Yeah, yeah. Usually in younger individuals. But that's one scenario where you don't have any internal control to rely on.
So you always look at the internal control. Accordingly, you have to have an external control. That is a point that is being made. So this is, I think Dr. Manoj talked about resource limited settings. So is formalin fixed paraffin embedded tissue an acceptable specimen for molecular biomarker mutational testing in colorectal carcinoma?
That's a loaded question. As everything, there is nuance to the answer. The short answer is yes, not just for DNA testing. I mean, we do a lot of RNA sequencing now on paraffin tissues. There's a lot of spatial transcriptomics that's done of formalin fixed paraffin embedded tissue. The reason I said it's loaded is because it can be formalin fixed and paraffin embedded, but the question is, when was it formalin fixed? So if you have a colectomy specimen that sat in the OR overnight and then it came to you and then you put it in formalin but didn't open the specimen, formalin didn't reach the specimen, you didn't cut through the tumor, you didn't fix it promptly, that's not a good specimen for any study, let alone DNA study. It's not good for H&E either. So prompt fixation is important, which is why yields in biopsies actually paradoxically is better because biopsy is going to formalin right away. And resection specimens are much harder. The rate of failure is much higher. So yes, there are adequate specimens, but remember that prompt fixation is very important. If you have a 10 centimeter bulky tumor and you open the colon and dropped it in formalin thinking you're doing a good job, it's going to be a messy specimen. So you need to make sure that you at least make 3 or 4 cuts through the tumor so that you get fixation throughout and you can use it as a good sample.
Another thing, quality of formalin is very important. Buffered formalin should be there, जो है, Here we get sometimes quality of family is not good. Even prompt fixation will also not give good results. That's
basically some formulations are a pre-embedded specimen. What would be the difference in the final outcome of it? It will be same.
The DNA is quite robust. So, I mean, the difference between frozen and formalin fixed usually used to be RNA. RNA is very labile, so you lose it and degrades very quickly. So the fresh versus frozen was RNA studies were done on frozen tissue, which is why there was a lot of infrastructure, biobanking done to snap freeze tissue rapidly from the OR or from biopsies. But now the technology has evolved enough that the difference in yield is not that much, provided the issues that we discussed, that the fixation was done promptly and the formalin is right, and you can do pretty much anything of formalin fixed. The advantage of doing things on fixed tissue is there is a morphological correlate. The challenge on many of the studies done in the past that were just snap frozen without any morphological correlate, we don't know what they were looking at. So they could say they didn't find a mutation, and they didn't find a mutation because there was no tumor in the specimen that was frozen. So you need to see what you're freezing. And for that, the formalin fixed paraffin embedded methods offer a great resource. So all the spatial transcriptomic studies being done now, where you can see normal mucosa, precursor lesion, cancer, superficial cancer, deep cancer, inflammatory response to the cancer, they're all being done on formalin because you can basically have a map of what's happening throughout the tumor based on the H&E.
Okay, thank you. I think we can go to the next part of the discussion, and because that has been already covered, most of it has been covered in Dr. Amitabh's lecture. We just put in some points.
So next topic for the panel discussion is minimal data set reporting in colorectal cancers. As sir has discussed in detail the staging of the colorectal cancers, I want to ask what are the key components of the minimal data set reporting in colorectal cancer?
I think, I mean, we can skip through that. I mean, if you just go online and go through the CAP templates for colon cancer reporting, you'll find everything that we need to do. Those are pretty comprehensive. And I think I focus mostly on the clinically important ones, the T and N stage categorization, because they kind of drive therapy the most. But I think we covered pretty much all the important ones.
Okay.
So some of the intermediate risk factors like the LVI, PNI, these are very important for us, especially for stage 2, stage 3 cancers to decide regarding adjuvant treatment. So, I mean, they have to be mandatorily reported, and sometimes we find it missing. Yeah, so that's the drive home point, that besides the T stage, the N stage, the number of nodes, these are classical risk factors like LVI, PNI, and lymphovascular space invasion. All these are tumor perforation. These are very important risk factors to be reported. Tumor budding.
I think there are some core elements and the non-core elements. So you have to focus on the core elements. You can skip tumor budding, and it is optional. If you are giving it, is good. But moving to the next question, how do they impact the clinical decision making and patient outcomes?
Yeah, I mean, I think we discussed during the talk how the management kind of drives through what we put on the report. And I mean, my suggestion would be don't try and reinvent the wheel. I mean, the CAP guidelines, the AJCC guidelines, you can just print the form and use it for your reporting so that you don't miss anything that's important, and just use that. Even if you don't use the actual template, just use those data points and just structure your report so that you're not missing anything.
And Ashish, Shagun ma'am, your thought?
So for a stage 2 colorectal cancer, so you divide stage 2 into low risk, intermediate risk, and high risk. For low risk intermediate cancer, you need not give any kind of adjuvant chemotherapy. For intermediate risk colon cancer, you do a MSI status. And based on the MSI status, if it is MSI high, you can keep the patient on observation. But if the patient is MSI stable, then you can consider 6 cycles of adjuvant, keep cytarabine alone. And if it is high risk in stage 2,
the patient goes for 6 cycles of adjuvant chemotherapy, that is a combination of capecitabine and oxaliplatin. And it's very important because all these therapies that you give in the adjuvant setting, they come with a set of toxicities. And some of them are very nagging. For example, oxaliplatin, when you give to patients, they cause peripheral neuropathy. So that's why it's very important to properly risk stratify, especially in stage 2 rectal cancers, colorectal cancers.
Nowadays, in the template itself, MSI status has come. Like that has to be reported. It has like full template has implication over patient's management, what treatment to be given and how to be planned, as well as it has implication over like patient's family counseling and their screening. So full template is very important and has to be reported accordingly.
Completely agree with you, Dr. Rajan. If you're talking of our setting, we'll be happy to do MSI panels in all our patients. Provided when the surgery is done, you also raise a form for MSI staining. So we'll be happy to do it in all cases.
Yeah.
Wherever we are receiving the requisition, we're doing it.
Yeah, definitely, ma'am.
So we must on the right side, it can be get optionally based on their demand.
I think this
can-
is related to our last question. What are the challenges in resource limited setting?
Yeah, I mean, I think it's like a backward way of thinking or reasoning. So the first thing to decide is what is our goal. So if our goal is like any other disease to detect, it's a significant cancer, as we said, not just for the patient, but for the family. For each cancer that you detect that is Lynch related, you prevent 6 or 7 cancers in the family. And if 3% of all your colon cancers are Lynch, then it's a significant burden, not just now, but going forward generations. So if the idea is to pick Lynch syndrome patients, then yes, we can set some guidelines, but they're going to be arbitrary because not every right side cancer is going to be sporadic MSI high, right? So what if you have a 40-year-old with right-sided cecal or a descending colon cancer? That's still very likely to be Lynch. So you cannot dismiss something just based on location. So any arbitrary cutoff so I would say try and push to screen every patient for MMR for the reasons that we are discussing on stage. That is no longer just about Lynch, it has implications to what you do for therapy. So high-risk patients morphologically, but MMR deficient, they can be observed. They're not going to be exposed to this toxic chemotherapy. So the implications are not just for Lynch now. So you'll be doing the patients a lot of favor by actually doing, and as we said, the 2-panel stain works just as well as the 4-panel stain. So if you just do the minor partners and they're intact, then you're done. And that'll be helpful in 97% of all your cases. So for those remaining 3%, you can do the entire panel, but you can cut down your cost and still screen everybody.
So to conclude, I think in minimal data set reporting, initially the MMR panel is optional, but you have to do the MSI panel. Okay, all our questions has been nicely answered and we have a next session online. So proceed for the next session. Thank you.
Thank you. We thank the panelists for their time and input. Thank you so much. Dr. Bell, can you hear us?
Yes, I can hear you. Can you hear me?
Yeah. Thank you, Dr. Bell, for staying online. We'll be connecting shortly.
Okay.
Yeah, we are allowing the yeah. Dr. Bell, can you please share your screen?
Yes. Sorry, one second.
For session 4, we would like to invite chairpersons, Dr. Amitabh Srivastava, Dr. Poonam Prasad Badani, she is Professor and Head of Department of Pathology and Lab Medicine, AIIMS Patna, and Dr. Supriya Sharma, Additional Professor, Department of Surgical Gastroenterology, SGPGI. Please join us in welcoming our speaker for this session.
Can you hear me?
Hi, Phoenix, can you hear us?
Yeah, I can hear you. Can you hear me?
Yes.
Okay.
I'm delighted to present the next speaker for this afternoon session. Dr. Bell did residency in Rochester, New York, was a fellow at Brigham and Women's Hospital, is a fantastic GI pathologist, a leader of the next generation of budding GI pathologists in the US. In a very short span of time, she's become the expert on difficult appendiceal lesion at Cleveland Clinic. And for those of you who don't know what Cleveland Clinic does, their annual volume for GI pathology is somewhere around 120,000 specimens a year. They have 15 or 16 GI pathologists, and there's 5 or 6 of them on service each day. I'm very thankful that she accepted our invitation. Don't be fooled by that young, energetic look. She was in the ER last night with her 3-year-old son with an ear infection. So many thanks for still agreeing to talk to us. Take it away. Thank you.
You're welcome. Thank you for the very kind introduction, and please forgive my voice. I'm recovering a little bit. But I'm delighted to be here this morning to discuss one of my favorite topics, appendiceal mucinous lesions, navigating the slippery slope from benign to malignant. I have nothing to disclose. So at our GI Pathology Consensus Conference, which we have every other day here, if someone sits at the scope and starts with the sentence, "I have an appendix," this is usually followed by a room full of groans. Now, personally, I love appendices, so you won't hear me groan, but I do find it interesting that such a small organ can stir up so much controversy. So as a brief refresher before we dive into the tumors, the normal appendix is an extension of the posterior medial aspect of the cecum. Most often it's retrocecal, however, it can be subcecal, it can be pelvic or juxtailial, and they average in 7 to 10 centimeters with a luminal diameter of 1 to 3 millimeters. Now, the function of the appendix is still up for debate. Some believe that it's a vestigial organ, so in other words, it has no function, while others believe that it has a role in mucosal immunity. Here's a nice gross example of a normal appendix with a smooth tan pink and glistening serosa. There are a few congested blood vessels, but overall very normal. And as pathologists, the vast majority of the appendices we encounter are removed secondary to acute appendicitis. And there are reported 233 cases per 100,000 population per year. And then the lifetime incidence of acute appendicitis ranges from 6.7 to 8.6%. Now, most commonly, as we all know, acute appendicitis is due to luminal obstruction, usually because there's a fecalith or some liquid hyperplasia. It can also be secondary to infection or inflammatory bowel disease, and very rarely it can be caused by a tumor. Now, how rare are appendiceal tumors? Well, there are approximately 1 to 2 cases per 100,000 population in the US annually. And although rare, patients most commonly present with signs and symptoms of acute appendicitis, thus my prior slide. Or these tumors can be incidentally discovered by imaging or colonoscopy. Our role as pathologists is very important in the management of patients with these tumors, as the most significant prognosticators are histologic subtype, tumor grade, and stage. However, clinical staging is complicated by the heterogeneity and rarity of the disease, the interplay of these prognostic variables, and variations in diagnostic terminology. So here, in the current edition of the WHO, benign appendiceal tumors encompass serrated polyps. So they include hyperplastic polyps and sessile serrated lesions with or without dysplasia. Now, adenoma was listed in prior editions of the WHO, however, it is not in the current edition. Our group will still render the diagnosis of adenoma, as will many other pathologists at institutions within the US, despite its lack of support in the current edition. Malignant appendiceal tumors include mucinous neoplasms, goblet cell adenocarcinoma, and neuroendocrine neoplasms. Today, our focus will be on the mucinous neoplasms. Appendiceal mucinous neoplasms include low-grade appendiceal mucinous neoplasms, or lamins, high-grade appendiceal mucinous neoplasms, or Hammonds, and mucinous adenocarcinoma. Gross examination of appendiceal mucinous neoplasms often reveals appendiceal dilatation and mucin extravasation, as is nicely depicted in this photo. Sometimes you can see areas with perforation. Less commonly and fairly rare, appendices may appear normal with minimal mucin within the lumen on sectioning, but then you find a mucinous neoplasm on pathologic examination. First, we'll start with lamin. It's a mucinous appendiceal tumor with low-grade cytologic atypia. They're most commonly discovered secondary to acute appendicitis. However, in some cases, a palpable abdominal mass or abdominal bloating may be noted. And lamins can progress to pseudomyxoma peritonei, which is the clinical term that describes the presence of mucinous ascites, which may be associated with omental caking, serosal deposits, and ovarian metastases. Now, the most common molecular alterations thus far described in lamins are KRAS and GNAS mutations. Microsatellite instability and BRAF mutations are infrequent. In addition to that low-grade cytologic atypia, lamins show key histologic features. Some of these include loss of the muscularis mucosae and fibrosis of the submucosa, as you can see in these photos. They may have flattened growth, as you can see in the top photo, or they may be more undulating in appearance, as you can see in the bottom photo. And they frequently show this pushing invasion, in which the tumor has a broad pushing front, almost like a wave making its way through the wall. Mucin dissection is often seen. Sometimes it can be very diffuse, like it is in this example. However, it may also be focal. Now, Hammonds are similar to lamins in that they show the same changes in the wall. However, the key difference here, as its name implies, is that the epithelium actually has high-grade cytologic atypia. So you can see hyperchromasia, increased NC ratios, loss of polarity, increased mitoses, etc. Now, importantly, there's no evidence of invasion. So, as in the case with lamins, also for Hammonds, it's important to entirely submit these lesions to exclude the possibility of an invasive adenocarcinoma. Similar to lamins, Hammonds harbor alterations in GNAS, however, they may also show TP53 mutations. Appendiceal adenocarcinomas are found in older adults, again, most commonly presenting as acute appendicitis. They may also present with abdominal pain or bloating. And it's defined by the presence of infiltrative invasion. So in some cases, you see irregular angulated glands within the stroma. In the case of mucinous tumors, you get these small mucin pools, and you can often see areas with this desmoplastic response, and you may or may not see tumor budding. Appendiceal adenocarcinoma may be mucinous or non-mucinous, which we will go into next. So mucinous appendiceal adenocarcinoma, it's defined by the presence of greater than 50% extracellular mucin. As I mentioned, this is seen as crowded mucin pools, and they're typically lined by cells with low to high-grade cytology. You may also see areas that have detached clusters of epithelial cells sitting within those mucin pools. Mucinous appendiceal adenocarcinomas are graded as G1, G2, and G3 from well to poorly differentiated. However, we don't really use G1 as we think that really only applies to lamins. So most mucinous adenocarcinomas are G2, lacking signet ring cells, and in some cases G3 if they actually do have a signet ring cell component. The precursor lesion most commonly associated with mucinous appendiceal adenocarcinomas is a serrated polyp, lamin, or Hammond. Here's an example of a mucinous appendiceal adenocarcinoma. At low power, you can see the tumor is composed of these small, crowded mucin pools that are destroying the appendiceal wall. At higher magnification, you can see that the epithelium has lining of cells with low to high grade cytology. And in other areas, you have these small angulated glands that are infiltrating the wall. Taken together, these findings are supportive of mucinous appendiceal adenocarcinoma. Non-mucinous appendiceal adenocarcinoma. I know that we're talking about mucinous tumors, but I just wanted to include this for completeness sake. Resemble colorectal adenocarcinomas. There are angulated glands composed of columnar cells with hyperchromatic nuclei surrounded by desmoplasia. Now, the WHO grading for these tumors lists it as low versus high grade. However, most institutions still use well, moderately, or poorly differentiated, which is also what is used in the CAP synoptics. So there is a discrepancy, but most institutions still use well, moderately, or poorly differentiated. And the precursor lesion is usually a tubular or tubulivillous adenoma. Here's an example of a non-mucinous adenocarcinoma. So on the left, you can see that there's an adenoma protruding into the lumen and surrounded by these atypical glands that are invading into the stroma and surrounded by desmoplasia, which you can see on higher magnification. Now, the current TNM staging for appendiceal tumors is seen here. It's fairly straightforward until you start to introduce lamins or Hammonds into the mix. So T1 and T2 stage are not applicable to lamins. Lamins confined to the muscularis propria are TIS. So it's not until the tumor invades the subserosa or mesoappendix that it becomes T3. And then once it invades the serosa, which includes extraappendiceal mucin or extraappendiceal cells, the tumor is T4A. If it directly invades other structures, T4B. Also important to note is Hammond is staged based upon tumor extent in the appendiceal wall. So it does include T1 and T2, and this is despite the lack of evidence supporting these designations. Here's the staging for N and M stage. Again, straightforward. I just wanted to point out that lamins and Hammonds do not show lymph node metastasis or M1C disease. So if this is the case, you're most likely dealing with a well-differentiated mucinous adenocarcinoma. How are these lesions managed? Well, most lamins and Hammonds are confined to the appendix. So they're T3 or less, and they're cured by appendectomy, so they don't require additional surveillance. Although studies have shown that a positive margin in lamins doesn't result in disease recurrence, some clinicians and surgeons may opt to perform additional surgery like a cecectomy. And then you have this gray area, T4A. And now, again, this is the presence of extraappendiceal mucin or extraappendiceal cells on the surface. And some studies have shown that localized acellular mucin has a low risk of disease progression, but that extraappendiceal cellularity is more likely to progress to disease. So the management of these lesions really varies from institution to institution, but most will have these patients follow up for regular imaging and surveillance. In contrast, the management for mucinous adenocarcinoma is different, as you can see here. Patients with TIS or T1 disease without adverse pathologic features, so that's without poor differentiation, LVI, or a positive margin, these patients get treated with appendectomy followed by surveillance. Then, if they have T1 or T2 disease with adverse features, or T3 or T4 disease, these patients get right hemicolectomy with lymph node staging. Positive lymph nodes or distant metastasis will lead to adjuvant systemic chemotherapy. Some patients who have perforation or localized right lower quadrant disease may also be considered for CRS and HIPEC, which we will discuss momentarily. So, moving on to pseudomyxoma peritonei. This is the clinical term describing the presence of mucinous ascites and mucinous peritoneal implants that most often arises from the dissemination of lamin. It can also be caused by the spread of mucinous neoplasms from other organs, like the colon, pancreas, stomach, gallbladder, ovary, etc. But most commonly, it's the appendix. And this occurs secondary to the quote-unquote redistribution phenomenon. This is when mucus and cells follow the normal flow of peritoneal fluid and get redistributed within the peritoneal cavity. The small intestine is often spared, but the pelvis, pericolic gutters, omentum, and liver capsule may be affected. The 5 and 10-year survival rates are somewhat low, 50 to 86% and 45 to 68%, but this really depends on grade. So how is peritoneal disease classified? Well, here are several classification schemes. You can see that there has been an evolution, Ronette categorized pseudomyxoma with high and low-grade cytology as diffuse peritoneal adenomucinosis, or DPAM. You may hear some people still use this term, but largely, at least within the US, it has gone away. And disease with complex architecture or infiltrating glands as peritoneal mucinous carcinomatosis. Bradley classified peritoneal mucinous tumors based on Ronette's classification, confirmed that tumors with low-grade cytology had a better prognosis than those with complex architecture or high-grade features, but changed the terminology to mucinous carcinoma peritonei, either low or high-grade. Lastly, Ms. Drahi found that tumors with high-grade cytology, but even without the complex architecture, had worse prognosis than tumors with low-grade cytology. He reclassified peritoneal tumors with low-grade cytology as peritoneal involvement by Lammen, those with high-grade cytology as well-differentiated mucinous adenocarcinoma, and those with high-grade cytology and complex architecture as moderately or poorly differentiated mucinous adenocarcinoma. Now, going back almost 10 years now, in 2016, the Peritoneal Surface Oncology Group International, or SOGI, published consensus terminology for appendiceal epithelial lesions and their peritoneal disease component. This consensus group was composed of appendiceal mucinous neoplasm experts from the fields of pathology, oncology, and surgery, and they classified peritoneal disease similar to the Ronette and Bradley classification schemes. So they really tried to encourage consensus on terminology. But one of the major differences was the addition of high-grade mucinous carcinoma peritonei with signet ring cells. So they added the signet ring cell component. And some of the features of these classification schemes were translated into the grading scheme for primary appendiceal tumors versus peritoneal metastasis in the current WHO. Now, the majority of lamins present with G1 peritoneal disease. This is characterized by hypocellular mucinous deposits or epithelium with low-grade cytology. Hammond's or invasive mucinous adenocarcinomas usually result in G2 peritoneal disease, which is hypercellular deposits with high-grade cytology and or infiltrative invasion, but there are no signet ring cells. And then lastly, signet ring cell adenocarcinoma or high-grade goblet cell adenocarcinomas result in G3 peritoneal disease. This is seen as mucinous tumor deposits with signet ring cells. Excuse me. It is rare, but there are cases that show a discrepancy between the grade of the appendiceal tumor and the peritoneal metastasis, which is why it's suggested to report the grades of each, as the grade of the peritoneal disease is more likely to affect prognosis. So with all these variations in terminology and grading, how do we report peritoneal disease? At our institution, we use low-grade mucinous carcinoma peritonei for grade 1, high-grade mucinous carcinoma peritonei for grade 2, and high-grade mucinous carcinoma peritonei with signet ring cells for grade 3. So essentially, we follow the SOGI definition. The presence of peritoneal disease is treated with cytoreductive surgery. This is when the surgeon goes in and they perform peritonectomies. They go over the diaphragm within the pelvis, and they excise or destroy any implants on the surface. So they remove anything visible that they see, mucin or lesion. This, in combination with hyperthermic intraperitoneal chemotherapy or HIPEC, in which the chemotherapeutic agents, for example, mitomycin C and oxaliplatin, are heated to 41 to 43 degrees Celsius, then they get circulated within the peritoneum. This is most often used in patients with low-grade disease. So the CRS plus HIPEC is used for patients with low-grade peritoneal disease, G1 or G2. While those patients who have high-grade disease, so typically G3, receive systemic chemotherapy. So here's an example of low-grade mucinous carcinoma peritonei, grade 1. You can see that the peritoneum is diffusely involved by acellular mucin, and there's very scant epithelium present. As you can see, I've highlighted the only foci in this photo in green circles. High power magnification of the epithelium shows cells with low-grade cytology. There's minimal enlargement, lack of hyperchromasia, no real nuclear irregularities. Given the scant cellularity and minimal atypia, these findings support G1. I will say there is a little bit of reactive atypia in this particular example because the patient had undergone CRS and HIPEC previously, but still remains low-grade disease. Here is an example of G2, high-grade mucinous carcinoma peritonei. As you can see, compared to the prior example, there's much more epithelium present, and you have more foci of this infiltrative type invasion. Higher magnification shows more complex architecture, and you have some tufting. You have higher grade cytology with these hyperchromatic and large nuclei, some with loss of polarity. So sufficient for G2 because you don't have any signet ring cells in addition to this. Lastly, this example shows an extensive signet ring cell population that's intimately associated with mucin, consistent with G3, high-grade mucinous carcinoma peritonei with signet ring cells. Okay, so we've gone through a lot already, but now we'll move on to the differentials for appendiceal mucinous neoplasms. So we have benign entities, including reactive changes and endometriosis with intestinal metaplasia. And we have neoplastic entities, which include some polyps, goblet cell adenocarcinoma, and metastasis. So we'll start with the benign entities. Reactive changes is one of the things that we receive the most consults for here at the clinic. The main question being, are these reactive changes secondary to diverticular disease, or is this a lamin? Reactive changes in the appendix most often occur in the setting of interval appendectomy or diverticular inflammation. And in interval appendectomy, patients present with acute appendicitis, but they can't undergo appendectomy at that time, usually because they have an abscess that has formed and needs to be drained and treated with antibiotics. And then they follow up in 8 to 12 weeks for the actual appendectomy. Histologic features that favor reactive changes include proliferative epithelial changes that lack definitive epithelial dysplasia. You typically have preservation of the lamina propria, muscularis mucosae. The extraappendiceal mucin and atypia is associated with an area of perforation, and you often see mural inflammation. So here's a straightforward example of an appendiceal diverticulum. You have an outpouching of the layers of the wall at the appendiceal tip. However, overall, the layers are preserved. Higher magnification shows mild crypt disarray and maintained lamina propria and muscularis mucosae. And the epithelium is hyperplastic and reactive in nature, but there's minimal nuclear enlargement, no stratification or contour irregularities, or increased NC ratios. Here's an example of a ruptured diverticulum. It's associated with this abundant mucin extravasation. And although this degree of mucin can be alarming, especially at low power, it's solely occurring at the area of perforation, and there's no evidence of loss of the lamina propria or muscularis mucosae, no evidence of dysplasia. So these findings are just compatible with a ruptured diverticulum, excuse me. Here's another example. This particular one showing an outpouching again at the appendiceal tip. You can see that there's extravasated mucin. This one's associated with some more inflammation. And there are areas of epithelial atypia in the form of nuclear hyperchromasia and elongation. However, the lamina propria and muscularis mucosae are maintained, and the atypia is only occurring at the area associated with the perforated diverticulum, supporting that this is reactive atypia in the setting of the diverticulum. So now we'll move on to endometriosis with intestinal metaplasia. This is very rare. It does occur. And you will always find areas that show conventional endometriosis. And then you'll also see varying amounts of this endometriosis with intestinal type epithelium. We'll go into an example in the next slide. The appendix is often distorted. You'll see fibrous obliteration and sometimes mural hypertrophy and elastosis. So here is a case that we received. It's a partial cecectomy specimen. They couldn't identify the appendix, but they described this big nodular mass adherent to the cecum. Histologically, you can see that there are these cystic spaces filled with acellular mucin and lined by epithelium. An evaluation of the epithelium reveals a mixture of cell types. So some areas demonstrate this intestinal type morphology with goblet cells. Other areas look more Mullerian type with absence of definitive cytoplasmic mucin, and you have areas of apical cilia. Other areas of the epithelium look more hypermucinous. However, there's minimal reactive atypia. There's no evidence of cytologic dysplasia. Throughout the rest of the specimen, there were these rare foci of conventional endometriosis, as you can see here, highlighted by this nice endometrial stroma surrounding this Mullerian type epithelium. And immunohistochemical stains were performed. I am highlighting this area here that I circled in green, and it showed that the epithelium in this region was positive for PAX8, and then the stroma highlighted nicely with CD10, compatible with endometriosis. In other areas where you really lack that endometrial type stroma and have the epithelium that is intestinal in nature with the goblet cells, we also performed stains. The CD10 is still positive in this area, which is interesting, and then it also highlights with CDX2. So taken together, the constellation of findings support endometriosis with intestinal metaplasia rather than a low-grade appendiceal mucinous neoplasm. Now we'll move on to the neoplastic differentials. So I know we already talked about how this entity is not in the current edition of the WHO, but we still actively use it. Appendiceal adenomas are found in middle-aged adults. They have a female predominance, and they are usually incidentally found. They are limited to the mucosa, and they don't usually cause luminal dilatation. Here's a nice example of appendiceal adenoma. As you can see, it resembles a conventional colorectal tubulovillous adenoma. It's confined to the mucosa and composed of epithelium lined by cells with hyperchromatic pencilate nuclei. Moving on to serrated polyps, these also tend to occur in older adults with an equal sex predilection. They encompass hyperplastic polyps and serrated polyps with or without dysplasia. They are mucosal-based lesions that have this serrated architecture, and they often harbor KRAS mutations. Serrated polyps, also known as sessile serrated lesions, do not usually show luminal dilatation, and they have a polypoid or circumferential growth. They are composed of elongated crypts with serrations that often extend to the crypt base with a characteristic crypt dilatation, intact lamina propria, and muscularis mucosae. They can be dysplastic. Typically, they'll show conventional dysplasia. However, rare cases with serrated or TSA-like dysplasia may also be seen. Here's an example of a serrated polyp. At low power, you can see that you have these epithelial serrations, and at higher power, you can see that those serrations extend to the base of the crypts with crypt dilatation. So this is a small serrated polyp or sessile serrated lesion without dysplasia. Oh, I apologize, this is not projecting very well, but this is an example of a serrated polyp with more florid epithelial proliferation. It has this villus architecture with serrations extending to the base. In some fields, you can see that it transitions to areas with this more conventional adenomatous dysplasia on the right. And the lamina propria and muscularis mucosae are maintained, supporting the diagnosis of a serrated polyp with dysplasia. Sorry. Okay, moving on. Now we have goblet cell adenocarcinoma. These tend to occur in older adults, again, presenting with acute appendicitis, and they're composed predominantly of these goblet-like mucinous cells arranged in tubules or clusters that circumferentially involve the appendiceal wall, and they often spare the mucosa. They can be low grade, again, characterized by this tubular growth, or high grade, which may be seen as single cells, single file cords, diffuse sheets of cells with high grade cytology. But to be classified as a goblet cell adenocarcinoma, you must have a low grade component. And we'll get to why that is important in a few slides. Goblet cell adenocarcinomas are graded upon the proportion of tumor with low and high grade patterns. So G1 has this tubular or clustered growth making up greater than 75% of the tumor. grade 2, 50 to 75%, and grade 3, less than 50%. These patients will undergo right hemicolectomy and may undergo CRS or HIPEC if they have peritoneal disease. Here's an example of a grade 1 goblet cell adenocarcinoma. Here on the right, you can see that you have these small tubules and clusters of cells, and they're really involving the appendix wall circumferentially and sparing that mucosa. You want to consider a goblet cell adenocarcinoma in your differential when you're diagnosing a mucinous appendiceal adenocarcinoma, particularly in grade 3 cases. So for example, as you can see here, the low power view of the tumor, it looks mucinous, perhaps some small mucin pools with these poorly differentiated cells and signet ring cells. However, at high power, you see that there are foci that start to show this more organized growth. Higher magnification reveals that there are actually these small tubules. Thus, this is a grade 3 goblet cell adenocarcinoma rather than the mucinous appendiceal adenocarcinoma with signet ring cells. Excuse me. Okay, lastly, I want to address metastasis. I'm not going to go through this whole table, but you can see that this is the immunoprofile of metastatic peritoneal tumors and their characteristics based on primary site. So the most common setting in which we try to determine the site of origin usually is when the tumor is involving the appendix and the ovary, and you're trying to figure out if it's a primary ovarian lesion or primary appendiceal lesion. And as you can see for the appendix and the ovary, their immunoprofiles overlap in some areas. However, studies have shown that SATB2 is frequently positive in appendiceal tumors rather than ovarian tumors, and that CK7 is usually more diffuse in ovarian tumors rather than appendiceal tumors. Now, of course, not all tumors read the book, and so this doesn't always end up being the case. I've seen, very weak positivity for both of these. So you really want to take into account the whole clinical picture. For example, how large is the patient's ovarian tumor if they have one? Is it only involving one ovary? Is it involving both ovaries? So you just have to remember to keep those things in mind. Other mucinous tumors to consider in the differential include pancreatobiliary mucinous neoplasms, typically SATB2 negative, and can show SMAD4 loss in up to 50% of cases. Others to consider also are colorectal mucinous adenocarcinomas, which stain the same as appendiceal tumors, gastric mucinous adenocarcinomas, which have variable CK20, CDX2, and SATB2 staining, and lastly, urachal mucinous neoplasms, which will typically be uroplakin-2 positive, but that can still be variable or weak. Okay, so now I've included 6 cases that we've received here for discussion and to kind of reinforce what we've talked about, because it's a lot of information over a short period of time. So case 1 is a 46-year-old female with acute appendicitis. At low power, you can see that the appendiceal tip is here on the left, and then there's this area of perforation associated with abundant mucin. You can see also at low power that this part of the epithelium is showing maintenance of the lamina propria, while it seems to be lost on the right side of your screen. And then if you look on high power magnification of some of the areas of the epithelium, you can see that it looks flattened with some calcifications in the wall. And then in other areas, it looks more undulating, but it's showing that low-grade cytologic atypia. So that, in combination with the loss of the lamina propria and muscularis mucosae, support the diagnosis of a lamin. And given that it is perforated and showed acellular mucin on the surface, it's consistent with a T4A lamin. Here's case 2. It's a 50-year-old female with abdominal pain. As you can see, there is luminal dilatation, again with mucin extravasation and epithelium going onto the surface of the appendix. There are some smaller mucin pools within the wall, and you can't make out any normal appendiceal mucosa. Medium magnification shows some mucin dissecting more superficially into the wall beneath this epithelial proliferation. And then high magnification shows almost a cribriform type architecture. The cells are piling up on top of one another, nuclei are hyperchromatic, some irregularities and loss of polarity. So these changes are really beyond that of low-grade dysplasia. So it's consistent with a Hammond, a T4A. And I just wanted to note here that there's no definition for the amount of epithelium that has to show this high-grade cytology. So it's really quite subjective when you're trying to make the decision when you're diagnosing a Lammen versus a Hammond. But in this case, there's a substantial amount of epithelium that was involved, so we believe that this is sufficient for a Hammond. Here's an appendectomy from a 58-year-old female who had right lower quadrant pain. At low power, you can see the lumen is overtaken by this epithelial proliferation with this villus architecture. Medium magnification shows this abundant serrations extending to the base of the villi. Areas with cryptdilatation are seen. And then on the top right, you can see that there are areas that look more like conventional type dysplasia, in addition to areas with many ectopic crypt foci and more eosinophilic type cytoplasm. So overall, these features are most compatible with a serrated polyp with TSA-like dysplasia. These are very uncommon cases, but I thought this was quite a beautiful case. Case 4 is a 62-year-old male who failed non-operative management for acute appendicitis. At low power, you can see the epithelium looks fairly intact, but there's mucin on the surface here and changes in the wall, suggesting that there was some type of prior rupture. In other sections, the epithelium looks more proliferative with this almost myxoid appearing stroma within the mucosa and submucosa, and there's submucosal fibrosis. Other sections start to show attenuation of the epithelium. It looks more hyperchromatic here, but this is associated with an area of prior rupture. As you can see, there's mural disruption, mural inflammation, and a serosal fibroinflammatory proliferation. Higher magnification of the area with this more proliferative type epithelium resembles changes you see in a hyperplastic polyp. There's this goblet cell-rich epithelium that lines the crypts, but it's still separated by lamina propria that has a myxoid appearance. And the epithelium shows focal areas with this cytoplasmic eosinophilia. However, no epithelial dysplasia is seen. So overall, there is this proliferative type change, but the wall of the appendix is preserved. There's mural inflammation. There's no evidence of dysplasia. So these findings support reactive changes in the setting of an interval appendectomy. You may have heard some people refer to these changes as post-inflammatory mucosal hyperplasia. We don't use that, but just so you know. Okay, case 5 is a 70-year-old female with acute appendicitis. Again, at low power, you can see that there's this luminal dilatation, and then at the appendiceal tip, there's abundant mucin. Higher power view of the epithelium within that area of luminal dilatation shows you have this low-grade cytology, loss of the lamina propria muscularis mucosae, so you're wondering if this could be a Lammen. But then if you go back and you really look at the mucin that's at the appendiceal tip, you can see that it's actually in that small mucin pool pattern that we discussed previously. Looking higher within these mucin pools, you can see that they're lined by this abundant epithelium with low to high grade cytology. So these features are consistent with a mucinous adenocarcinoma. Sorry, the staining due to the mucin is a little prominent, so it's hard to see. And then case 6 is a right oophorectomy from a 53-year-old female with an ovarian mass. So you can see at low power that the ovary is involved by this mucinous process. There's some epithelium here involving the fallopian tube. And then looking at high magnification, you can see that it's involved by this low-grade mucinous epithelium. So immunohistochemical studies were performed. It showed that this epithelium was negative for CK7 and diffusely positive for CK20, STAT-B2, and CDX2. Taxate was not performed, and estrogen receptor was also negative. So the operative impression was a dilated appendiceal tip in addition to this ovarian mass. The appendix was entirely submitted for pathologic examination. However, they only noted that it was mildly dilated, and they describe adhesions with acellular mucin and no evidence of a mucinous neoplasm. Unfortunately, I didn't get to see the appendix for this case, but they said it was entirely submitted and they couldn't find a neoplasm. So how would you diagnose this? Well, in this case, the pathologist signed it out as a low-grade mucinous neoplasm involving the ovary. See comment. And although the appendix had been favored, given that there wasn't a lesion identified in the appendix, there rose a possibility that it could be coming from another primary gastrointestinal site. So this is usually when you need to do more radiology, a colonoscopy, etc., to make sure you're not missing another gastrointestinal neoplasm. Otherwise, the features would be most consistent with an ovarian mucinous borderline tumor. Interestingly, I looked the patient up the other day and they subsequently, developed pseudomyxoma peritonei, which you typically get from an appendiceal lesion. However, I have read that you can get them with these ovarian mucinous borderline tumors as well. But I just thought this was an interesting case because it's not, very straightforward. So it's not always A, B, C to get to a diagnosis. So in conclusion, pathologists play a key role in the diagnosis and management of appendiceal lesions. So number one, the diagnosis of the primary lesion. So diagnosing something like benign, like a ruptured diverticulum, results in drastically different management than diagnosing a lamin. But clinically, surgeons often see the same thing, like a dilated appendix with mucin. So we really hold the final say, which is why it's important to not overdiagnose a lamin, mistake it for a diverticular rupture, for example. Grading of peritoneal disease. Again, surgeons see mucin or lesions within the peritoneum, but we have to provide the grade. So grade 1 and grade 2 will result in CRS and HIPEC, while those who have grade 3 disease will get systemic chemotherapy. And lastly, but most importantly, communicating with the patient-facing clinicians. So the nomenclature and the diagnosis is confusing for pathologists and surgeons alike, with terminology that varies between pathologists at the same institution, between institutions. So it's important to have open discussions to ensure that everyone treating the patient is on the same page. And finally, lamins are classified as separate entities from that of adenomas, serrated polyps, Hammond's, and adenocarcinomas. However, as we've seen, they have significant histologic overlap. This classification system will likely continue evolving. Hopefully, we'll be seeing some changes in the next edition of the WHO, which I believe is supposed to come out next year, but we'll have to cross our fingers for that. And with that, I thank you for your time, and I'd be happy to answer any questions.
Can we take a break and then have the questions in the next session? सर अभी 15 मिनट का ब्रेक कर देते हैं अभी 15 मिनट का ब्रेक
Phoenix, would you prefer questions now, or should we were scheduled? We are a little behind, so we were scheduled for a 15-minute break. But then you, Arthur, and I, and others are going to be here and meet the experts, so we can take questions then.
Oh, yeah, that sounds good.
Okay, so we'll let you go recover for 15 minutes, and then we'll be back online.
Okay, thank you.
Okay, perfect. Okay.
Everyone, please wait. There is going to be a live question answer round.
And then we'll join back after a 5-minute tea break.
ये आतुर सिंह, फिनिक्स बेव, अरुण अरुण। बट अभी तुमने अपना कैमरा बंद करा। ये माइक का असर अभी हटाया हुआ है, तो इशू कर रहा है। पीछे से करके लेआउट को चेंज करना।
दो ही लोग हैं मैम। सर का अभी ऑफ हो गया तो Good morning, Dr. Rathur. Can you hear me?
Yeah, I can hear you fine.
Yeah. So just to let you know, we have given a 10 minutes break for the tea. So we're just waiting for the participants to come in. So that
Sounds
is
good.
there'll be
Thank you very
about
much.
10 minutes before we start. Thank you
Thank
for
you.
joining.
Thank you for having me.
Yeah.
Arthur, Phoenix, can you hear me?
Yeah.
Perfect.
Yes.
You may not be able to see us. We are here in the far corner. I'm
I
waving to
see you
guys.
waving.
Okay, so I think we'll get started. Um,
Yes, we can see you.
Sorry? Yeah, they can see me.
Yeah.
So with me here in the session is Professor Prasenjit Das from All India Institute in New Delhi. We've beaten down the audience during the day with a lot of GI pathology from 9 o'clock till this is 5 p.m. past 5 p.m. now. So we'll see how interactive this gets. So first of all, thank you to both of you for, I know both of you had different challenges and still managed to join us. So thanks a lot. Arthur with technical glitches, and Phoenix seems to have viruses following her wherever she goes. So thank you so much. And Arthur, maybe I start with you. So I learned one new thing today, that the ampulla is just 1.5 centimeter, not a millimeter less, not a millimeter more.
It's completely arbitrary, right? And so that's
And
the challenge. I mean, if you look in a couple of other textbooks, you can see it at about 2 centimeters. So a neoplasm within basically within 2 centimeters of the ampulla itself should be considered an ampullary primary. But I think you have to have some criteria, but sadly, it's completely arbitrary.
Yeah, it made me wonder which nice European island they went to decide it's 1.5 centimeter in diameter.
Probably the same island that they decided to do, 30% as an adenosquamous for squamous differentiation or something of the similar sorts.
Yeah. No, so it was a very nice talk. The other thing that struck me were your beautiful whole mount sections. Do you do that for most cases, all cases, or just for the ones that you're prepping for conference?
No, I think we do that. We do that routinely for all of our surgical resections. And so I think there's many ways of opening up a pancreas that may involve either a pancreatic primary, a bile duct, an ampullary, small intestine. But unfortunately, you never know until you open it up where that lesion is. And so in order to maintain conformity amongst our physician assistants, we decided that we would just always open and bivalve along the ductal system. So we do that for every Whipple. We do that also for our distal pancreatectomies, where we cross-section it right through the main pancreatic duct, going through the spleen and bivalving it that way as well. Just more for conformity and then looking at anatomic location, as opposed to bread loafing the specimen altogether.
Yeah, I know the bread loafing stuff is more popular, at least in some parts of Europe. I'm not sure about all parts of Europe, but
No,
do you
certainly if
speak
you
briefly about like the pitfalls of one over the other? I mean, I guess if it's a solid lesion, the bread loafing may not be that bad. If the cystic lesion, opening around the duct has so many advantages for looking for communication with the duct and so on, that it's a much better way. So do you have a preference, solid versus cystic, or people used to? I know that there are some people here in the audience who trained in UK, and I met Fiona some years ago at a conference in Kochi, and of course they were big on like the bread loafing the way of grossing pancreas. So can you just have a 2 minutes on pros and cons of either approach?
So I think that there's multiple ways of opening up a Whipple specimen itself. And as you mentioned, bread loafing. So Carolyn Verbecki had really pioneered the idea of really bread loafing the specimen. Volkan Adse in Turkey really loves the idea of orange peeling. So basically removing the surface of basically the peripancreatic soft tissue first and kind of unraveling the pancreas overall. I think there's many pluses and minuses. When you know exactly where the lesion is located, you have really good radiographic endoscopic correlation of where everything is. But sadly, our radiologists or gastroenterologists are not there yet. They don't have great imaging techniques. Oftentimes, they may think it's a biliary process when it's really an ampullary process. And it's very common for them to unfortunately miss where that lesion is, especially in the setting of pancreatitis, where a lot of times these patients are presenting with pancreatitis due to an obstructive mass lesion. I think that certainly there are times where bread loafing is quite important, especially when you're doing it or when you're evaluating it in respect to maybe certain margins like the uncinate vascular groove. Maybe even more now, so when we're starting to see more jump grafts around the superior mesenteric vein and portal vein, which I know a lot of venous reconstruction was actually pioneered in India. And there's some very amazing surgeons that are able to do significant jump grafts across the superior mesenteric vein, across the portal vein. And there, it may very well be a good idea to do really a bread loafing, because then you get nice cross sections of that clear soft tissue margin and invasion into the vein itself, which could very well be an important prognostic biomarker, but just not enough data yet.
Yeah, I mean, I think the reason I thought about you to give the talk when we were talking with Professor Jain, putting something together for the audience here. There's a lot of, at least I hear a lot of quote unquote periampullary carcinoma here in Lucknow. And I always wondered whether it's lack of detail about the pre-op imaging, whether it was a stricture in the distal common bile duct, was it just a mass in the uncinate or the head of the pancreas, was it a polypoid lesion in the duodenum on endoscopy, and is it really a difference in prevalence, or it's basically represents a wastebasket where you don't want to commit it's bile duct or pancreas or duodenal or ampullary, and it's 4 tumors that can occur in the same location, and so everything becomes very ampullary. So I like the beautiful gross images you were showing, and hopefully that helps people who were here in the audience listening to try and tease out. Obviously, I mean, we didn't talk a little more about precursor lesions that might help. We saw nice examples of the ampulla, but dysplasia in the bile duct versus Panin 3 versus a duodenal adenoma on the surface, trying to help you decide which invasive carcinoma came from where. So that was a very nice, comprehensive kind of grossing and workup algorithm that you gave.
I appreciate it.
Yeah.
Yeah, in our department also, some faculties prefer to do bread loafing, and I advise all to cut along the ducts, which because we also get many periampullary carcinoma where it is not defined from where the tumor is arising exactly. And pathologist, when we cut along the duct, it is quite easy to pinpoint where from it is arising. But when we are doing bread loafing, though it is very good for the margins, but to pinpoint from where it is exactly arising, I find it very difficult sometimes. So
yeah, I mean, I think that's what Arthur was referring to, that if you have good pre-op imaging, you know what the tumor most likely is, then bread loafing can work. But if you're kind of going in cold, trying to figure out what that is, maybe just cutting along the duct and seeing different locations and landmarks is good.
Exactly.
There's a question from the audience, which I'll repeat, Arthur. So, sorry, go ahead. You were saying something.
Yeah, I think we're also entering an age of a lot of neoadjuvant therapy, and I think that's really important because, that really changes where that lesion is after therapy sometimes, meaning where the residual tumor is and where it's not, and where maybe a scar might be present, especially if you have radiation. If you have radiation and you've radiated that whole area, which we do sometimes for some duodenal and ampullary cancers now as well with SBRT, I mean, that literally creates just a field of scar tissue where it's almost impossible to grossly identify where that mass lesion is until you really open up along the ductal system, meticulously look at it microscopically, taking standard sections. It can actually be quite difficult sometimes.
Yeah, and those specimens create another challenge. I was talking about precursor lesions. I mean, there's going to be so much atypia that you can overcall either dysplasia or pan and so on. There's a question from the audience which you won't be able to hear, but maybe I'll repeat. Phoenix, could you hear the question?
No.
I wasn't ignoring you. I was going to come to you after Arthur, but
That's okay.
the
No,
audience.
I have a really quick question for you, Amitabh. At MSK, do the PAs take your margins on Whipples? Did you hear me? No, that was for you. I know at UPMC, since I was there, that we take them ourselves, but at MSK, do the surgeons do it or do the PAs do it?
No, we do the surgeons don't do the I mean, they'll sometimes send
I only ask because the surgeons take the margins here and it's really frustrating to me.
yeah.
And I would like to change that.
Well,
So I was just-
sometimes during the surgery that we might get like just a sliver as a duct margin. More often than not, they'll just send the whole specimen and say, "Can you just report the neck margin?" The question for you, Phoenix, from the audience was that if a surgeon sends in a dilated appendix for a frozen, what information do you feel comfortable providing them, other than the diagnosis, of course?
Yeah, well, usually they won't send these for frozen section, like the primary appendectomy, if that's what you're talking about. Sometimes they'll send like deposits that they find that are mucinous if they suspect that the patient is having this mucinous neoplasm, and we can diagnose, yes, it looks like there's mucinous epithelium on the peritoneal biopsy, for example. But they typically won't send like a straight appendectomy to us for frozens. We would say, defer to permanent, if that was the question.
Yeah, yeah. Arthur, do you get any kind of this lamin type things for frozen at all?
Yeah, I mean, every now and then we'll have a surgeon say that I saw something interesting in the appendix. And if it maybe turns out to be a goblet cell adenocarcinoma, they're more indicative of trying to say, okay, well, maybe we should do more of a cecectomy or right hemi even as well, that they don't want to come back for a second procedure. Unfortunately, there are many times where it's best just to have the permanence, especially if you're looking for displaced lesions, et cetera, because, cutting into that specimen and really, honestly, compromising it can really be detrimental in our ability to stage it and what the next steps for that patient are. And so we try to push back as much as possible and wait for permanent. It shouldn't be much of a contraindication to go back into that patient's abdomen again, for the most part. So, yeah.
Yeah, we tend to do the same, to tell the surgeons it's not a good idea, that if it's a lamin, the most we can do is give you a proximal margin. There's no prognostic significance. We know of a positive proximal margin. If it's truly a lamin, what it's going to do is mess up the specimen, and then you won't be able to tell whether it's really a T4A or not a T4A, and then you'll write a long note, which is not going to be very helpful. So it's better to just wait and let you process the specimen for permanence and not do a frozen.
I had a question for Dr. Bell. Regarding this is a very practical issue. I face sometime to differentiate between PMP grade 2 versus 3. That is based on the signet ring cells. If there are many, that is not a problem. But occasionally we see some occasional signet ring cells. We need to confirm that. We ask for the step cuts and then keratin stains. By the time it lands up to the IHC lab, those cells are gone. So what you do in such cases, we should give a benefit of doubt, or what to do exactly?
Well, that's a very good question. It's not something that happens infrequently, but I would do the same thing that you do. I would definitely, if it was only rare, make sure they're not mucophages. So I would do like a CD163 or a CD68 as well as a keratin. It's unfortunate if it does get lost on deeper levels. I think in that situation, then I would be descriptive, would say signet ring cell morphology, see comment, and the comments say that you tried to decipher whether these were true signet ring cells or mucophages, but it was lost on deeper sections, just so that they know that there was some type of cell there, in case they need to treat this person in the future. Usually the signet ring cells happen in appendiceal lesions that are higher grade. So if you have a signet ring cell carcinoma or a goblet cell adenocarcinoma, so I'd be more suspicious if that was the primary appendiceal lesion, and I would probably back off more if it was, a lamin or a Hammond or well differentiated mucinous adenocarcinoma, for example. But that's a very good question.
Arthur, your thoughts?
Yeah, I mean, I think that a lot of so basically the appendix in the WHO has always been very, and most of the WHO chapters have been really pragmatic, and it's based on the H&Es. And so really focusing on the H&E rather than ancillary studies, I think that's where the trouble becomes. the presence of grade 3, I think is, and I'd love to hear what Phoenix thinks about grade 3. The cutoff for grade 3. What is the cutoff for grade 3? I've heard many people say 10% of cingulate ring cells. Question is that 10% out of the whole submitted lesion or a focus that's 10% on a slide? And that's the challenge I have with the honestly the grade 3s. And it's almost eye of the beholder sometimes as well.
Yeah, I agree. I don't think anyone agrees on that. I don't think there are studies to really support what percentage thus far. So that's why I typically am more descriptive in my diagnoses.
Yeah, and I mean, I think there's different scenarios that the whole peritoneal involvement in mucinous lesions is conflated by so many different things. It's not just lamin. The studies included all kinds of different tumors. And of course, if you include metastatic colorectal cancer or pancreas cancer or something else, the two signet ring cells may actually be important. And if it was a lamin, you almost never see G3 disease as progression. So those really are carcinomas that were carcinomas to begin with. And then having these arbitrary thresholds doesn't really matter because it was the same tumor all the way from the beginning. I mean, I know that the WHO is working on the next edition, and I think the 10% rule will make it into the final draft. But as you said, it may solve the problem Prasanjit just brought up, like it was 2 cells, then you don't have to worry about, you can call it G2. But it's not based on solid evidence. But at least there's some guideline on if you were worried and you lost those 2 cells on an IHC stain, don't bother about them because that was not 10%. I'm curious because I mean, I know both of you were together at UPMC, so it may be redundant, but is the peritoneal classification, do you use, I know Phoenix is laughing because they probably have 3 different ways of signing out the disease at one clinic. Do you use, and Arthur, for those of you who don't know, trained at Hopkins, so they were the pioneers for disseminated peritoneal adenomyocinosis, and then others prefer to call carcinoma and different ways of calling carcinoma. So the practice at UPMC currently is uniform, and you use the carcinoma nomenclature, or you stuck to your Hopkins roots?
Yeah, that's a really good question. I'd say we've moved over to honestly really using PMP, using, grading as an adenocarcinoma. We don't use many of the old nomenclature that Hopkins originally pioneered. And it was really pioneered based on really our GYN pathologists at Hopkins at one point in time. And then thereafter really kind of, be honest, they were trying to deal with the mucinous neoplasms of the ovary versus the appendix and trying to create nomenclature from that. But then they slowly or quite rapidly realized that that's probably incorrect in general. And so hence they've dropped that as well.
No, and it's been a problem. I know I've followed at 3 institutions that I've worked at in the past 20 plus years. Each had their own way of diagnosing and classifying peritoneal disease in the setting of lamin. At Brigham and the Farber, it was just peritoneal involvement by lamin, which was simple. And as soon as you said carcinoma, the oncologist thought this patient needs systemic chemo. You go an hour away to Rhode Island, and they use the low-grade, high-grade carcinoma nomenclature. And then at Memorial, they have their well-mod and poor-diff mucinous adenocarcinoma nomenclature, which is different from everything else. There's no G1, G2, or G3. So each report that I sign has a note, clarifying what it means. If I say well-diff mucinous adenocarcinoma, my note clarifies that if this were Hopkins, this is what it was. I don't mention the institution, but I basically give the synonyms people have used so that if the patient goes somewhere else, they know what to do and what I mean.
Yeah, I mean, I'm impressed about the amount of nomenclature, but our surgeons as well have also become confused with all the nomenclature that's out there. Because obviously it's in the literature as well. There's multiple names for really the same entity. where it becomes challenging for like, how do you treat a patient? Do you give chemo or not? Is it really an adenocarcinoma or not? Is it going through disseminated spread from the systemic circulation, or is it just through peritoneal and that's it? And one of the things that we've been doing more and more of is really using stains from the point of view of surrogate biomarkers of molecular alterations. And so P53, SMAD4, because even you and some of your papers have shown that, sometimes you can have P53 alterations associated with bad appendiceal adenocarcinomas. And same, sometimes a very small subset can have SMAD4 loss. And so we've been even using those types of stains in general, as opposed to just doing molecular testing on every appendiceal cancer, which we probably are starting to do that as well. And I'm sure Memorial's doing that too, that we're trying to use that to even sometimes stratify these patients.
That's good to hear, because Phoenix alluded to her in her talk about the minimum criteria for diagnosing Hammond, and at least in our place, I've been pushing others, and I've been using P53 to, if it's a small focus, and we know that it's not something, it's subjective, and it can be one person's Hammond, and others may say, well, it's still in the spectrum of a Lamon. But if you can show a clone that's clearly distinct from the background and its mutant P53 signature, then people feel more comfortable. At least it's a little more reproducible, that it's really a lesion that has progressed and you can call it a Hammond. So in sort of minimal volume cases, I think those ancillary stains can really be helpful. Any other questions from the audience? Yes. I don't think there would be, I'll let Arthur handle this. The question was, in a minimal resource setting, is there a stain, or is there a test that can help pick out ampullary carcinomas?
Now, well, so if you look at some of the literature in a minimal resource setting, that's a little challenging though, but if you look at some of the literature from a molecular profile point of view, they had mentioned that there are certain alterations that are somewhat specific for ampullary, and that is an ELF3 mutation, but that has not panned out, actually. Many people don't see that. It's a very rare alteration. The honest truth is, an ampullary cancer, as I mentioned in my talk, is that it has multiple lineages. It can be intestinal, it can be pancreatobiliary, it could be actually a stem cell niche, which can give really, is pluripotent in itself, where it could give lineages and multiple lineages. And maybe that's where our pancreatobiliary and mixed type adenocarcinomas are really arising from. I would say that the best stain to use, though, is an H&E. And honestly, that's probably the best way of going around it. I mean, I've seen even some of our intestinal type adenocarcinomas morphologically look beautifully intestinal type, exophytic precursor neoplasm, but then stain with immunostains like a pancreatobiliary phenotype, which then gets me totally confused that is the oncologist truly going to treat the patient appropriately as a pancreatobiliary subtype, or rather, can that patient really negate some of the toxic effects of that chemotherapy and just go for something a little more milder with an intestinal type, kind of colon type kind of treatment overall?
Yeah, and it's interesting. I mean, I was talking about gastric cancer in the morning and saying the same thing, that most of these well-differentiated things that have been described, the pyloric gland type or the funny gland type, and the deeply invasive ones start looking more conventional. And I wonder if it's the same phenomena in the ampulla too, that, I mean, it can look intestinal because it's closer to the surface or the duodenal lining, whatever. And then when it starts going towards the pancreas, the environment kind of forces it to change phenotype and adapt, and it looks more pancreatical biliary. Do you do a panel of stains on all your ampullary ones to try and subclassify?
Yeah, as per the well, basically CAP recommendations as well as NCCN guidelines in the United States, there had to be some uniformity, and so that has been a recommendation, and so we've adopted that, where we stain every ampullary with the 4 stains that I mentioned, which is literally MUC1, CK20, CDX2, and CK20 itself. And so, or MUC2, excuse me, I might have mentioned that. And so basically those 4 stains overall are what we use, but there are a lot of ambiguous cases. I mean, up to 20% of our cases are ambiguous, which is not helpful. And so in my personal opinion, I think that these are stains that are a good start, But the problem is they were developed back in 2014, and we learned a lot about ampullary cancers. The sad thing is we don't have better stains. We don't have better subclassifying, and we have no data to support that if we subtyped based on additional stains, that would improve patient care. And so there's just because it's a rare neoplasm with respect to pancreas and cholangiocarcinomas, it's just the unfortunate problem that we're dealing with is we just don't have great biomarkers for classifying that would truly affect patient care from a treatment perspective.
And do the oncologists use that in any way to change the first line therapy at all?
Yeah, for the adjuvant therapy, they want to know what should be the first step, especially in an octogenarian, an 80-year-old patient, where you know that you're going to give FOLFIRINOX to that patient if it's a pancreatobiliary type, but you want to be sure it's truly a pancreatobiliary type because you know the side effects of modified FOLFIRINOX. Now, that being said, we're doing more and more molecular testing here in the United States because we know that the ampullary adenocarcinomas, even if you have a stage 2, well, honestly, a stage 2 ampullary adenocarcinoma, that could very well metastasize in the patient's, honestly, lifetime. And so knowing maybe the molecular profile beforehand might be helpful. And then we're using that data to leverage also whether it's pancreatobiliary type and intestinal type. And so we're not using that, and I didn't mention that because I don't think it's commonplace, but it's known that many of the intestinal types are typically p53 mutant, beta-catenin mutant, so following, the Wnt pathway, while the pancreatobiliary type are typically RAS mutant, MAP kinase mutant. And that makes sense from what we understand from colon cancers versus literally just pancreatic cancers. And so we are using some of that data to the point where if we find a BRCA2 alteration or a PALB2 alteration, we're leveraging that information to say, okay, let's give a platinum-based regimen because that patient is in theory going to respond better. But sadly, there is no basket trial or trial data at all to support that with ampullary cancers specifically.
Phoenix, do you type all your ampullaries at Cleveland Clinic or no?
Sometimes.
She's been corrupted, Arthur.
Obviously, I would.
Yes.
So, in order to differentiate between the scientific or type of origin, whether it was a writing from the appendix, side to the protein, or it was the ovarian pathway. So, how to confront this challenge?
Always the appendix. The question, Phoenix, was if you have a woman with bilateral ovarian involvement and an appendiceal tumor, how do we tell? Was there a panel of stains that can help decide whether it was ovary going to the appendix or appendix going to the ovary? And I answered for you, and I said it's always the appendix.
Yeah.
So there was a very nice study. We were talking throughout the day about the importance of grossing. So there's a very nice study from Robert Scully from the Mass General Hospital from years ago, and actually controversial at the time because he suggested his conclusion was a series of similar patients, and he concluded that all these cases are essentially appendiceal mucinous neoplasms coming to the ovary. And the reason was just looking at the gross appearance of the ovarian involvement, a lot of surface mucin, very different from primary ovarian mucinous neoplasms, which would be mucinous cystadenomas and borderline tumors. So it was a very elegant, routine H&E study, looking carefully at the morphology and making a conclusion that we now know based on immunohistochemical studies and molecular profiling that he was right all along.
Though we did not discuss the neuroendocrine tumors today, but Dr. Sinki has a lot of experience. So I am talking about the mean criteria. We know the articles which say that now 30% cutoff is not absolutely necessary. And next WHO, we don't know. So what we should follow? Should we report mean if it is less than 30%? Undisputed?
Yeah, so the WHO, I can tell you what the answer will be, that there was not a better cutoff. So it's going to remain 30%. So the endocrine WHO came out, I think last week. Everyone started getting, all the authors started getting their copies, so I wouldn't be surprised if it's now available for purchase. But it is also available online. Basically the GI WHO, as Phoenix had mentioned, will be out next year, but all the proofs aren't out yet, but all the revisions are ongoing, if not finalized already. But the pancreas and the menin section, whether it be endocrine pancreas or just the luminal GI section itself, they'll all say 30% is the cutoff. Now, the challenge is, when do you use the menin for certain things? Because we were starting to see in the literature, or rather in pathology reports, menin being used very often. Like, for example, a good example is the mixed acinar neuroendocrine carcinomas, where if you have synaptophysin and an acinar cell carcinoma, are you automatically going to call it a menin? And so the WHO has now been going to be explicit, saying that you can have synaptophysin expression. You can have even INSM1 expression in an acinar cell carcinoma, and it is not a menin. It is still an acinar cell carcinoma. And the idea here is to remove a lot of those, honestly, those overdiagnoses of menin, which is then causing some challenges for our oncologists, because they're then having an understanding of like, what should they give a chemo regimen wise. That being said, though, menin will contain really the same information that you already see in the WHO. Not much else has changed. One thing that we do realize, at least from the menins, is that most of them are truly carcinomas and not truly tumors. And so, I mean, to be honest, they're typically a mixed epithelial or exocrine type neoplasm overall.
I think what they'll add is more of the amphicrine type, where the same cells expressing glandular and neuroendocrine differentiation, which was an omission, I think, in the earlier editions, which is a welcome step. But the 30% is indeed arbitrary. But do you, in the upper GI, if you have where most of the stuff happens on biopsies, and the neoadjuvant considerations are determined primarily on the biopsy diagnosis, I don't feel comfortable using the 30% rule, because it's a little sample of the whole thing. And if I'm seeing 2 lines of differentiation, I think I have an obligation to report both, regardless of the proportions. So I do say in that scenario what I'm seeing, and raise that this could be a mixed tumor. Also, because post-neoadjuvant, it could be one or the other component that's left, and then you end up in this scenario where there is a different tumor, same tumor, and a lot of workup can be saved if you just acknowledge upfront what you're seeing on the biopsy. Your thoughts, Arthur, and then Phoenix?
Yeah, that's actually really important. I agree with the biopsy interpretation. I never use the category of menin as a primary diagnosis. Certainly it's in the differential, but definitely do not use menin in the final diagnosis after neoadjuvant therapy on a surgical resection specimen. That's a really unfortunate pitfall, because many times, as you had mentioned, is that you can lose a component of that, or it can actually transdifferentiate based on radiation or the adjuvant therapy or the neoadjuvant therapy that's given. It can actually adopt neuroendocrine features. It doesn't mean it was a menin all along. It honestly could just be post-therapy changes that are occurring in the neoplasm. Phoenix, I don't know what your thoughts are.
Yes, I completely agree. I never use it in a top line, usually in the comment.
Yeah, I mean, we didn't get to, in the talk on colon cancer staging, the phenomenon Dr. Singhi is mentioning, that you can sometimes see really extensive neuroendocrine type. It looks a little different, more eosinophilic, and I think Phoenix has had examples that we've seen together. And there's been a nice study from Memorial from Karuna Ganesh, one of the oncologists and basic scientists, showing the plasticity of colon cancer cells in the liver, and they're adopting neuroendocrine features. So you can really mistake them for mixed tumors, but it's basically just therapy-related change. And we don't even bother mentioning them, because it's going to just confuse the surgeons. So we just keep a list to ourselves to write something at some point. But an important phenomena to recognize and remember. So if there are no other questions from the audience, I want to thank both of you once again for I know it's early morning and Arthur was up late last evening trying to wrap up and record his talk, and Phoenix was in the ER with her little kids. So thank you so much for joining us, and it was a wonderful session, both the talk and the current session. And see you guys back in the US. Thanks again.
Thank you for having us.
Thank you again.
Hello. I am Dr. Manoj Jain. Hello. Dr. Bell and Dr. Atur. Sir, we are extremely grateful, both of you, for sparing time, giving us. And I wish next time you will be physically, we will be seeing you here and interacting with you all. And I thank Dr. Amitabh also for coordinating all this activity. It's just like live you are here. We are feeling that you are here conducting our sessions. Okay. Thanks a lot, Dr. Phoenix
Thank
Bell.
you again for the invitation.
This time you could not make, probably some otherwise I could have seen you here, Dr. Atur.
Lucknow, Arthur knows a little bit, I think, about Lucknow because he's the one who came up with the IPL title. I copied his lead and I made something about on the same theme. So Phoenix doesn't know what we're talking about, Arthur, so you'll have to tell her.
I was hoping to have some time during my presentation to talk more about that and try to interlace that, but unfortunately I ran out. But next time.
Yeah, next time. So hopefully in person next time here. It's a fantastic city, a lot of history and culture here. So we'll organize something with you guys in person. Thanks again.
Thank you.
Sounds good. Thank you.
Thank you, sir, ma'am, for such an interactive session. We draw the curtains on this day one of CME. Today has been nothing short of a masterclass in gastropathology, from exploring endoscopic ultrasound guided biopsy techniques, different spectrum of cases, staging, case discussions, and interactive sessions. I extend my deepest thanks to each one of you for your presence, your questions, and your commitment to continual learning. To our phenomenal speakers, your insights were just not presentations, but powerful learning experiences. To our chairpersons and moderators, your thoughtful navigation of discussion brought out the best in every session. A special thanks to our international speakers who joined us across the time zones on our national faculty for their dynamic insights and our coordinators for this meticulous program. Finally, to every delegate